think that currently the pandemic is at its worst with the emergence of Delta strains. Before I begin, I would like to invite everyone to take a moment of silence to pay our respect to all our friends and colleagues and families that were lost during this pandemic. As the world strives to recover, it seems that online education will remain in the distant future to its effectiveness. Considering the current situation, it is impossible to have an in-person meeting as planned in Bali this year. So the meeting has been postponed to August 23rd to 27th of next year. In its place, we have to organize this combined virtual meeting to gather all orthoplastic surgeons and residents from Asia Pacific and Middle East in one event. It's been a long dream of Yan Wang and I gathered all orthoplastic surgeons from Asia Pacific and Middle East together. Because if we stand united, our combined total numbers of orthoplastic surgeries will be one of the largest numbers in the world. One of the most interesting about Asia Pacific and Middle East is that each region presents different and specific cases. We have all the latest sophisticated technology like in United States and Europe, but our cases are much more challenging. I hope that soon Asia Pacific will be the new hub for orthoplastic training. I'm extremely honored and humbled to have the privilege to open this meeting and welcome you all. As the concurrent presidents of the APAS Asia and APKS and on behalf of the organizing committee, I would like to express our sincere gratitude to all the invited faculty for taking the time out of their busy schedules to join us here. I would like to thank also our amazing scientific committee, namely Rami Soriel, Yan Wang, Chao Li, Yixin Chao, Guo Qiangxiang, Sahid Noor, Amin Chenoy, Park Sanchetti, Kuku Hedugarahanto, and Ricky Hutapia. With their hard work, we have assembled some of the most prominent names from all over the world in the field of hip and knee surgery to share their expertise during the next 3 Saturdays. Through strong international collaboration, we have been able to design a highly engaging program which includes the plenary sessions, live surgery, debates, panel discussions, and symposia, as well as a free paper presentation. To all the participants, I would like to encourage you to attend all 3 days to get the most out of the meeting. There will be 2 auditoriums, one for the knee topics and the other for the hip. I would also like to acknowledge and thank our industry partners, especially our platinum sponsor, Stryker, Zimmer Biomet, Diffusynthesis, and Smith & Nephew, and our titanium sponsor, Corin, for their generous support toward this conference, which enable us to foster the international academic exchange and educations in our field. Through this virtual meeting, these companies will educating us with their own industry session in program, demonstrating the recent technological advances in their products and service and that they have developed to aid us in providing the optimal care for our patients. I encourage you all to visit and engage with them in this exhibition foyer at our virtual platform. We have other exciting plans going forward, including the Travel Fellowship and a Young Surgeons Forum meeting toward the end of the year. Finally, my deepest gratitude to Alison and Michelle, Sophie and Bridget, Peggy and Jessica, the AV team, Wolflight, and Re-Entertainment who had worked wonders behind the screens. Without all your support, this meeting would not have happened. Thank you very much for your attention and enjoy the meeting. All right, ladies and gentlemen, let's start the meeting with the first presidential guest lectures. I have the privilege to moderate together with Professor Wang Yan. He's the founding father of Asia and the past presidents of the APAS. And also we have Professor Charlie and Professor Parag Sanchetti. It is an honor for me to introduce my good friend, Professor Seth Leopold, who is the editor-in-chief of Clinical Orthopaedics and Related Research. Seth, you know that CORE is a high-impact journal with over 3 million article downloads and about 30,000 citations last year. He is also a professor in the Department of Orthopedics and Sport Medicine at the University of Washington School of Medicine in Seattle. The title of his presentation today is How to Get More Out of What You Read in Orthopedic Journal. So welcome, Seth. Please.
Well, good morning, good afternoon, wherever you are in the world. And I'd like to thank the societies as well as President Professor Buddhaparama for this very kind invitation. I'd like to speak with you this morning a little bit on the subject of critical appraisal, or getting more out of what you read in orthopedic journals, how to become a critical reader. By way of disclosure, I'm the editor-in-chief of Clinical Orthopaedics and Related Research, and for my work there, my institution receives salary support. So let's imagine next week, you come back from this weekend, you were on call, there's an active 55-year-old woman attached to this x-ray, and the question is, how are you going to help her out? Lots of choices, as those of you in the room no doubt know: hemiarthroplasty, bipolar, hip replacement, maybe fixing the fracture. And the question is, how are you going to decide? You can toss a coin, ask the implant rep, ask one of your partners. If you're one of the younger people in the room, might you do what you did in your residency, which may or may not work for a couple of years, but after passage of time, the things that you learn may become out of date. You could do what you learned at a course or a conference like this one, but how will you know that it's the right thing to do? Hopefully, you'll go do a search, a PubMed search or something similar. But the question is, how will you know what you find is good? How will you know it's worth your attention? And you're so busy. How are you going to read through all of the things that you find on a search like that? Nobody's born doing this. This is an acquired skill that can be taught and learned. And so let's talk this morning a little bit about how to do it. It's important to do because critical reading should inform our decisions. If our skills at it are soft, then less reliable information sources may drive our practices. So if I'm going to talk to you about evidence-based medicine, what's the alternative? Well, some people call it eminence-based medicine, listening to people who ought to know. They often have gray beards. This is C. Everett Koop, former Surgeon General of the United States, and he was once quoted as saying, "It is true that there are people in my situation who could not receive $1 million grant and remain objective, but I do." Maybe he does, but it's awfully difficult to take somebody at his word saying things like that. And so it'd be nice to be able to figure these things out for ourselves and not rely on people who ought to know. We ought to be able to know. Advertisements are another particularly bad source. We all say that they don't affect us, and every study that's looked at it says that they do. Sometimes advertisements don't look like advertisements. This is a web page from an academic website, a university. Makes the claim that PRP has been demonstrated to be non-inferior, that is similar to and even superior to hyaluronic acid for patients with knee arthritis in multiple studies. The problem is that neither of those things is very effective. The American Academy of Orthopedic Surgeons put out a clinical practice guideline on hyaluronic acid and biologics and found that they couldn't recommend either of them. And so the idea that there are academic websites, they look like neutral sources of information. They're putting out information like this. That doesn't help our patients and it doesn't help us. The problem is, since that clinical practice guideline in 2013, the market share of these products has only increased. It's now $2.6 billion. That's an enormous industry for something that doesn't work very well. Here's another claim from an academic website, orienting itself, as you can see, towards somebody who's at least in middle age. Makes the claims about arthroscopic knee surgery that it is minimally invasive. It can remove loose fragments and bone spurs and repair damaged cartilage that are causing pain. The problem is that there's no evidence that this is true and plenty of evidence that it isn't. Again, this is an academic website. We need to figure things out for ourselves. We can't depend on the claims of others in those contexts. Ads, not articles, do influence our practice. Whatever we think about it, every study that's evaluated has found this to be true. One found that studies of exposure to information provided by commercial sources have found associations with higher prescribing frequency, higher costs, and lower quality. No evidence of net improvements in prescribing. So we know that reading should drive our practices. We know what needs to happen. We know that how well we read affects our patients' lives and their health. And so how are we going to do that? So this morning, this afternoon, I'd like to speak with you about the topics of validity and bias, the most common kinds of bias in clinical research, the importance of no different studies and how to evaluate them, and the questions you can ask of the most common study designs. So I'm going to focus first on two types of validity: internal validity, which some people call methodologic rigor. In this situation where you're looking at this, the methods are sound, the interpretations and conclusions are supported by the data in the study. There are different criteria for assessing internal validity for the different kinds of studies we're going to read, and we'll talk about the common ones. External validity is also called generalizability. Here, the question is, can the results of a well-designed, internally valid study be applied to your practice? Here, you're dealing with questions like the patient population, the study site, the provider experience, the equipment, or the approaches and the technology. Consistent criteria for external validity exists across all different study designs. The problem is, as external validity increases, internal validity usually decreases. What do I mean by that? As inclusion criteria become stricter, the study does become more homogeneous, but it tends not to represent all comers who you might see in the office. So am I saying that good studies can lack validity? Absolutely. They say some people are rats, but rats aren't people. So studies done in rats may not apply to humans. More realistically, in clinical research, let's imagine I'm trying to convince you to use a new implant that I've designed. True disclosure, I haven't designed anything. Let's imagine I'm making a claim that my new knee replacement has no risk of failure at 10 years, but I may have neglected to point out, and you may not know to look, that the patients have to be thin, lightly muscled, women over 75 with blue hair, and, of course, insurance. Not this kind of blue hair and not that kind of blue hair, but somebody like this. If I put my new knee replacement into somebody like this, in fact, if you put anybody into somebody this fit, they're likely to do okay. And this is what you have to sort of suss out as you're reading this kind of research. So let's talk about bias for a moment. The AMA defines it as a systematic situation or condition that causes a result to depart from the true value in a consistent direction. Bias refers to defects in a study design or how it's measured. Bias is not the same thing as preference. Preference is in the mind or the heart of a person. Bias, for the purposes of this conversation, is in the design of the study. There are four common types of bias you want to be aware of, and I'll talk a little bit about each. Selection bias, transfer bias, performance bias, and detection bias. Selection bias is sometimes called susceptibility bias, and it deals with the idea that a study might try to compare results between groups that are dissimilar at baseline, prognostically dissimilar. And so if groups are dissimilar before they got their treatment, they get a treatment, the results of that treatment may not be caused by the treatment. They may have been caused by the differences between the groups that were present even before the patients got treated. One way around this is good randomization. Stratified randomization is even better when resources permit, but there are other ways. Since only about 3 or 4% of orthopedic studies are randomized, we're going to have to find other ways to work out the problem of selection bias, and I'll show you how. Transfer bias deals with the question of whether the follow-up is sufficiently long and sufficiently complete to detect all the harms that you might care about. It's especially important when you're comparing two groups and there's a difference in completeness of follow-up between the two groups. Non-responders usually have worse health status. And so you can ask yourself, imagine all of the missing in both groups did poorly. Would that change what I think about the treatment? Performance bias deals with the possibility that there could be dissimilar skill levels between people doing the operations in a study. It could be that there are different approaches or techniques used. But importantly, it may not have anything to do with experience at all. It could deal with what they call co-treatments that are alongside the test intervention. So imagine I'm trying to convince you to use a less invasive something or other. But in addition to the different approach, the less invasive group got more nonsteroidals. They got more physical therapy. They got more follow-up. They got more hand-holding, more painkillers. So there are lots of ways that performance bias can influence your studies, and we'll talk a little bit about that in a moment too. Detection bias, sometimes called assessment or assessor bias. Here, you're wondering who's asking the questions and what's their interest, and maybe even more importantly, what questions did they ask? Are they standardized or inconsistent? Validated endpoints, blinding examiners, those are the best ways to get around this. So let's talk about three common study types that make up together well more than 90% of articles in orthopedic journals. Studies about treatments, prospective or retrospective, studies about new diagnostic tests, and then review articles like meta-analyses and systematic reviews. Now, obviously, there are many other kinds of orthopedic studies, but they're beyond what we're going to cover today. Those will be topics for some other day. We'll focus on the big three. If you want to pause and take a screenshot, go ahead and do so. This is a great resource for people who are curious and want to go deeper than I can go in 15 minutes. Gordon Guyatt and Drummond Rennie really invented this stuff back in the 80s and 90s. And in that book, which fits into the pocket of a white coat, it covers this topic in great depth. But I'm going to focus on three questions that you can ask of each kind of study that you might read. The material is also available at Clinical Orthopedics and Related Research in this editorial if you want to take a screenshot. And we've even programmed a tool on our website that you can use that walks you through the reading of an article. It's built for reviewers, but it's equally good for readers. And you can find this at Clinical Orthopedics website, www.clinorthop.org. I should add that I've also provided a handout that's downloadable, and Professor Buddhaparama can tell you how to get that resource on the website for the conference that goes through all this material. As you approach an article, you might begin by assessing its external validity. Could you apply it to your practice? Are the patients similar to your patients, or are they dissimilar? Do you have the tools and technology that the authors had and the experience, perhaps? I would say that if the answer to those questions is no, don't bother. Skip that article. If the external validity is good, if the patients look like yours, if you think you could do this operation, then ask yourself, well, let's see what they had to say about it. If their claims, exactly as they made the claims and the conclusion are true, would it change my thinking? Don't try to figure out at this point if it's true. You can't figure that out from reading an abstract. You got to read the whole paper. But first you want to see, can you even tell what they're studying? Did they ask clear questions? If their conclusion isn't that interesting to you, then there's no sense wasting your time. Skip it. But if the patients look like yours, you think you could do it, and the conclusions look like they would change your thinking, at this point, you want to skip the introduction and go right to the methods section. And you're going to look there for major deficiencies or fatal flaws. And if you find any, here she is again, you're going to skip it. At this point, once you're into methods, there's a few key questions you can ask for each study design. And what I'd like to do is, for each of those three study designs I mentioned earlier, ask you the three questions for each of those designs. So again, studies about treatments, studies about diagnostic tests, and review articles make up almost all of what you're going to read in orthopedic journals, so we're going to focus on those. So retrospective studies about therapies or treatments. Ask yourself who is included. That's the question of selection bias. Can you tell how they decided whom to include? Can you tell who received the operation in question, or the operation and the comparator or control? What proportion of their practice were enrolled? Which ones? Then ask yourself, was the follow-up sufficiently long and complete? This is the question of transfer bias. Imagine they make a claim that they were completely successful, but half the patients were lost. You can't count on that claim being true. The missing are not doing as well as the accounted for. Were the outcomes measured appropriately? The question of assessment bias. Did they use validated tools? Were they assessed by somebody other than the surgeon? Sometimes they'll say that we've got some limitations. The study was level 4, and I would say don't worry about that. Sometimes level 4 is just right, particularly if the intervention failed. There's no need to go on and do another study like a randomized trial. But typically, level 4 studies that make big claims, you've got to realize that the kinds of bias we're talking about, selection bias, transfer bias, and assessment bias, all tend to inflate the apparent benefits of treatment. These biases are additive. They don't offset one another. They all push the results in the same direction in favor of the new treatment. That's why as study quality gets better, we see smaller effect sizes. This happens again and again. How about prospective treatment studies? These are the same, you ask the same questions as we asked a moment ago about selection bias, transfer bias, and assessment bias, but in addition, you can ask were the groups similar at the outset. Here, randomization helps. Other than the experimental intervention, were the groups treated equally? Here, blinding helps. And if they randomized the patients, did they use the intention to treat principle when analyzing? We can talk about that during the questions if you'd like. Moving on to the second kind of study, diagnostic tests. Was the new test evaluated against a gold standard? This is important because you need to know how they figured out whether the new test is worth anything. And then importantly, did the results of the new test influence the decision to apply that gold standard? If they only applied the gold standard, let's say, to patients who tested positive on the new test, you're going to inflate the apparent effectiveness of the new test. Did they enroll a suitable population of patients that covers the full spectrum of disease that you might be interested in? This is sort of an external validity question, but one worth asking nonetheless. Finally, review articles. Did they describe their search adequately? Do you know how they found the information they found? Which databases did they look at? Are they likely to have missed something important? Did they tell you how they decided what to include or exclude? Did the authors deal with the fact that not all studies are similarly well designed and similarly convincing? It's not appropriate to lump in level 4 studies with randomized trials and treat them as though they're the same. As we've already found out before, they're just not. Did they grade the studies so that you can see whether the evidence base that they're using is of a high quality or low quality, and how much do you have to discount the results because of that? Do they deal with the questions of publication bias and, in particular, heterogeneity? Is it even appropriately to mathematically combine to meta-analyze the results? Let's talk about heterogeneity for a minute. So the idea of heterogeneity, imagine there's a meta-analysis that's evaluating some treatment in which half the patients were killed by the treatment, half the patients were cured. If you average those, you might conclude that there's actually no effective treatment, but that's badly misleading. You need to drill deep and figure out why some patients were harmed so severely and some were helped so much. That's analogous, if you like, to averaging night and day. You just get a quantity or a quality that's not even sensible to talk about. You've got to just drill deeper. If there's a lot of heterogeneity, you shouldn't pool them together. At this point, if the study passes your test, you can read the results next, and you can decide what you conclude. Is there anything new here? Is there anything you could put into your practice? Are there any caveats or limitations that you would apply based on the shortcomings that you identified? You don't have to count on the authors. We can take a short detour into no different studies. I think they're important to publish. Positive outcome bias makes meta-analyses misleading. If the literature consists only of studies that found treatments to be helpful and suppress the publication of no different studies, then meta-analyses are going to make things look better than they are. It's going to overestimate treatment effects. This is going to influence how we use resources, and this is a real problem across science. No different studies may not be fun reading in the sense that they're not always so dramatic, but I find them important because they tip you off that the early positive findings that we thought were true may not be true. And so this is where you find the early cautionary messages that suggest that something that you thought was good may not be as good as you thought. It's important to know that sometimes studies don't find a difference because they're too small, and the authors need to tell you how likely that was. If the power of a study to detect differences was low, authors need to be realistic about their conclusions. A no difference finding in an immodest discussion can be a misleading paper. You need to know that the absence of proof doesn't mean something doesn't work. It may just mean that they needed a better study to detect what they were looking for. At this point, you could read the introduction and the discussion of the paper. It's more fun. You've already decided what you think. You don't have to take the author's word for it. If the article seemed valid to you, the introduction and the discussion may give you some context, may point you to some limitations you missed, and may give you some references you want to go look up to learn more. You can be critical. You've got the criteria to do this. You can decide for yourself each article's value. You don't have to be intimidated by the author's interpretation of their own importance, which are almost always overstated. Know, though, that it's easier to critique a study than to praise one, and you don't want to become cynical in the course of doing this activity because every study has flaws. And your task as a reader is to say, given the limitations, is there still something I can learn here? Bits and pieces are okay. Can I use any of this article in my practice, even a part of it? And so I understand we're not going to be taking questions straight away, but there's going to be another talk from Professor Parvizi, and then after that, both of us will take your questions, and I'll look forward to that. Thank you again for this kind invitation.
Thank you very much, Seth, for the excellent presentations. But I think maybe we can start first now to the Q&A while waiting for Jay. I'm going to. I will have some questions for you, Seth. And if you look at most of the publications on new technology, CAS or robotic, are underpowered in my opinion, because the sample size is too small to be detected using the traditional RCT methodologies. And if you look at the follow-up time, mostly are only from 2 years. So I think, for example, to reduce an outliers of the alignments from 20% to 10% and an alpha threshold of 0.05, one might require more than 400 samples, for example. or an outcome to change, reducing the aseptic loosening from 8 to 4%. One needs, I don't know, maybe a couple of thousand sample, but I've never seen on a publication. So I would like to share, what is your thought? Maybe you can share with us, Seth.
That's a great question and a really important one. And as a medical editor, it's a question that's dear to my heart because, as you can imagine, every year we see a couple of thousand papers coming in, all with new ideas. And the question is, how do we know when an idea is good enough to recommend it? And here in particular, you're dealing with technology that can be expensive, that has a learning curve associated with it. And during the learning curve, people can get hurt. Patients can get hurt as we get better at using these tools. And so we want to make sure that if we're going to use one of these tools, that we're really confident that it's making a difference. So I would say there's a few parts of your question that are worth unpacking. The first is, what is the endpoint that we're looking at, and is it the right endpoint? So is looking at the reduction of outliers the right thing, or do we want to really, before we invest in an expensive technology that has a learning curve where people can get hurt, do we want to make sure that we're looking at an endpoint that really makes a difference, like the reduction in revision risk? And I don't think it's enough to have a hypothetical benefit, like the reduction of the number of outliers. And I don't think it's okay to say that we're underpowered, and so maybe there's a benefit, but we just didn't detect it. It seems to me that before we can recommend something new that has new costs and a learning curve, it has the obligation to demonstrate its value to us. And if it can't do that because the value is so small that you need thousands or tens of thousands of patients to tell a difference, then maybe the effect size just isn't that big. Maybe this technology isn't going to do what we hope it's going to do. And so I think we need to wait on the deployment of that technology until it proves itself to us. I don't think we should always assume the best about every technology, because the history of our specialty has shown that a lot of well-intentioned ideas have wound up hurting people. I think this is different if you're dealing with an operation that's generally well-behaved, like knee replacement or hip replacement, that most of the time patients do pretty well with it, than it would be, let's say, if you're talking about some kind of an unsolved problem. So imagine somebody came up with a new approach for pelvic discontinuities or extensor mechanism disruptions. There we don't have good solutions. And so, we can be a little bit more experimental or a little bit more open-minded about how we deal with those problems. But when you're dealing with a generally well-behaved operation, like let's say a first-time knee replacement or a first-time hip replacement, it seems to me we shouldn't embrace these new technologies based on the idea that hypothetically they should be helping people because there are fewer outliers. That's just too much of a risk. Those technologies need to prove themselves to us in a more definitive way before we should embrace them.
Thank you, Seth. Maybe Parag, you would like to have some questions? Yes, please.
Yes, excellent talk. Really learned a lot of new things, Professor Leopold. My question is slightly different. We always talk about doing multicentric trials, and they say it's one of the best ways to really prove a point, versus to doing well-done RCT. So what do you think, which generates a better evidence, or which we should follow, a multicentric trial which gives it out, or a randomized control trial done by one center? And which has better evidence, because there's always a lot of confusion. And to add to that, we also have this systematic reviews. So there's always a conflict in my mind, which is better than the other. So can you just throw some light on this question? It's a little different, but I thought I should ask you.
I love it. I'll do my best. So I think I understood the question. The first part of the question was, imagine you could have a trial from one center of 1,000 patients, or a trial from 4 centers, each of whom contributed 250 patients. Which would we rather read?
Correct.
Right. Well, it depends a little bit what you're trying to get out of it and who's reading it. So, on the one hand, it might be nice if I did that technique exactly the same way as the large center that did 1,000, then that trial might be really exciting for me. If I do it exactly as they did, having 1,000 patients would be more interesting than having sort of slight variations on that theme at each of 4 places. But the real world being what it is, where each of us does things a little bit differently, there's something very appealing about what I called in my talk external validity or generalizability. So if that technique works in one place, you have some confidence in it. If the technique works in 4 places, you have a sense that it's a more forgiving technique, perhaps, and that it may be generalizable to more centers. So I think that's sort of the first order answer to your question. But then at the end of your question, you threw in a couple of other things that I think are even more fun, which is what are the other kinds of study designs that can inform us? And you mentioned the systematic reviews, or let's call it a meta-analysis if they're going to pool the data. So imagine we're still talking about randomized trials where you can mathematically pool the data. That adds yet another level of generalizability. Sometimes when you ask people what they think the gold standard study design is for a study about surgical treatments, people will say the randomized trial. But I would assert that the gold standard study design is probably the meta-analysis of randomized trials, just because it gives you a measure of generalizability that you don't get from a one center or even a several center trial of a technique. If you can find other things that are worth pooling together and similar enough to justify pooling, I think that gives you the added confidence that this is maybe a more forgiving technique, or a technique that you don't have to be a professor who's done 10,000 of them for it to work. There's one more kind of study that you didn't mention in your question that I think is worth adding in, because as we're getting a little bit sort of savvier about this, a little more experienced with clinical research, we see that a lot of different study designs can complement one another. Right. And so the other kind that I find really enjoyable to read and to sort of hold alongside the randomized trial is the National Registry study. So when you look at, if we're talking about, let's say, arthroplasty, on the one hand, you've got studies, randomized trials, and a really big randomized trial in orthopedics might be 400 patients. But now you can put that alongside a meta-analysis that might have, 10 studies. So now you're at 4,000 patients. Well, now imagine you had a study that had 40,000 patients, 10 times as much as that. That might be the Swedish Arthroplasty Register, or the Norwegian Arthroplasty Register, or the Australian Arthroplasty Register. And those are fun because they're unlike randomized trials. They're not quite so tight, right? They don't have that same internal validity where everything is controlled for, but they have this wonderful quality of every man, or every man and every woman, because they're evaluating the treatments just as they're being used in the community. So again, you don't have to be a high volume professor of something or other to consider that work applies to you. I figure I'm an average surgeon, right? None of us really knows if we're above average or below average. So let's all assume we're all average. It's nice to look at registry studies and see what the average result looks like in that setting. And it's even more fun when you can compare and contrast randomized trials that may have one result. Maybe it's a little different in the registry. Maybe the results of that randomized trial don't play out in practice, or don't play out quite that way. So to me, all of these things complement one another. The nice, tight randomized trial, whether single center or multi-center, the somewhat more generalizable meta-analysis of a bunch of randomized trials, and then the sort of man on the street, or every man and every woman, experience of a country in a registry context. So I think if we look at those things together, it kind of gives us a well-rounded picture of how something is behaving.
Perfect. Yeah. Thank you. That shows.
I would like to remind the audience as well, Parag, to send their questions to the Slido. So I haven't seen any questions here. And maybe I would like to ask set another questions. Is nowadays all new technology becoming hype. Like robotic. That's a hope. And then I read an article in last year by Michael De France, which shows that 91 published on robotic declared that the financial conflict of interest, of course, reported for a positive result of the robotic. Now, because it is a difference and publication bias and investigator or study aside preference. And how precise was the estimate to the treatment effect? Because otherwise, if you read only about this, then you saw it's like a norm nowadays. Everybody has to use that stuff. So what is your thought on it?
Well, these are great questions because each of them can be taken in so many different and fun directions. But so let's talk a little bit about the idea of industry-related conflicts of interest and other kinds of conflicts. And then we can talk about precision of estimate of effect size. I think that in our specialty, I'm an arthroplasty surgeon too, as you might know, and so I'm comfortable with this conversation because this conversation has been going on for as long as I've been a surgeon. I think, we shouldn't assume the worst. I think that a lot of innovations are going to begin the life cycle as industry funded in our specialty. I think that that's just the way it is. And the fact that something comes to us from an industry study, we shouldn't assume that it's not true. We shouldn't assume that the person is trying to advantage himself or herself or advantage his or her company. But I do believe that the fact that so much of the innovation in our specialty is industry funded should force us to ask for more before we put these tools to use in common practice, in general practice. I think that if an initial study comes to us from an inventor or an innovator or a consultant to industry, I think it's probably reasonable to ask, has this been replicated by somebody whose relationship to industry is maybe not quite so tight? And maybe we shouldn't rush right in and change our practice over the first study or two that may have been delivered to us through an industry partnership until some other people have replicated the work. If it's a really promising technology, there should be a lot of excitement about it, and there should be some independent trials following, hopefully not too far behind. I think the question of publication bias that you mentioned is maybe a little bit different. To me, publication bias doesn't mean that the person was funded by industry. It doesn't mean that he or she is enthusiastic about something. To me, publication bias is not something that I can tell as a reader from reading one study. To ascertain publication bias, another word for publication bias, positive outcome bias. And this is the concept that journals may be more likely to publish studies that have favorable conclusions or show differences rather than studies that have no difference or negative conclusions. And it's the same phenomenon that maybe reviewers are more prone to recommend for publication exciting findings, studies that show difference, as opposed to no difference studies, which they may perceive to be a little boring or unspectacular. You can't, as a reader, even as a really good reader, you can't tell from reading one study whether there is publication bias present. In order to tell whether there's publication bias present, you have to look at a whole literature on a particular question. And there are mathematical ways to work it out. These are things called funnel plots. And I'm not a statistician. I'm not a mathematician. I can't even do a good imitation of a mathematician or a statistician. But when you look at this mathematically, when you can plot out the results of a bunch of studies on a subject, and if what you see is that plot, imagine a scatter plot, is missing the dots that you'd expect to see where you would look for small, no difference studies, then you can assume that journals are saying, well, these small, no difference studies, maybe they were underpowered. They don't justify our attention. We're not going to publish them. Perhaps somebody else will. The problem with that, the problem with publication bias, is that if guys like me, journal editors, favor studies that show difference and we suppress studies that show no difference, this can hurt patients, because then when meta-analyses happen, the meta-analyses can only pool what's been published. And if what's published has sort of systematically tilted towards the positive, then meta-analyses are going to overestimate the apparent benefits of treatment. And that's misleading. That can harm patients. It also wastes resource, because imagine, you're a sensible investigator. You see a bunch of studies that all seem to show the same thing, that something works, but you can't make it work in your practice. And so you think maybe we need a trial on that, but it turns out maybe there are already 5 trials showing no difference, but they couldn't get published. So it's important that journals, that editors like me, be especially open-minded to negative and no difference studies, even if they're smaller. And this is something that I've written a lot about. It's something that I think journals don't do as good a job with as they need to. But publication bias has unquestionably harmed our patients and misled us as surgeons. So it's up to people in positions like my position to do better? It's a good question, Nick.
Yeah, thank you. Parag, maybe.
Yes. So one question which always comes to my mind, and this is more for the newer generation, the young doctors who are just finished their residency program and got in practice. And, when they talk about research and when they are asked to do research and get into that thing, especially in countries like India and Indonesia, there's always a reluctance for research. And one of the common excuses given is that, oh, there's so much of literature already there. What new is to be taken? How do we really get into this? So I just wanted some tips from you, Professor Leopold, for beginners, to entice them or to stimulate them to get into this research, because they say, oh, there's at a click of a button, you get 1,000 articles. I don't want to add 1,001. So, those kind of answers are always seen. So how do you motivate them?
That's a great question. So the first part of it, I think, just as I said a moment ago, I have a responsibility as a journal editor to deal with the problem that Professor Buddhaparama just brought up. I think all of us who are part of this talk, you and Professor Buddhaparama and me and Professor Cowley, and all of us who have been fortunate to enjoy good mentorship, and I think you'd probably agree that each of us can look back on our careers and point to people who have mentored us and guided us and helped us and encouraged us. I think we have some obligation to pay that back. And obviously we can't pay it back to our mentors, so we have to pay it back to the next generation. So we have to look around us and find the people who we think would be really good at this and tell them, I think you would be really good at this. And I think too often, as people who are in our positions, we wait for them to approach us. And I think they're often intimidated to approach us. They may fear approaching us or wonder if we would embarrass them or maybe not support them. And so I've been pleasantly surprised when I see somebody who I think has some of the qualities that I would like to see in the next generation of academic orthopedic surgeons. And I tell them that unsolicited. The smile that it creates is very spontaneous and very authentic. And it's been fun to watch some of those people who previously said they had no interest in academics, just because somebody like you or Professor Buddhaparama goes up to them and says, I think you'd be really good at this. They may reconsider their career choice. Simply saying something kind like that unsolicited makes a difference. But as far as what you said specifically, the question you specifically asked me is how can we, if they approach us, what do we say? Or if they, even worse, they approach us and they say, I'm not interested in that because I don't think there's anything more to be learned there, or I don't think I could contribute. One of my mentors suggested to me when I first arrived at the University of Washington, I said, I'd like to set up a registry at the University of Washington in Seattle for knee replacements and hip replacements to see how they're going to do. And this mentor is very smart. He said to me, Seth, you could do that. You could do that. But the year is now approximately the year 1998 or 2000. I forget when exactly it was. He said, the Mayo Clinic has got a 30-year head start on you. And Harvard has got a 30-year head start on you. And God knows the Swedish Arthroplasty Register has got a 30-year head start on you. Do you really want to put all of that effort into answering questions that these other places are going to answer probably more effectively than you can? And even if you could answer some questions that they forgot to ask, it would still take you 10 years before you could start to do that. He gave me the best advice I got starting out, which was find some corridors of relative indifference. That was his expression, and I'll never forget it. Some pathways or roads of relative indifference. Find some things that may even seem small, but around which you can frame some small answerable questions, projects that you could answer in 2 or 3 months rather than 2 or 3 years starting out. Specific sort of hypothesis generating questions, yes, no questions, small questions that aren't the things like, should we use posterior stabilized or cruciate retaining, or should we use cement or no cement? Leave that for the Mayo Clinic, leave that for Harvard, leave that for the Swedish registry. But Seth, why don't you ask some questions about, at that time, actually it was positive outcome bias was one of the first things I did. It didn't take me enrolling any patients. All it took was a pencil and paper and a stack of journals. And I could start answering questions about industry sponsorship and positive outcome bias. So look for the smaller questions, and you may find that there are a lot of small questions that can get you excited. And I know that worked for me starting out. And in fact, I never really left the small questions. I never really wrote anything about cruciate retaining knees or cement and cementless. For me, it's always been sort of the questions that other people have left aside that are the most fun.
Okay. Yeah, Nico, you want to ask a question? There's just an announcement that Professor Jay Parvezi could not join because of some issues, but we will take his talk on DVT prophylaxis a little later. The talk was an interesting talk, VTE, money, politics, or patient outcomes, but we will fit that in later. So, Professor Nico, we have time for 2 more questions, and then we go to the live surgery. Over to you.
Yeah, actually, I would like to encourage also the audience, because now we have the slide, especially during the live surgery. Because if you look at, we have 12 live surgery, and with all this, with all the latest technology. So I think I encourage everybody to use this Slido, and it's another question, maybe Parag, from you.
Yes. There's one question on this statistical analysis, which I always have an issue with. There is something which you can play around the statistical analysis and at times make it work in your favor. So what is your take? Which is the best way to do statistical analysis? Because most of the times we just outsource it. I will tell you very honestly. We get the data and we have a couple of people, a couple of agencies who do that for us. So do you have any guidelines on how one does the statistical analysis? Because I think that's important for you. Unless you see there is some significance in that study, you would not be happy to take it through the editorial board and approve it. So please enlighten all the delegates. We have more than 600 people who have joined us now, Professor Leopold, on the statistical analysis part.
Well, that's a great question also, and probably more than I can answer in 3.5 minutes, because every study is different. And just like orthopedic surgery is a living science that changes every year, and we have meetings like this, our biostatisticians have meetings like this every year, because their science is a living science too, and it continues to improve. But if I could say just one thing about statistics that I think readers should focus more on, and probably editors too, is worry less about the p-value and focus more on the question of effect size. So as a reader, if something's in a journal and it's coming to you and there's a p-value attached to it and there's a statistical analysis and you're not an expert on that, maybe leave that aside for a minute, because you're probably not going to become an expert by the end of that article. But focus your attention on how big the difference was. So if there is some new expensive technology, like we were talking about before, that might have cost associated with a risk or novelty that could hurt people, and it gave you 2 points out of 100 on the Harris hip score or the HSS knee score or something else like this, maybe that effect size isn't big enough to care about. Maybe let's focus our eye more on something that the methodologists call the minimum clinically important difference. But you don't even need big words like that. Just look at the differences between the group, not the p-value, but the actual number of points or the range of motion differences or the time of healing, whatever the parameter is it big enough to care about, and focus a little more on effect size. And I think if we spent a little more of our energy focusing on effect size and maybe a lot less on non-experts like me trying to sort out what the analysis should be doing, we'd probably be further along. It's essential that guys like me get that analytic part right, and we've got a good team to do that. But I'm never going to become an expert at that. What I can do is try to ascertain whether the effect size is big enough to care about, or big enough to pay for, or big enough to expose my patients to risk over. And I think that's something that's often missed.
Great.
All right.
So we have one quick question from Nico, and then I have a short question.
No, you first. You first.
So the last question for this session is, how many articles in the last 1.5 years did you receive on COVID-related research in orthopedics? And, how did you tackle them, and how did you select them? Because doing research in 2 months, 3 months, 6 months. I believe I have been reading, and then some of them just got published like this. So
Right.
How many articles did you receive, and how did you view them? What was your, perception of these, and how did you decide to publish them?
Right. We created a fast track for COVID-related research, hoping that we would see some exciting and transformative work. And we saw a little bit of it. We saw a lot of submissions, but I wouldn't say we saw a lot of transformative research. And as I look more broadly across all of medicine, there were an extraordinary number of COVID-related submissions to all journals, and ours was no different. We got hundreds and hundreds of COVID-related submissions. We published probably a handful of them because many of them were, as you can imagine, something you can throw together that quickly is often not very spectacular. And COVID is not really an orthopedic illness, right? It's a pulmonary illness. There's not a whole ton of things orthopedic surgeons can say about it. I would say the most common article we got, and we got dozens and dozens of copies of this article from all over the world, was an article that asked some version of this question. If you close down your operating room because of COVID, what happens to your surgical volume? And the answer is it goes down. And, it's a little bit silly, right? And, when I was talking to an editor at JAMA, he said they had something just like that in internal medicine, which was if you take a patient with COVID and you give them a blood transfusion, what happens to his hematocrit? And the answer is it goes up, because you give anybody a blood transfusion, their hematocrit. So the fact that these things happen in COVID are not terribly enlightening. We saw a few good COVID articles. And as I read the other good journals like JBJS, they saw a few good COVID articles, but it really wasn't an orthopedic illness. Most of the orthopedic articles were about systems. How can you get the OR working again after COVID? And there's sort of going to be a transient interest in that, but life is going to go on.
Perfect. Thank you. Thank you so much, Professor Leopold. We really learned a lot from your talk. That brings us to the end of the opening ceremony and the plenary session. It was really awesome. Our apologies that Jay Parvezi could not join, but we will tune in later for that talk. With this, I want to thank all the event managers, the Alison in particular, also Peggy and the entire team back office who have been a wonderful job. And last but not the least, Professor Rami Sorial from Sydney, Australia, for putting all this together. He has put up a wonderful scientific program and has been stimulating all of us. Thank you. And we go forward to the next session, which is a combined session for knee and hip in different auditoriums. Morning. Good morning.
Hi.
Okay, welcome to the knee auditorium. We'll be doing a knee replacement here live. I welcome everybody to the meeting and APAS 2021 and concur with our President Nico's initial introduction and his thoughts. Great session from Seth about critical reading. We're going to do a knee replacement here using the ROSA robot. I'm going to start and just talk as we go through, but at the same time, I want to introduce our moderator panel, which consists of Sebastian Parag, and Nico, who you've already met live. So the aim is really to get this done in the space of time that we've been allocated. I'd like to really thank all the live surgery teams that have accommodated our requests to run this for the meeting. This is a big effort really on everyone's part to get this done in a virtual space and deliver it to you. So I'm truly grateful to all the surgeons who have accommodated our requests, but also special gratitude to the surgical teams. And they're certainly very broad, from our assistants to the nursing staff, to the scrub staff, to the anaesthetic staff. And then a special thanks also to all our AV crew and the camera people who are making this possible and allowing us to deliver this into your lounge rooms and hospitals and auditoriums. So to our moderator panel, they're going to be involved in this process, hopefully helping me get this operation done, and also to answer your questions as we go through. What I want to say is, what we're doing here really is a TKA using a technique that I use now routinely at this private hospital, using the ROSA. The good thing about this conference is that you're going to see a lot of technology and really a showcase of the different high levels of technology available. But it's not to say that one is better than the other. It just happens to be the technology that we are using, that I am using, that Simon's using, that Dermot's using, etc. Or that the standard approaches that the other surgeons are using. Everybody can achieve a good outcome for their patients, but if you, by joining us in this live surgery venture, just pick up one tip or one special technique that delivers a better outcome for your patient, then maybe we've done a job for you. Please feel free to ask questions. The moderator panel will hopefully answer most of those without me having to do too much while we get on with this. What I might do, I'm doing a standard medial parapatellar approach. And before that, I'd like to thank Dr. Bhagesh Patel, my assistant, Dr. Amit Babaid from Mumbai, who's our fellow, my anaesthetist Terry Tay, and my scrub Eloisa. And what I might do is revert to Sebastian and the moderator panel just to introduce this patient and the plan for that, the preoperative plan. Seb, do you want to take that?
Yes, Rami, thank you very much for this. Excellent, Rami. Thank you so much for this introduction. And I'm going to present the case for you today that Dr. Rami is going to do for us. I want to make sure that you can see my slides and the plan for this patient. You can see my slide. Excellent. The plan for this patient is to perform, as mentioned by Rami, a robotic total knee arthroplasty using the ROSA knee system with a cementless Persona total knee arthroplasty. So the idea is to first introduce briefly what is ROSA. ROSA is a robotic knee system developed with a specific robotic arm holding the jig that is allowing you to cut precisely. In fact, we published the result of the accuracy of ROSA in the Journal of Arthroplasty, showing an excellent accuracy not only for the bone cut, but also for the ligament. There's a unique 2D to 3D standing planning tool where you don't need any CT scan and you can do X-rays, full-length X-rays, AP and lateral. And thanks to a specific algorithm, the engineers are able to prepare a 3D planning of the case that, of course, you can adjust according to your decision. You can work imageless as well. You can fit any surgical workflow. And as Rami was mentioning before, we all in the world have different approaches and different techniques to treat the same problem in the knee, meaning that there's not one above the other. And as long as you're consistent with your technique, it's probably the best for your patient. ROSA has been defined as efficient, time neutral, and we observe early, better functional results for our patient that, of course, should be confirmed in the future. The case that Rami is going to do today is a 76 years old male, a right knee osteoarthritis. This patient underwent tricompartmental knee arthroplasty for the left knee with some partial limitation. He has some medical history, and there's one that I would like to mention is the fact that he's under Xarelto. And you know that this patient can bleed a little bit more under Xarelto. So today the plan is to go for a right knee tricompartmental knee arthroplasty. The patient had some limitation of range of motion preoperatively with some flexion contracture and a limited range of knee flexion. So hopefully that's gonna the surgery will be able to treat completely this case. You can see the AP and lateral views of the knee, and we can imagine why he has the flexion contracture with this very significant osteophyte at the anterior aspect of the knee, and also the limitation of range of knee flexion with the impingement of the osteophyte at the posterior aspect of the knee. You can see that it's a relatively straight knee, even though there's more medial osteoarthritis. And here you can see the X-rays that we are performing for the ROSA surgery. You can see that there's two trackers that are on the lateral aspect of the thigh and the lateral aspect of the calf. And thanks to these beams, the engineer are able to match AP and lateral view of the knee and able to reconstruct the 3D planning of the knee. So what is happening is that your team can upload the X-rays onto the website, and thanks to that, the engineer are going to be able to recreate the planning and to perform the 3D planning of the knee. So that's what you obtain once you got your 3D planning, and you can see that you can access a very dedicated portal where on the website you can perform your planning. You can see the preoperative deformity with the standing full-length X-ray, which is very interesting to have, because you're not talking about a laying down patient, you're talking about a real standing patient. And at the end of the day, that's what matters to us, because we want our patient to walk well postoperatively. And alignment is all about the full-length alignment, patient standing. So you can see that you obtain these values preoperatively, and you can plan your case including the flexion space, the extension space, and also, of course, plan your final alignment. So the idea is to reconstruct the anatomy of the femur, and you know that Persona is a so-called morphometric implant with adaptation of the offset with sizes and increment every 2 millimeter, allowing you to reconstruct perfectly the offset of the patient. You can plan your final flexion gap. You can plan your rotation, of course, the flexion of the femur to make sure that you can match the anatomy of the patient. You can choose the size, aiming for the adequate posterior resection, knowing that Persona thickness at the back of the knee is 9 millimeter plus 1 millimeter related to the saw, and that's how you get the size that you want for your patient. You can do the same for the tibia, and the beauty of Persona for the tibia is that there's a morphometric tibia. And we published in the Journal of Arthroplasty recently with the team of Marseille the interest of the morphometric tibial plateau to optimize the coverage and the rotation without compromising the risk of impingement with the soft tissue. So basically, we were able to optimize the coverage and the rotation without any impingement compared to a standard symmetrical type of tibial tray. So with the ROSA, you can plan not only the size, but you can plan the rotation to perfectly match the anatomy of the tibia and to perfectly optimize the coverage of your tibial plateau. So once you have this, you can go ahead and check your final gap, making sure that you will be able to resect completely what you want to. And you can see here that the choice has been made by Rami for mechanical alignment, which remains the gold standard today in knee arthroplasty. And we can talk about the alignment philosophy later. However, today still the gold standard is the mechanical alignment. You can see the tibial positioning, you can see the femoral rotation and the tibial slope. knowing that persona has an intrinsic slope of 5 millimeter. Most of the time, we go between 5 and 7 to optimize the position of the tibia. And that's all for the case today. I'm going to stop sharing the case, and we're going to discuss with Nico and Parag if there's any question for the case, while Rami is completing the approach, and he will let us know when he's completely ready to go ahead.
Actually,
so Nico,
Sebastian,
yeah, you ready? Yes, Rami?
I got a question for you, because you said that the mechanical alignment remains the gold standard. That's what I'm doing. But you are actually one of the authors on a landmark article that changed people's thoughts about whether we should actually do mechanical alignment or otherwise. Do you want to comment on that in view of what is the gold standard?
Yeah, thank you, Rami. So what we showed with the Mayo Clinic team a few years ago, and that has been republished by our friend Matthew Abdel, is that the outlier, the patient that were below 177 and above 183, didn't have a worse survivorship compared to the inliers, the one comprised between 177 and 183. What we have to notice in this paper is that first, we didn't say that alignment doesn't matter. And second, we have to know that Jim Rand was the surgeon performing the surgeries at that time, an excellent, brilliant surgeon. And his outlier were very limited. And the most important virus in the series was 173 degrees, and the most important values was 189. So it's very, very limited. And the fact is that we might accept a little bit of variation according to the mechanical axis. However, we have to do that in a very conservative and in a very moderate manner. We are just about to publish our changes and our new technique of alignment using ROSA, being a little bit more anatomic than with the standard mechanical alignment, but also respecting limited variation. Parag, Nico, you want to comment on that, and you want to give your opinion as well?
No, I think I'm just getting questions. They want to see what Rami is doing. So Rami, can you just explain the steps, what you've done till now? Because all the delegates are quite interested to know the steps.
Yep, so now we're putting in the femoral arrays, and that goes, it's got to be high enough so that when you do the trials and the implant, it doesn't impinge on the array, because that would stop your flow. So you get it approximately 2 centimeters above, and you can see the distance here, 2 fingers breadth above the top of the femur. And that's a correct positioning towards the midline, pointing towards the camera, which is on the left-hand side of the patient. With the positioning of the robot, you can see the robot is on my right-hand side. We'll show you a wider view later. I tend to position ROSA, which is my new best friend, on the right-hand side of the patient for all cases, regardless of whether I'm doing a right or a left total knee replacement. It just creates uniformity for the staff. They don't have to ask me which side we're doing or which side the robot is going to go on. And we just flick around, working on different sides, but the robot always stays on the right side of the patient. So once you've got the femoral array in, the tibia, and if you've done navigation, it's just a standard array really, pointing towards the camera. This is the tibial array here. This is a bit more specific. You've got right and left sides depending on which knee you're doing. We're obviously doing a right knee, so the right side will be uppermost. We'll position it distal. Now, the positioning is kind of critical in that it depends on what tibial implant and trial you're going to be using. So I tend to use the Persona cementless. One of the advantages there with the cementless, obviously, is it doesn't have a keel for the Persona. So if you are using one with a keel, you're going to have to go a little bit more distal than where we're putting it in at the moment. But if you're using this one, then this is correct placement for it. I tend to put my pins within the wound rather than external. There is an advantage in that it's cancellous bone. We've been doing ROSA now for 1.5 years, and I have not had a pin site issue to date, touch wood. Obviously, they're reported and it is a risk, but we haven't had a pin site infection or a pin site fracture. And I think it's because we're putting it within the wound and proximal within metaphyseal bone.
Rami,
you want to comment on other placement?
Rami, I have a question. Yeah, does it make any difference if you put the for the tibia, but it's a bit lower on the distal part compared to the what you done now? Is there any different?
No difference. You can put it as low as you want, and the question is whether you can get it within your standard wound, or whether you make a separate incision lower down and put it through, a separate incision to the wound. So the advantage I have here is I put it through the same incision, so I'm not making a separate wound that I have to worry about later if it goes red. So I see that as an advantage, but it just depends on your own technique.
And a very important point that underlined by Rami before is the fact that if you put it in the metaphyseal part, in the cancellous bone, that's the best way to reduce the pin fracture, the related pin fractures. And it has been shown in the paper of Philippe Beaufils a long time ago for the navigation. And I think you remember this paper, Nico and Prague. And it's a very nice thing. And I like the fact that for the femur that you can control exactly the position. You can see what you're doing. While when you put the pin outside of the incision, you don't see very well. You don't know if you are close to the cortex, and if there's an obese patient, you don't control much. So this positioning on the femur is very helpful, and it's also acting as a kind of retractor, putting the extensor mechanism on the side, and it's very helpful like that.
All right, we're going to do a ROSA registration now, so we'll go to the other camera. You can see we've got the pins in. We're ready to register the robot. Now let's go to the ROSA, to the wide camera for Jamie. So ROSA's positioned beside me here on my left-hand side, on the right-hand side of the patient. Take a wider view, Jamie. That's it. Good, thanks. So now we're going to go through 6 steps of registration, which basically establishes the position of the robot on the ground, and it stays permanent throughout the operation relative to the patient themselves. The 6-step registration is automatic. I'm just pressing on a pedal. It'll go through the process. As long as there's no interference in the line of sight between the robot and the camera, it usually works first time. I tend to turn the lights off because sometimes reflection can interfere just with this part of the operation, and then we turn the lights back on after the registration process, so reflection isn't an issue. So you can see now that we're successful in our registration. We're going to the home position for the robot, and we can now go to the next step. If we can go to the screen, so if we can flick between screen and wide shot, I'm going to now register the center of the femoral head, and as I do that, it'll take 12 points of registration in different positions. Getting some noise interference there from somewhere. Okay, suck there.
Excellent. So you can see the registration of the center of the femoral head, 14 point, very classic. If you have used the accelerometer before or the navigation, it's the very standard technique. Now Rami is going to register the femur. I'll let you.
Yep. So now we're registering basically the same mark here. That's the entrance to the intramedullary canal. And then using this device, we're going to basically assess the posterior condylar axis. So we place that. And if we can go to screen, at approximately 3 degrees, it measures the PCA line for the posterior condyles. And then for Whiteside's line, we do the anterior groove and the posterior. So we register that to the robot. Anterior part of the trochlea, the posterior part of the trochlea. These are obviously approximations, but they are taken into account with the robotic. Note, this patient's had the x-rays as discussed before. So we've got the bone formations there from plain radiographs. We don't have to do an MRI or a CT scan. I feel the medial epicondyle. We register that. We map the surface with 3 points of the distal femur. Doesn't matter what order you do it in, as long as they're the 3 most distal points. And then we go to the lateral epicondyle. Again, the transepicondylar axis is not as critical here for me as it used to be. I used to religiously mark this out. But now, because we go to a gap balancing technique in flexion, it's not as critical for the transepicondylar axis. this is an important part of your landmarking. It's correlating your bone formation with the x-rays to where the true anterior cortex is, just so you minimize the risk of notching. So now we've done the femoral landmarking, we go to the center of the ankle, so we find the medial malleolus. And this is obviously for our alignment. Hold that up, thanks, Amit. Now we got the ankle in. Now we landmark our tibia, and this will be the center of the tibial tuberosity, or the medial third, the intramedullary line for the tibia, in between the ischial spines, the attachment of the PCL, posterior aspect of the tibia. We mark out really the depth of the tibial tray in the middle and on the lateral side, because this is where the level of resection is taken from. And we'll be determining level of resection in a little while. But for now, we're going to go through alignment. And if we show the screen here, so basically we are in 6 degrees varus. The preoperative, let's go to the HKA pre-op. From the x-rays, I think was around 10. There's usually a couple of degrees difference here. It just depends, as you can see, on how much force is being applied to the knee in what direction. But we've got a varus knee here, varus deformity, and a flexion deformity of about 15 degrees. I then assess it in extension, although we're not in full extension here, we're really in 15 degrees. I assess it through the range of motion, internally and externally rotating, to make sure we've got the full excursion and the correctability at certain positions at 90 degrees, and then we assess range of motion. This patient now has 106 degrees after all that manipulation. Take a picture.
That's a question, guys. If in patient with a stiff hip or knee, do you have any tricks?
If they don't have any hip movement, it's a problem, yes, because you won't be able to actually register the center of rotation.
The fact is, Nico, that if the patient has no hip motion, you might probably treat the hip before the knee. So
Correct.
This situation is not very frequent.
Okay, so if we can shoot across to the main screen now that we've done all our registration and marking, what we can see is our extension space, our flexion space. So our extension space here measures 23 and 18, which is too much, and I can now go and decrease our extension space, but note our flexion space is also high. So I've got an 11 millimeter tibial resection here, so I'm going to go to the tibia, and I'm going to decrease that. Take it up 10, take it up to a 9.5 millimeter. That gives me an extension space of 21.5, a flexion space of 21. I'm also going to go to the femur. I'm just going to decrease that. So now we've got a flexion extension space laterally, which is a more normal side, of 21. That's a good starting point. I then want to look at the flexion region. Take that off. You're seeing the screen, correct?
Yeah, very well, Rami.
Right, so normally I aim for about a 2 degree to 3 degree range of flexion, but what you've got to make sure is you don't have a stylus height that's too high. And you can bring your stylus height down. Go back to balance. So now we've got 21 on the lateral side, which is the more normal side. We've got reasonable resections all round. So we've got good balance, flexion to extension on one side. The rest, which is the medial side, where you've got 17 millimeters and 16.5 resection. Remember, you've got a varus deformity, you've got to correct that. So if you have a smaller space on the medial side, you put the implants in, it'll take it round to equalize your spaces, and we'll be able to reassess that inflection later on. So that's a good starting point to allow us to make the first tibial resection, which we're ready to do now. Seb, any comments on that?
No, I think it's when you are a surgeon, you have to do exactly when you use robotic what you do in a normal knee arthroplasty. We know that there's a lot of numbers on the screen, and we flew over it briefly for the sake of the surgery. However, when you start robotic, don't be worried. There's a lot of numbers, but it's come up very quickly. And when you are used to navigation or using PSI, you know how to do your planning. So don't be afraid or worried by the number of numbers appearing on the screen, and just follow exactly the same principle that you're using for a standard total knee arthroplasty.
Okay, we'll take a wide view of Rosa now. So as Seb said, if you're used to PSI, you'll be used to the numbers. If you haven't done navigation or PSI before, it's a bit daunting, but look, this is really, you can use it as a standard technique. It's just another instrument, and you can use those numbers to whatever extent you want to initially, but they're just giving you a guide to the number of millimeters in a space, and you want a minimum 19 millimeters in the space. You're basically reproducing what you're resecting with the implant, and the rest is just about balance. So now we're set. The robot's going to bring the tibial cutting guide into position. It takes 2 movements, and then in a collaborative mode, I can move it towards the tibia just to adjust it into position. It'll hold that position, and actually you can leave it there, but I tend to, and it is recommended, you put 1, 2, or 3 pins in. It does vary. It's now locked in position. It's not going to move. If the patient moves, it moves with it. But I tend to put in 3 pins, including a locking pin. Some may not be doing that routinely. Once that's in, one step.
Rami, can you show the live cut values for the attendees, for them to understand that, as you said, ROSA is in a collaborative mode. Then approaching the knee, you can set up ROSA exactly where you want, but ROSA is keeping the values that you dialed in.
So can we show the screen? Actually, move out of the way because I can show them the screen.
Excellent. We can see the screen now.
So there's a cut out. That's what we're planning to cut. Okay. And so it's all green, which means you're in the right position with a 7-degree posterior slope. You're aligned to 0 degrees, and your level of resection is what we've planned. So now it's fixed in that position. We'll go ahead, we'll make the cut, and then we'll validate it. So come take the, thanks. Let's have the saw, thanks.
So while Rami is showing, you can see that the ROSA process is relatively easy. ROSA is arriving next to the knee in an automatic mode, and then the collaborative mode allows you as a surgeon to position exactly the jig where you want, while ROSA is staying coplanar. Then you ping the jig to the knee, you do your cut, and it's done. So it's very intuitive, it's very easy into your surgical flow, and there's nothing major. It's not a revolution, it's just an evolution. ROSA doing what we can't do well, which is to position exactly the jig at the right place. But you can see ROSA now going away. Your cut is done. It took not much more time, to not say no more time compared to a normal surgery. So now Rami is going to extract the tibial plateau. And of course, when you're using ROSA, you can start with the tibial cut like Rami did right now, but you can also do your femur if you prefer. You're really free to choose which cut you want to start with. So no problem for that. There's no, you're not forced to follow a specific order. You as a surgeon can decide.
But Seb, can I ask you? I mean, compared to the other like Mako with a burr, so what is the plus and the minus point of this disadvantage of this system?
So the other system are the so-called haptic system, and they are bringing some more constrained way of doing the surgery, because I don't know if you probably ever try, you feel very constrained when you're doing the surgery. While with ROSA, and I'm biased because I'm one of the designer, and we worked with the other designer to make it as a part of the surgeon tool and apparatus. We didn't want the robot to force the surgeon or to constrain the surgeon. As you know, we have a lot of constraint everywhere in our job, in the office, with the hospital, with everybody. So in surgery, we wanted to keep the freedom of sewing, and we are surgeon, we know how to sew. The haptic can prevent some of the complication, but not all of them. And so that's why we didn't want to increase the constraint for a potential benefit, which is not always very clear. And another principle of ROSA is to not replace something that we do well. So, for example, Rami is going to show us later on that he's going to use the 4-in-1 block. ROSA is going to help us to position the 4-in-1 block, but you don't use the robot for the 4-cut because it's taking a long time, while the 4-in-1 is very accurate, it's very smooth, and it's very easy to use.
Thank you.
Yeah, so I find here that this is, I can exchange from using ROSA to using the Persona instruments quite nicely. I just get so much more information using this. So it does give me the ability to get better balance intraoperatively. Whether that plays out as a better outcome for the patient, at the moment, obviously, I believe it does. But in the long term, studies will tell us. But at least intraoperatively, I'm making decisions based on fact, not based on guesswork. And that's the main reason I'm using it. I do like the feedback from the smart tools to tell me where I am, how much I've resected, was I accurate. I validate everything I do. So it's not a case of, okay, have I cut it in varus or valgus? I won't know till the post-operative x-ray. But now you can actually put your validating tool in and actually see what you've done at this step before you go to the next step. And I think that's very beneficial to us as surgeons. So you can see here, I've got a tool now to validate. If we look at the screen, can we take a shot of the screen? Yeah, so you can see it's moving until I actually put it onto the tibia. And then so that's our resected levels. And you can see there, it's within 1 mil or 0.5 mil of the projected. Did you go past? Okay. Did we see that? Okay, good. So it was all green. If it's all green, we're in the ballpark and we're good to go. On to the next step. Now, you can see my trusty sales rep here from the company, Cyrus. I'll mention his name. And the reason is that when you're using robotics in theatres, you can't do it without a good backup, unlike conventional instrumentation. So it's worth discussing that when we get into this level of technology, you do need someone reliable out there working the technology in the background so you can actually get on with the operation at hand. Seb, any comments on that?
No, that's very nice, Rami, and we can see that you're ready for the next step. We can see that, like you said, we can switch from one technique to the other one. So far, I've been less lucky than you because I almost never have a rep in the room in Abu Dhabi. But the fact is that the team is well trained, as you mentioned before, and the beauty of this system is also that you don't have to have a rep in the room, while some other systems are requiring a rep, and then your surgical schedule is based on the rep schedule, and I don't like that.
So Rosa has just moved the femoral cutting block into the position. If we show the screen for the anticipated cuts, you can see it's positioned that cutting block to what we had planned for the distal resection of the femur. And again, we'll lock it in with 3 pins. How we got to? Okay, so there's a question here from Simon, and that is how we got to this level of resection. So the plan identifies that we're doing a mechanical alignment. To achieve that, you have to resect a certain amount to leave yourself a gap that accepts the implant we're going to put in. So if we go, we're not going to go back, but if you recall the initial screens, we had a 20 or 21 millimeter gap. I like a little extra gap because this guy also has a very restricted range of flexion and extension. So I've given myself an extra 1 mil or 1.5 mil to work with. And if I need to make that up with an extra mil, an 11 millimeter poly, we'll do so. But that's how we basically arrived at this level of resection of 8.5 millimeters on one side, 5.5 millimeters on the medial side. Simon, does that?
Excellent.
So?
There's a question from the audience.
Yes, Nico, you want to go ahead with the question while Rami is sewing?
Yeah, do ROSA works with every brand of implant, or do we need to register a program if we won't use different implant for examples with NFU or J&J?
No, ROSA is made for Zimmer Biomet implants, so you can use whether the Persona, the Next Gen, or the Vanguard. It's not made to be used with other type of implants.
Yeah, they have to know first what is a closed system and open system.
Exactly. So I'll let you explain that, Nico. Huh? I'll let you explain that.
Yeah, because after this, most of the robotic now, they have a closed system, right? So it's not like a universal, like the old one.
So you can see in our live surgeries in APAS, we're going to be showcasing really ROSA, which is Zimmer. We're showcasing Velis, which is DePuy, Omnibot, which is Corin, Maker, which is Stryker, and in a masterclass, the new one, Corey, which is Smith & Nephew. They're all closed platform. They're for their implants. I don't actually have access to or familiar with a non-allocated one. I think it was called Think initially, but Seb, you might know. But most of them are closed platform, aren't they?
True, and the Think Surgical is still an open platform. There's the Think Surgical is the old RoboDoc, and you probably heard of it because it's the historical robot. And this is still an open platform where you can dial the thickness of resection corresponding to your implant, and you can use the robot. This robot is an active robot, meaning that the surgeon is doing nothing. It's just setting up the robot and then burring. We're going to go back to the surgery as Rami is going to validate, as you saw for the tibial cut. Now Rami is going to validate the distal femoral cut with the same tool.
Show the screen. So we've validated now. If you see the screen, Steen, show robot screen. So you can see we've validated here, and again, we've got all green. So the cuts we intended to do, we have done within a millimeter. You can try to get more precise, I guess, but within a millimeter, I'm pretty accepting of that. And our alignment is certainly well aligned for our start. So it's a good starting point to say, okay, we've now done the main cuts. Let's now go and see what our extension space is like. And this cuts back to the old technique where basically I look for the extension space, I feel for the PCL, I put in a spacer block, and we measure that. Now, remembering this guy had a significant fixed flexion deformity. So the question here, and this may vary from surgeon to surgeon, I still got a bit of work to do on the posterior capsule behind. So I like to be below 10. I don't aim for 0 or chase 0. If I'm 12, I'll go back, take another 2 millimeters off the femur here. But I'm below 10, so I will accept that. Seb, what do you do?
Yeah, same, Rami. As you mentioned, you haven't removed the posterior osteophyte yet, and I think that you will gain this degrees of extension after removing all the osteophyte and doing the work at the posterior aspect. I don't overcut the femur. I don't like that.
So now we're at a position now where we're actually going to use a tool called the fusion device, which we can show. Can we show back to the other screen? Yeah, so this is basically a gap balancing tool. Allows you to put tension on the space in flexion and then dictate the rotation of the distal femur on the cutting block at 90 degrees. Good, no, that's fine. Let it go, let go. Yeah, let it go. Good. Can you tighten that up for me? Can you see clearly what? So what we're doing now?
Very well, Rami.
Increasing the gap. We're tightening it up now. There are marks on here, but it's just a question of how tight do you need it to eliminate a little bit of movement or accept up to a millimeter of movement. So at 90 degrees, I internally and externally rotate. I need to show the screen. The screen will show us that we're externally rotating. We show the screen? Yep. So you can see the 19 millimeters on one side, 14 on the other. And if I internally and externally rotate, it moves about a millimeter, right? So a millimeter of movement is good. If it's more than that, I'll tighten it even more. So that's our flexion space with rotation external from the PCA by 5.5 degrees. So this determines the positioning of the 4-in-1 block. Okay, save that, capture. So that's what we're going to go with. And this is really the dilemma. When we were using conventional instrumentations, we weren't sure about our tibial resection because we couldn't validate it. And I was using the transepicondylar axis really routinely on every case for 22 years. But now I've changed. Why? Because I think it actually makes sense. I can see the information, I get the feedback, and anecdotal as it is, my patients certainly seem happier in the first 24 hours, and it's quite noticeable. Others may comment on their approach to, measured resection, gap balancing, and while I make this cut.
Nico, Parag, any comment about that?
So my particular take is, I'm more of a gap balancing guy, because basically I do a PS knee always. I'm not a CR guy. That's number one. Mm-hmm. And I feel that, it always gives you a leeway, and it's better to do, parallel to the tibial cut technique. And I feel that particular step is good for me. So I go more for gap balancing than measured resections, because at times then you leave the knee too tight. That's what I have seen.
Indeed. Nico, any comment? You're more a CR surgeon. I do PS as well, Parag, and I love to. Yeah.
I adopt your technique, SAP. This the hybrid. Nowadays, I'm do both the hybrid, the gap balancing, and the measure resections.
I might just interrupt for a minute. Steve, do you want to put it on the screen?
Okay.
So now we've got our flexion space determined. But we've got our rotation determined, but now we've got a bit of tweaking to do, and you can see. I don't know if you can see the screen there. They can see it.
Yeah, very well.
So now you can see our extension space is 19.5 and 20. So I'm happy with the extension space, if you can see that. The flexion space is 22.5 laterally, 21.5. So the flexion space is slightly more than the extension space. So in that circumstance, I'll go to the flexion tab. I'll bring down the stylus height, basically to be at the top of the femur. What we've created there is a flexion space and extension space that's near balanced. Now you can tweak it a little bit more by opening up the medial side, just by rotating it slightly one way. It's that way. So you can see what I've done here. Our extension space is 19.5, 20. Our flexion space, medial and lateral, is 21 and 21. The only problem is our stylus height is a little bit too low for my liking. I like it at 0 as a minimum, preferably a half, so I'll go up back to 0. So now we've got 20, 21.5. Now, if you were going to decide you want that completely equal, you've got the option here, and I'll do it just for an exercise, of going up a size. So we can go up a size 10. So I've gone now from a femoral 9 up to a 10. Then I can accommodate that by moving it up. So I've got 0.5 millimeter of stylus height. What I've got now looks to me like a nicely balanced flexion extension space for this implant, going from the initial size 9, which is predetermined on our x-rays, to what functionally is a better fit for this gentleman, a size 10. So that's the one we'll go with, and accommodating that. I always like it a little bit looser in flexion than it is at extension, but here everything's within 0.5 to 1 millimeter. Okay.
Very clear, Rami. Thank you for this precision. And maybe we can see the approach of the robot for the 4-in-1 cut.
Yep, let's take a wide shot. The robot's ready to go. We'll now come into position. So 2 moves, and then collaborative mode. Ease it down onto the distal aspect of the femur. It stays in position. Lock it in with your pins. 1 pin and 2. This is just to make the marks for the 4-in-1 block. Now it's done.
And once again, the approach here, yes, here we remove ROSA, we put the 4-in-1 jig. And here, once again, the approach as designer, the team of designer was, why would you use the robot to do the 4 cuts while you can use the 4-in-1? It's very simple, easy, efficient, and that's what we're going to see with Rami now.
So now at least you know you've got your balance as per the robotic numbers we've just shown. We've positioned it correctly, or as accurately as we can. We've pinned it into position. We don't need ROSA anymore. So at this point of the operation, the rep can remove Rosa completely out of the way, and I can get my trusty assistant into the correct position for the rest of the operation.
Indeed, you just keep Rosa for the evaluation of the knee status at the end of the surgery. However, like you said, you don't need the robotic arm to do anything anymore.
Correct. This is a very, very big gentleman, as you can see. Even with a size 10, it's still got a very wide femur, so there's no issue going up a size here. I'll double check that we're not going to notch, but you know, we've given ourselves a comfortable clearance there, and that should be quite good. All right, so.
So while Rami is showing, you have to know that the intrinsic accuracy of a robot, any robotic system, is 0.5 millimeter. When you, if you will go to worst case scenario, you can end up to an inaccuracy between the 4 cuts that you're going to do on the femoral side up to 2 millimeter. If you sum up 4 times 0.5, that's bring you to 2 millimeter. So that's one size of persona. As we saw, from 9 to 10, there's one size, 2 millimeter. So that's also a reason to choose the 4-in-1 block, because for the 4-in-1 block, the 4 cuts are linked. So there's absolutely no discrepancy between the anterior cut and the posterior cut. And it's even more important for a cementless implant to make sure that the contact with the bone is optimal. So that's one of the reasons why we choose to use the 4-in-1 cut rather than the robots to do the 4-in-1, the final 4 cuts. Any comments, Parag and Nico, on this approach? Or
No, I agree with what you're saying. Essentially, I'm not still started using the robo, but after hearing you and seeing Rami, I might start using it. But I agree with your comments. So, are you using robo for all your cases, Dr. Parrott?
Yes, I'm going to say 90%. It's a matter of turnover, or when I have very. There's one limitation for me. One contraindication is the extremely obese with venous insufficiency of the tibia, because I put my tracker outside of the incision, and I don't want to risk any cutaneous complication for this, the old patient with very bad skin quality or things like that. That's the real contraindication. Otherwise, I've done BMI up to 55 when they have a good quality of skin and everything. It's even better than the normal instrumentation because you don't have the impingement with the soft tissues.
And do you feel that you've been using the robo for how long now, Sebastian?
Since a bit more than 2 years, because we did the first official case in Abu Dhabi in March 2019. So since then we have been using, and I saw a change in my technique, in my practice, and we are now publishing the first papers about that. One is going to come out this month, and the clinical reports are going to come out. We're submitting the paper now.
So I must say you've got converted, and I can see Rami also, that I've been talking to him a few times, and Rami is also liking the robo. Not very happy with that, if I have to say on a lighter note, but seems that the robo is going to stay. So, Rami, what are your thoughts, Rami? I know you've been great at conventional technique, and you've always done that.
So Parag, it's interesting. It's the information you get intraoperatively. I mean, when you go back to the instrumented knees, we can all do instrumented knees, and there's no problem with that. And if that's the only access you have, you know that at 19 years, 90% of your patients won't have had a revision. That's what the joint registry tells us, okay? So we can do it. But if you want to fine-tune, tweak, and just get slightly better functional outcomes for your patients, then you've got to look for other means of achieving that. And what this technology delivers is that information intraoperatively. For you to choose to use as much or as little of it as you can, because you don't have to use the full energy of this technology. You can start simple, just use it for your cuts, to validate your cuts, and then start using the balance tools and the analytics and all that. So start slow and build up if you have access to it, and eventually it will become affordable for everyone.
So I had a quick question, not directly related to the robo, but I don't see that you used a tourniquet here. So is it because of the robo you started doing that?
No. I stopped using tourniquets about, I keep saying 5-6 years ago. It's probably a lot longer now, maybe 8 years ago. It's a long time. And you can see, I guess I have an advantage that I use cementless technology, but I also use hybrid in the public, and, I use no tourniquets at all. And there's actually a good study from Chris Vitullo from the Joint Registry.
Does not using tourniquet have something to do with the robos because you've got your arrays coming there, or is it something greater than that? Or Sebastian, you can answer me that. Is it comfortable? Is it good to use a tourniquet while doing a robotic surgery, or you don't care?
I mean, you can. I'm not using tourniquet either, and I think I've never used tourniquet. I learned with Jean-Noël Johnson, and since the beginning of my residency, I've never used tourniquet. You can use the tourniquet if you want with the robot, no problem. You can. What we recommend is to not change your technique. So basically, if you are a tourniquet surgeon, you use the tourniquet with the robot. If you're tourniquetless, it's working very well as well.
Okay, got it.
There's a lot of paper coming up about tourniquetless surgery. It's interesting to see that a lot of American surgeons are coming to tourniquetless, while in Asia or in Europe, it's something very common since many years, like Rami was saying. Now a new approach for some of the surgeons is controlled pressure for the tourniquet, so it's kind of in between. Very low pressure, and there's a beautiful paper from Andrea Baldini. We received the European Knee Society Award for that, showing the potential interest of a low pressure tourniquet surgery.
Right. I tell you, Parag, that once you commit and move away from tourniquets, you won't move back. One of my colleagues, I sat next to him in a meeting, Miles Coolican, and he said, "What are you using tourniquets for? For goodness sake, just try again." And I did, and I haven't gone back. So you need a bit of a nudge every now and then.
No, we'll start doing that. In the same breath, do you also use drains, Rami, or you don't use drains?
No, I stopped drains a long time ago.
So no tourniquets, no drains.
No, I'm saving money to pay for the robot.
I don't think you'll have to save a lot then.
Same here. I just spent a little bit on the tranexamic acid, which is brilliant. And I used to use it only IV, and now I combine IV and intra-articular. And all the papers are showing that doesn't matter where you put it, as long as you give it to the patient, and that's the beauty. Nico, you like it as well? Parag, you like it as well, the tranexamic acid?
Yes, I use it all the time, and it's brilliant. My rate of transfusion has gone down. For unilaterals, it never was there, but bilaterals also, I used to transfuse, but now it's gone down. Maybe 10% of my patients would require a transfusion for a bilateral. So that's really great. It works like magic.
True, right.
Sep and Rami, I have a question. Both of you are always a pioneer. When the first computer CAD, both of you were one of the pioneers in the world, and now the robotic. So now you move from the CAD to a robotic. Do you think does it make any difference, or you say no?
Definitely a difference. For me, definitely a difference. You move because you don't want to get stale, Nico. You stay in one spot too long, you get a bit stale. But look, if it wasn't giving you the information intraoperatively to help you make critical decisions, it wouldn't be worth it. But that's where I find the value here. But look, everybody's got to make their own decision. It's only in trying it that you'll come to realize the value that it brings to the surgery.
Good.
Indeed, and Nico, it's bringing also the fact that the robot is making the positioning. So you have the information, and you have also the accuracy of the positioning. Why we know that for navigation, it was a bit wobbly. And second, the sagittal plane for navigation, we never get quite there, because I think the rigidity of the construct was not sufficient for the slope or for the flexion. While with the robot, the rigidity of the construct is really excellent, and therefore you gain in accuracy, particularly in the sagittal plane as well.
Yeah, especially one of your publication, look at the robotic, the osteoporotic with the cast, right?
Indeed.
Yeah.
And I wanted to mention, we were talking about bilateral with Parag. So bilateral are not common everywhere, but it's very common in Asia. And we are about to submit a paper of bilateral robotic knee arthroplasty as well. And interestingly, there's no paper about bilateral robotic knee. There's bilateral cast, but no bilateral robotic. And we show that it's feasible. and we compare that to a population, to a cohort. It's a retrospective comparative study showing that we get a better accuracy without increasing complication, and with 10 minutes more surgery average compared to the standard bilateral.
So, Seb, I'll just interrupt for a minute. So we're going to do a trial now. I'm happy with the posterior aspects. I've removed a lot of osteophytes, as you saw. That was probably limiting our ability to extend. We've done all the cuts. Now let's do a trial. I am using, the Persona cementless, which has a 2 hexagonal lugs with a TM surface preparation. You can see it's an asymmetrical base plate, which is good. I think it's even better with cementless if you use something that just fits as well as you can out to the cortices, gives you good stability when it sits, also blocks all the cancellous channels from bleeding. So that's a good fit. Rosa predicted a G. This is a G. And look, it actually is a fit. But you can go up a size, down a size to whatever you want, but I'm quite happy with that. I'm a CR surgeon, but look, at the moment, my balance of implants is 80% CR, 7% MC, and 13% ultracongruent. I don't use the PS anymore. I don't cut that box anymore unless.
So what did you say? 7% what, Rami? 7%?
80% CR.
Yeah.
7% MC, and the other ultracongruent.
So the medial pivot, you mean when you say?
Medial.
Correct.
Plane, not medial pivot. There is a difference.
And what would be the difference?
So it's a size 10 femur, the size G tibial component, a 10 millimeter CR poly. All right, let's have a look. And you can see we've got 6 degrees flexion. We've got, can you see that? Yeah. We're in 2 degrees of varus. And so clear all, let's start that again. Yeah. So what I want to assess in that degree, that's not full extension, that's about 7-8 degrees. I've got no medial to lateral movement as I'm trying to basically push it internally, externally. I go up to 30 degrees, 45 degrees, 60 degrees. Again, there's none of that mid-flexion laxity. It's a nice, smooth set of movements, and my range to flexion is now 126 degrees and in that movement. So that's my trial. If I was worried, I could tweak it, I could come back, I could readjust cuts, but I'm quite happy considering where we started in this gentleman with his range of motion to have now a good range to flexion. The other thing is this is CR, and if we can focus in on just here, you can see that posterior translation, there is none. He's riding on the mid-coronal plane, there's good balance, internal, external rotation, doesn't open it. So I'm happy that this is a well-balanced knee, and I'm going to go with those implants. Let's mark that.
So Rami, there have been some surgeons who would like to use a tourniquet just while doing the prosthesis because the presumption is that you should have a bloodless femur and tibia for good integration. So
no
do you
problem
do
at
that?
all. There's no issue using tourniquets. It's just an added thing for me. I don't need to use it, but anyone who wants to use a tourniquet, by all means.
How do you ensure there's no blood in the trabeculae and there's no blood there so that you have a good implant bone interface?
I think urenesis makes a big difference too, because if they can keep a hypotensive patient, then you'll have less bleeding. Whereas if urenesis isn't on the job, it'll be a bit messy.
Okay.
Rami, very good
there's a question from Rajiv Kumar Sharma. What is the level of soft tissue release that needed in robotic surgery?
Well, you can see what releases I've done, virtually zero in this patient, but this was only a 10-degree deformity. Where I find I have to do some releases is I've got a 15-degree valgus deformity or more, I'll probably have to do some posterolateral fenestrated releases. But ever since I started using this technique and the balance, I find I'm doing virtually no releases for various deformities. But having said that, I should qualify it. I don't get the various deformities that Parag gets, okay? These are a little bit more benign than some of the substantial deformities that he and Arun and Ashok get over there in India. So we should qualify that.
Yeah, you'll see one this afternoon.
Yeah. And I think that's the difference. Yeah.
That's true. And Nico, I confirm that with the, I'm going to say moderate deformity, and we got quite nice deformities here as well in Middle East. But with moderate deformities, you don't need any release. And sometimes what you can do is the vertical cut on the tibial plateau to gain this without releasing too much your medial collateral ligament. It's also very helpful to do bony resection, but with this robot you can calculate everything, which is good. You can see exactly where you are. And to me, the release time is always the oops time, where you release a bit too much, you don't want that. So that's why with the robot you can really control what you're doing. Rami, I see that you're doing LIA. You're doing local infiltration of anesthetic.
Yeah, so
it's very important.
Local infiltration anesthesia, combination, we write it up all the time. Ropivacaine, 30 mils, 1%, adrenaline, 1 in 1,000, 1 mil, and normal saline. Sometimes we use Toradol, it depends on the anesthetist and their renal function. But the base is ropivacaine and adrenaline with saline.
Okay. Then no steroid.
The other thing is whether anyone uses adductor canal block routinely. I used to use it for a while. I've stopped using it now. It really is GA and local.
So we used to use the femoral block, and also later on we gave that up, started the adductor block, but now we've come down to IPAC. We just do that, and it's a good thing.
Indeed, it's very helpful to do this local infiltration, and you don't have to wait for the anesthetist to do the adductor canal, so it's also good.
Sebastian, you were talking about your experience with PS knees and CR knees. So while Rami is just finishing that bit of the surgery, what are your thoughts and comments?
So I think that we have no final validation in the literature. So I like to say that it's like a religion, it's a belief. And at the moment, I'm still using PS for the range of knee flexion, because to me, that's how you can get the full range of knee motion for the patient. And it's a very important requirement in Middle East as it's in Asia. I haven't tried the MC that Rami was talking about, where you can sacrifice the posterior cruciate while having this medial congruency that is guiding the mobility. I think that at the end of the day, when you do a good balance, when you do a good release of the osteophyte at the back of the knee, and when your knee is when your implants are well positioned, I'm not sure that will make any difference. What do you think about that, Parag and Nico?
No, you have to attend this at the 3 o'clock debate, so you can see who win. Yes, Parag.
I'm just going to show you.
Right now, I am a 100% PS guy, but I've tried the CR, but would like to see. I haven't tried the MC knee what Rami's talking, or for that matter, the ultra congruent. I would be happy to try that.
We're just
Yes, Rami, we are ready, Rami. Can you show us the salient features? How do you put that? Yeah.
And we're not using cement, obviously. We've made 2 drill holes, and in it goes. And I try to lift up, it doesn't move, and then I take it home.
Okay. Yeah, so is that the final one now?
And then our poly goes on. And the advantage here, obviously, is we don't have to wait for cement to go off.
Yeah.
And we take the polys in. Take that out. And we're ready for the femur.
So Rami, it's a trabecular metal surface, if you want to show.
Say again, sorry?
It's a trabecular metal surface, correct?
Correct.
At the back of the implant.
The TM surface preparation with tantalum on the bottom. And now we've got a good position. Oh, that looks good. Okay, so let's have a look. Look at the ROSA screen. We've got 5 degrees flexion, 2.5. The movement in that medial to lateral is negligible. We go up to 30 degrees. Again, negligible. 45 degrees. There's no opening. 60. 90, and range to flexion, it flops nicely to 125. So, and patella tracking, that's the other thing. We go back to, you can save that, save it. Let's go back to the main screen. You can see I haven't resurfaced the patella. We haven't really talked about that, maybe in another session. I'm a non-resurfacer unless it's completely worn out. It's tracking very smoothly, no crepitus, and that's what I'll accept. Bosch?
Excellent, Rami. Huh? Bravo.
Well, Rami and Seth, you know, with this robotic, you look at the alignments. You can have mechanical alignments, or you can just a kinematic alignment with the robotic. But I would like to ask both of you, how about the middle pivot?
Yeah. Rami, you want to start?
Sorry, I missed the actual question. What was
the question? Was about, can you use medial pivot with the robot, and can you talk and develop a little bit more about your experience using medial pivot?
So firstly, I don't use the medial pivot, but I use the MC, the medial constrained. It's not quite as constrained as a medial pivot. So, you know, it's not that I'm not of the philosophy of medial pivot, I just don't use that implant. They're specific to do two particular implants, but this one, medial constraint, just gives you better congruence and contact on the medial side. So if I have a PCL that's compromised, I'll use an MC to give me more congruence and stability in that medial side. That's when I'll use it. If I've got a really good PCL, I've got good range of motion, I don't need to fenestrate it significantly to compromise it, I'll use CR. And so the majority of my patients are CR, but I do like having the backup of an MC for where I have to really take to the PCL to give myself good flexion space. And if I have to sacrifice it completely, I'll go to the ultra congruent in those significant deformities.
So what's your indication for ultra congruent again? So, because that's like, you said 13% of your cases are ultra congruent.
So the main indication for the MC is where I've had to do sufficient work on the PCL that I'm just a bit concerned about stability. So I go for the higher congruent poly to give me better congruence and stability. That's where I'll use it. But otherwise, I do CR in the majority, you know, over 80% of patients.
So when you do the ultra congruent, you cut off the PCL, is that right?
So when I do the ultra congruent, you have to remove the PCL because there's no space up the back, and it will actually impinge if you've left any. But the MC does have a cutout, so you can leave the you can leave the PCL, you can sacrifice it, you do it, and usually I'll leave whatever remains behind. If I use an MC, I'll leave part of the PCL, and I'm really augmenting it for extra stability.
So Rami, we have about 4.5 minutes left. You did a great job. So I think any concluding remarks or questions?
Yeah, look, the main thing is what I wanted to show here and share with the wider audience is, look, this is what I use routinely and have done so for a year and a half. This is only one bit of technology, and it's only one part of the operation. There are other bits of technology that are equally as good, and you'll see them throughout the meeting, and that's the beauty of being able to see live surgery and go in with the surgeon, and we're all grateful for them inviting us into their operating suite and for the teams making the time on a Saturday to actually allow that to happen. So kudos to all of them. But I hope the audience gets a benefit from seeing what we do routinely and then getting some advice from each one. Everyone's got a different perspective of how they approach it, how they balance knees, and you'll pick up something from everybody, and then hopefully everyone will deliver a better outcome for their patients.
Yeah, so one quick question before Sebastian can give his concluding remarks is regarding the cemented and uncemented. So we do have a debate coming up soon, but just to get your view on the uncemented, I can see again that there is a clear shift in your practice to uncemented, hybrid, and completely cemented. So just a quick...
Yeah, look, I've got a schizophrenic practice. My private has been cementless for a long time. My public, it varies from cementless to cemented. You know, it's a question of availability. I like to keep a bipolar practice with the industry, so I get to contact and talk to everybody. But look, I've been using the Persona now for 2.5 years cementless. Before that, I was using the Vanguard Regenerex cementless for 10 years. Cementless works despite what people tell you, and I'm not selective. I use it for everybody. And in the 2.5 years of using Persona cementless, I haven't had a failure that I've had to revise for aseptic loosening to date. I've done one revision for exchange of poly in a septic knee, but that's it.
And when do you do a hybrid?
In the public, I'll use a cemented tray for now until I get the cementless tray made available.
No, apart from that, in your private, are there any times when you think that, okay, this is a better case?
Zero cement. It's all cementless in my private practice.
There's one more thing which, the osteoporosis part, your people I've seen generally have healthy bones, but we see in India, the bones are quite osteoporotic, but sometimes you get a good femur, but the tibia is not so great.
Yeah.
So would that be a case for doing a hybrid?
Well, look, I mean, there's a lot of literature on that, and I will accept that there's more osteoporosis in India. But we have patients with rheumatoid arthritis. We have osteoporotic patients. Just ask them to drink more milk, Parag.
Right. yeah. And even though we have more sunlight, they don't want to go out. Maybe. Yes, Seb.
Thank you very much. And once again, congratulations, Rami. It's not a simple exercise to do a live surgery on a Saturday in front of a lot of people. So thank you very much and congratulations for this beautiful demonstration. Like you said, the robot is a tool and the other parts of the surgery remains very important. Even if you have a robot, you need to know where you want to go. It's like if you have a GPS in your car, you still need to know the basic principle of knee arthroplasty. You still need to have a strong experience and build your strong experience on the clinical result, on the literature, and on the experience of the others. I would like to thank you, Parag, for your motivation and moderation. And thank you so much, Nico. Nico, I hand over to you as you are the boss here and to introduce the next session and to conclude and to give the final words for this session. Thank you very much, guys.
Thanks.
Thank you very much, Sap and everybody. And Rami, it was a great operations, on time, good pressure, right on time. And now we move to the next sessions for the knee and the hip, of course. The knee, we're going to go for the technological advancements. So maybe we can stay, who would like to stay here or go to the hip auditorium. Again, thank you very much. And
round of applause for Rami. Well done.
Thank you, Nico. Congratulations, Parag, Rami, and Sebastian for a most wonderful demonstration of the ROSA robot. Made it look easy, Rami. Well done. So we're now going to move on to the next session, which are 6 papers on technological advances in total knee replacement. And I'm joined by my co-moderator, Professor Ni Nung Lo from Singapore. We're going to have 6 talks, which will run sequentially without any introduction from us. And then Professor Ni and I will then lead the 15 minutes of Q&A. So let's move on to the talks on technological advancement.
thank you, Mr. Chairman. Today, I would like to share with you about new technology and the replacements. Is the latest always the greatest? This is my disclosure. We know that orthopedic surgery is the most dynamic specialty in medicine or surgery because it has a rapid advances, curative, and a lot of innovations. But we know that rapid advances has a double-edged sword. When it works, patients benefit. If doesn't, it will be disastrous and serves to emphasize the risk of new technology. The question now, where are we today with joint replacement? We know there's a lot of evaluations of robotic procedures and implant designs, smart implants, artificial intelligence, and outpatient surgery and the centers of excellence. Fact number 1 shows that long-term data of the current knee implant designs demonstrate 90 to 95% success rate at the 15 years follow-up. Although 20% of the patients who undergo knee replacements are dissatisfied in the short and mid-term, the implant survival remains greater than 80% at 25 years. So it's hard to improve 98% success rate, and you might have the chance that it will be worse. Question now is that CAS, PSI, and robotic, can it achieve 100% success rate? This publication from the Australian Registry by Richard De Stuyker shows that patients less than 65 years strong evidence of how computer navigation is reducing the numbers of revision. There's commentary from Go Chin Lee. He says that registry data only provide a bird's eye view of a situation and lack of specific clinical details. Yong Ho Kim, who won the Chit Renawat Award, he says there's no benefit to computer navigation in replacements in the terms of pain, functions, or survivalship. So then, is mechanical axis maybe the wrong target and CAS? These 2 publications from our good friend here, Matthew Abdul and Seb Parrett, do the study in Mayo Clinic. They say that outliers have somewhat better 15 to 20 years survival. Christopher Jones, he said that CAS usage in US and UK is only 3 to 5%, while in Australia it's about 30.9%. Given the similarities of demographic, surgeons training, and another surgical aspect, it's difficult to elucidate the reasons behind the big difference. Simon Young, in a recently published 2020, look at 20,000 knee replacement, he said the CAS did not confer detectable advantages. AOS guideline shows that strong evidence support for not using either PSI and the CAS. So we said move out of this bulky thing from the OR. Nowadays, we have the handheld navigation system, which gives us an intraoperative feedback and fairly inexpensive. But we published the core last year. We show here that not enough data published to support any functional benefit of the ABN over the conventional. Fact number 2, the patient's demand for a new technology can influence selection. Because nowadays it's direct to consumers marketing through the internet and the philosophy that the latest is the best. Nicholas Pagani shows that patients' preference for robotic is critical when considering patients' involvement in decision-making and public unawareness of the dubious outcome superiority of the robotic due to the misinformed decisions in some patients. So robotic is a powerful marketing tool for the surgeons and the hospitals that offer robot to be better than hospitals that do not. We know that much of today's innovation is fostered by the industry rather than by academia, and the follow-up is only 2 years, which is underpowered, and done by a single surgeon in a single center study. Mostly are popularized by a famous surgeon with an untested treatment. Michael DeFront in Journal of Arthroplasty 2020, he shows here that 91% of the published papers they declare of financial conflict of interest, and mostly are reported favorable result for the robotics. New technology always comes with an increased cost. We know that new technology is expensive while the reimbursement will decline. William Sherman put a questionnaire for the AAS CAS shows that robotic increased the operative time and not more cost effective. So widespread popularity of robotics may not necessarily correlate to superior clinical outcomes. Number 4 fact shows that new technology comes with a technique difficulty. But Kayani shows here that the learning curve is only at 7 cases. While Pierre Boucher, he said that surgeons and hospitals should not use these approaches since they add cost and have a learning curve with an uncertainty of novel surgical approaches. It is being supported by the publication from Peter Skulko, shows that robotic have yet to be determined and the equivalent clinical outcome score to conventional. If you look at the long-term follow-up of 10 years, these two publications shows that robotic-assisted TKA does not improve long-term clinical or radiological outcomes. Larry Dorr in 2019, he said that robotic might not show significantly difference compared to the conventional when used by a high-volume experienced surgeons. It's useful for the low-volume or inexperienced surgeons. But Jay Parvizi said that high-volume surgeons who can avoid it do not need it, while low-volume surgeons who need it cannot avoid it. At last is the public perceptions. They said that prefer for robotic by a low-volume surgeons than a conventional by a high-volume surgeons, even if the results were comparable. Contrary to popular belief that the less or more experienced surgeons do not differ in their willingness to adopt new technology. So my conclusion is that all technologies need a long-term assessments and clinical appraisal. And what we need is a simple robotic system that will improve the patient's functional outcome, alignments, and the long-term satisfactions at no additional cost. The interpretations of literature is difficult for the physicians trying to decide if and when to implement new technology. Thank you very much for your attention.
Good afternoon, everyone, and welcome. Before I talk a little on navigation, I want to thank Nico Bhattipurama and Rami Sorial for inviting me to speak, and importantly for having the courage to keep this meeting going. Here's my declaration of interest, the most significant of which is I've been a dedicated navigator for 18 years. Computer-navigated total knee replacement was a quantum leap forward from the days of an eyeball and a plumb bob to towers with alignment rods, and then conventional intramedullary and extramedullary instruments. These conventional instruments were developed over several decades and were generally satisfactory but unlikely to improve. They are associated with non-ideal alignment, even in experienced hands. And 15 or so years back, our option was to accept that or to improve with other techniques. Along came computer navigation. How does navigation assist? Well, prior to bony resection, it'll tell us the alignment of the knee and, importantly, the fixed flexion deformity and the range. And that will alter the way the surgeon approaches the operation. It delineates the bony anatomy. During the case, it'll tell the size of the implant. It'll confirm the plane and depths of cuts, the final result, and even the kinematics of the joint. So at the end of the operation, you know that you've got the knee out straight because it's written up on the board, or you can be like this team from 15 or 20 years ago, just put your thumbs up and say, it looks pretty good. So a summary of why I use navigation. Well, the primary reasons are for its accuracy, particularly within the coronal plane. It's useful for sizing and balancing. It's reliable. It's safer for patients in that we don't have to put rods down the intramedullary canal, and it's useful for teaching. And it does give improvements in function, morbidity, costs, and survivorship. Now, there are many studies that demonstrate navigation is more accurate than conventional instrumentation. We also know that malalignment leads to failure earlier in the piece than if we maintain a good alignment. These papers are all relatively old with older polyethylene. But even now with our polyethylene that's sterilised in argon and our cross-linked polyethylene that we hope will last 20 to 30 years, if we leave the knee malaligned, we're more likely to see these better polys fail us. The axial plane remains a problem, and there's no doubt that conventional knee replacement is no better and no worse than navigation. Perhaps pre-op 3D imaging will help, or shape-match cutting blocks will be the answer to make the axial plane more reliable than it is with navigation. If we look at the issue of navigation and revision rates, the Australian National Joint Replacement Registry recently has demonstrated a difference between conventional and navigated total knee replacements in patients under the age of 65. This gold line represents the revision rate for patients under the age of 65 with conventional knee replacement, and the green is navigated. And there is a significant difference. There is also a difference in patients over the age of 65 who are navigated versus non-navigated, but the difference is small and it will take some years before there will be a difference demonstrated in the over 65. But the under 65 age group, navigation has a lower incidence. If we ask the question of whether there's a relationship between cumulative revision rate and outcome, the New Zealanders have looked at this with an analysis published by Alistair Rothwell some years ago. Gary Hooper, who's on our faculty, was part of this study. And what they demonstrated is that for every 1 unit decrease in the Oxford score, the risk of revision within 2 years increased by 9.7% for total hip replacement, 9.9% for total knee replacement, and 12% for unicompartmental knee replacements. So there is a relationship between cumulative revision rate and outcome. There are studies looking at outcomes of navigation versus conventional knee arthroplasty. Dutton and others in 2008 published an RCT and showed improved function and recovery in the navigated grip compared to conventional. There's an improved alignment with 92% within plus or minus 3 degrees in the navigated grip compared to 68% for conventional. Peter Chung in Melbourne, published in the Journal of Arthroplasty in 2009, demonstrated greater accuracy and alignment, and better function, better quality of life with navigation versus conventional. So what do robots add? Well, the first answer is a great deal of information about the anatomy, displayed to allow the surgeon to do the operation virtually before he cuts the bone. The gaps between the joint surfaces are visible, and some implant systems will make the cut for you. I put it to you that navigation will do most of this. So what do robots add? Well, they provide execution. They will help avoid cutting ligaments and other soft tissues that we don't want to damage. They resolve the issue of unstable cutting blocks and potentially will allow more precise and more accurate cuts. But what robots really add is data. From preoperative imaging and PROMs, which can be stored along with the engineer's plan, any changes made by the surgeon, and intraoperative landmark registration, and the final surgical plan. We can have the cuts achieved, can be stored, the implants utilised, the alignment and balance, and all that's in a computer compared to having it on a board where it has to be written down and stored. That stored data gives a vast amount of information of surgical details, and if we combine that to patient outcomes, there's a huge potential with artificial intelligence to identify the best surgical plans. So if you choose to use a robot, what are the requirements? Well, there's the cost, about $1.5 million, although this varies. There's the time to learn a new technique and potentially the learning curve of a new implant. There's added personnel in the operating room and a big machine that can get in the way. There's altered workflow and radiation exposure for the patient and added time. So in summary, navigation does almost all that we do with robotic surgery. There is the probability that the cuts are more accurate, but the real benefit will be when we close the loop between the imaging and surgical details on one hand and the outcome on the other. And we await and expect more evidence that a robot does a better job and gets a better outcome than NAV most of the time. Thanks very much.
Hi everyone, I'm Peter Chiu from Hong Kong, China. In the next 5 to 6 minutes, I will tell you why I do robotic arm assist total knee arthroplasty. These are my disclosures. Please note there may be conflict of interest due to my connection with Stryker Mako. I use robot because it helps my bone cuts and my handling of soft tissues. First, about bone cuts. Most surgeons do cemented total knee arthroplasty. However, some of them failed with time, and the main reason of revision was loosening. The risk of loosening was particularly high in young and active patients. The Australian National Joint Registry showed that cemented total knee arthroplasty for patients above 75 did very well, but the risk of revision increased 5 to 7 times in patients in their 50s and 60s. This paper from Mayo Clinic found that the risk of loosening of cemented tibial tray was doubled in heavy patients with BMI above 35. In these high-risk groups, how about the risk of cementless fixation? The early literature reported higher risk of early migration and loosening. This could be attributed to improper design with poor initial stability and early bone ingrowth technology. In the past few years, more and more surgeons, like myself, are converted to do cementless total knee arthroplasty because now we have advanced bone ingrowth technology, and the implants are now better designed with excellent initial stability. In addition to this, we also need the bone cuts to be precise and flat like a mirror. How can this be achieved? With these instruments, the surgeons relied on cutting jigs and used relatively thin saw blades. A flat bone surface cannot always be achieved. The cut surface may not be in intimate contact with the coating for bone ingrowth. With the Mako robot, there is no cutting jig and the saw blade is much thicker. We have been very happy with the cuts made by the Mako robot. Since January 2019, we have been using Mako to do cementless total knee arthroplasty in young, active, and heavy patients. We have not seen any migration or loosening of the components so far. Second is about the soft tissues. When we use manual instruments, we need to dissect the soft tissues away from the bone in order to prevent the oscillating saw from damaging important structures. This study from Belgium proved that the saw could cause damage to the capsule and ligaments irrespective of the experience of the surgeon. A big advantage of the Mako robot is its feature of haptic guidance. From the preoperative CT scan and the intraoperative registration, a tight boundary is created for each cut. The saw cannot overshoot. It will give you feedback and will even stop if you push with force. It is thus very friendly and safe for the soft tissues. I now dissect the soft tissues to a much lesser extent compared with before, and this may result in less postoperative pain and bleeding. The other important feature of Mako robot is to permit the surgeon to achieve a patient-specific alignment and balance the gaps medially and laterally, both in flexion and extension, to within 1 millimeter in most patients. This can be translated to better clinical outcomes. I will discuss this in a separate talk. In summary, I do robotic arm assist total knee arthroplasty because it helps me to achieve precise bone cuts that is important for cementless fixation. It also helps me to protect the soft tissues around the knee and to achieve the balance gaps in nearly every patient. I find it a very useful tool. Thank you.
Good afternoon, ladies and gentlemen. I'm Myung-Chul Lee from South Korea. Today, my topic is sensor devices for ligament balance in primary total arthroplasty. We have measured the soft tissue tension using gravity or various kinds of manual distractors before and after bone resection in doing total arthroplasty. However, these conventional devices depends on each surgeon's subjective assessment, and there is discrepancy in assessing soft tissue balance depending on the kind of distractors. Ortho sensor has several microelectric sensors on tibia tray, and it provides dynamic compartmental load and contact point on femoral component on the tibia tray through phalangeal motion. And they provide dynamic kinematic tracking to see the tibiofemoral articulation through full range of motion. We can make informed decisions regarding soft tissue balance with this real-time feedback. Clinical research has suggested the load to be ranged within a green zone from 5 to 40 pound-force, and the load difference between the medial and lateral compartment to be less than 15 pound-force. This is an example of well-balanced knee, good pressure in medial lateral compartment. Green line presents favorable rollback of femoral component. When the medial side is tight, you can see the high load on medial compartment. In this case, we can do medial release step by step. And finally, you can see the medial and lateral loads become within the acceptable range. At this moment, we can have question whether this technique, the sensor device, has any advantages over conventional methods. To answer this, I performed study in more than 100 TKAs. First, I did TKA with conventional modified gap technique. I have checked the ligament balance subjectively in extension and flexion position, and I did additional ligament release if I felt it is needed. Then, when I thought the balance is quite optimal, I did check the ligament balance with Ortho sensor. This is the result. In extension, only 47% of knees were well balanced. In mid-flexion, 61% of knees were balanced. In 90 degrees of knee flexion, only 60% of knees were balanced. And finally, in high flexion position, only 61% of knees were well balanced. Therefore, we can say that the result of ligament balance of conventional technique was not same with that with a sensor device. Then, can you say that this sensor technique can guarantee the better balance? In this study, they compared the results of Ortho sensors and gap technique done by a 30-year experienced surgeon, and they found that the sensor group showed a lower difference between medial and lateral compartments, and sensor provided objective feedback to improve balance. In another study, knees with Ortho sensor with measured resection technique were compared, and in this study, sensor group showed better medial to lateral force ratio. Based on several studies, we can say that the sensor technique can improve the ligament balance. Then, can you say that the sensor technique results in better outcome? There are several studies saying the advantages of TKAs with the sensor. In this study, a balanced group with sensor devices showed better clinical outcome. When you look at this study comparing various kinds of surgical technique, well-balanced group with sensor devices represents very high satisfaction rate. In summary, in TKA, subjective assessment of ligament tension may not be accurate in certain instances, and I think sensor devices provide instant feedback to perform ligament release and to improve ligament balance. And the balanced knee with sensor devices may result in improved outcome. However, still we need long-term follow-up at this moment. Thank you for your attention.
I would like to thank the organizers for inviting me for this presentation on innovation of implants and predictors for outcome. Actually, innovation is in the DNA of us surgeons. We want to improve outcome for our patients with new technology. But it's also about a perspective, our perspective, patient perspective, as well as the industry perspective. And for that matter, I would like to share with you a presentation of last week during the virtual EFORT meeting, where researchers compared papers from opinion leaders and looked at the impact and the level of evidence of these papers, which is actually very low. They usually produce only eminence or opinion-based papers. And when you looked at the research which have randomized controlled trials, large registry studies, good research, which has a higher scientific impact, and even more, the level of evidence is also higher. But the interesting thing is that the audience tend to believe the opinion leaders more. The reason, that's up to you. So be critical. I think that's my remark. When we look at innovation, we see that during the last 150 years, there's a huge increase in innovation for better our patients. The first ivory knee was implanted in 1850. The first total condylar knee, which was invented by Yamamoto in Japan in 72, and then Insel in 76, and then evolved, and with evidence, we even produced better knee implants. And then ultimately, we had excellent results for our patients. But in some cases, the innovation to even improve more led to disasters. Like, for example, the Oxinium knee, which is just 6 years ago, we had a disaster with high revision rates. Do we have to stop innovation? No. We still need innovation. These are data from a paper we published from the Dutch Orthoplasty Registry, and we can see that in the younger population, we saw less good results in the males younger than 6 years compared to the older ones, which had a revision rate which was about 3 times higher than in the younger population. And especially the PS knee were performing worse, far worse than the CR knee implants. So we need innovation for the better outcome. And we look at the registry, 11-year data, we see that the best performing implants, the PFC and the AGC, which are being done in about 80,000 knees, are far more superior compared to the Journey knee and the OptiTrack, which have revision rates which are about 3 times higher. But still, 7,000 patients had these less optimal implants. So actually, the downside of registries is that they have only historic data, and we should prevent not only after 8 years that implants should be taken off the market, but already at 1 year. And when we have early results, then we have less patients exposed to mediocre implants. And for that reason, we need for new implants or new surgical techniques, we need RSA or micromotion studies, either with RSA or CT scans. Can we use this RSA technique also for new implants or for new techniques? Yes. We can even challenge concepts which are around. These concepts are likely to be valid, like the constitutional varus concept. It is likely, but we can also evaluate this with RSA. There's a study which was published this year by our group, and we showed that this concept of constitutional varus in the cemented knee and in the cementless knee had no effect. So in case there was a pre-op varus or even valgus, the migration was the same. However, if there was a post-op varus in the cementless knee, we saw higher migration, which was not affected in the cemented knee. So that's interesting. So the constitutional varus concept may seem logical, but is not proven by evidence. Another concept is the use of robotics is better for our patients. There's a very interesting study that compared robotics in a very small group, 15 patients in each group, and they showed that the patients who had robotics had a less inflammatory response compared to the conventional ones. But is this due to the robotics or due to the more subtle, gentle soft tissue handling, which is probably done by the robotics? Because when you do gentle releases, gentle bone cuts, that may also have an effect irrespective of the robotics. Even more interesting is that when robotics was used, also a paper of 2021, the ligament balancing was better. However, the pain relief was not associated with the better balancing, and also the expectation of patients. So it's more complex than we can think. We need new technology. We need to improve outcome. However, how the patient perceives this is a different ballgame. Different patients will have different expectations, have different cultural backgrounds. And the major determinant for outcome for patients is optimism and pessimism and expectation, but also the credibility of that surgeon, the credibility of that surgical procedure for them. So in the end, it's more about we need technology, but also we need to take into account the perceived outcome by patients. But we also need to take into account the way we as surgeons evaluate clinical evidence, level 1 and 2 evidence for the better of our patients. So in the end, we should make our decisions on clinical evidence and have excellent surgical skills to prevent disasters of patients. In the end, our patients should not become fashion victims. That's not the goal. Thank you.
Welcome at Digital APAS 2021. My name is Emmanuel Timpon from Brussels, Belgium, and I will present to you patient-specific total knee. I have a relevant disclosure. I consult and design for conformists which products I will discuss in this presentation. We know that there is high anatomic variability within human diversity. And this has been studied by several authors. The distal condylar angle is highly variable. If we look at the range of variability, we see that this can be within 7 degrees of varus and 16 degrees of valgus for the individual patient. What is the possible impact of this high variability of the distal femoral geometry on total knee? Let's look first at the distal condylar offset. We see that the medial side is more prone, more distal than the lateral side. And this difference in distal condylar offset will on a mean be 1.55 millimeter, which can be minimal 0.02 and maximum 5.96. The same change and difference in geometry can be observed on the posterior condylar offset. Here we see that the medial side is more posterior than the lateral side, and the mean difference is 2.9 millimeter with a minimum of 0.23 and a maximum of 8.11 millimeters. When we look at the histogram of posterior condylar offset, we see that 80% of patients have a PCO, so a difference of more than 2 millimeters on the posterior side. Finally, we know that the native femur has 3 J-curves, one on the medial condyle, one on the lateral condyle, and one that represents the trochlea. If we want to reconstruct this within a prosthetic implant, we need to try to copy the distal femur. So what has been done in this patient-specific design that I have to discuss today, we see 3 individual J-curves. We see respect for the distal condylar offset, respect for the posterior condylar offset. The AP and ML aspect ratio is respected, so there is no undersizing with over-resection of the posterior condyles, for example, that can lead to flexion instability. Furthermore, the width of the femur is anatomic, so there is no soft tissue impingement, and the shape of posterior side condylar anatomy is respecting the anatomy of the human knee with, for example, a small recession for the popliteal tendon. We could call this, in the discussion of all the new types of alignment, a femur-driven kinematic type of design. If we want to obtain the same with an off-the-shelf symmetrical implant, like you can see on the upper figure, you notice that we have to implant this type of design obliquely, and that if we want to respect the posterior condylar offset obliquity, we have to have some anterolateral impingement with an implant that is more prone on that side. On the figure underneath, you can see that you can have the anterior side parallel to the transepicondylar axis, with still respecting the posterior side with an asymmetrical or patient-specific implant. Let's look now at the tibia to see what the options are there. We know that there is tibial asymmetry with especially the medial side, which is bigger on the AP and ML side, as you can see on both of these studies that have analyzed these anatomical features. If we have a symmetrical implant, we need to compromise between proper rotation and maximum tibial coverage. And this is of course possible in the hands of an experienced surgeon, but it will always be compromise. And as one study has shown, if you look at optimal rotation and optimal coverage, this is only possible for about 30% of our patients. Therefore, it could be interesting to have individual rotation. As you see here with this type of design that I discussed today, there is a choice to align the implant with COPS rotational angle and the design of different medial and lateral sides. So an asymmetrical implant allows you to have optimal coverage and the rotational axis that has been proposed. There is still a little bit of freedom in the hands of the surgeon for about 5% of coverage and 5% of rotation, depending on his alignment philosophy. Now let's look at this important study by McDessie, who classified the coronal plane alignment of the human knee. You can see that both in non-osteoarthritic and osteoarthritic knees, most have their apex distally. And if you want to reconstruct this with a knee design as this one, an asymmetrical polyethylene, as you can see here, the lateral size is higher than the medial side. You are in this group of joint line obliquity patients. So what is possible? The cuts are perpendicular to the mechanical axis, which makes it easier for load bearing and eventual osteoporotic patients. And the DCO obliquity is respected by a slightly higher lateral poly, which adds that difference. With mechanically aligned cuts, respect for individual anatomy, and restoration of joint line obliquity, we call a patient-specific knee an epiphyseal reconstruction with a volumetric replacement, which allows soft tissue tension restoration with MCL isometry. I thank you for your attention.
Right. Well, we thank you to the various speakers for the excellent presentations. I'm not seeing any questions on the Slido, so could I please encourage the audience tuning in to send in their questions now, such that the panel would address your questions. Maybe I could just start off with a question for the panel. We have heard all the various expert speakers talk about the new technologies, the new tools of navigation, sensors, robotics, and patient-specific implants. Let's say if we talk about the low-volume Asian-Pacific surgeon out here doing knee replacements, what is the role of this new technology for them?
Will it help them improve their surgery, have less outliers, do better work, less mistakes? Or do you think it will just add another layer of additional technical difficulty for these patients, these surgeons, and just make life harder for them? Maybe some advice from the expert panel to people thinking of adopting new technologies.
I'm happy to start by answering that question, Prof. Lowe. I do think that use of a computer is helpful for the low volume surgeon, because that surgeon, he or she, will have a good understanding of what problems are with that knee from a range of motion point of view at the beginning of the procedure when everything's registered. And they'll also have an answer at the end of the procedure as to what they've achieved in terms of range of motion and stability. So I think Nico's comment that robots, and I guess any technology, is not needed by those who can afford it, and those who do need it can't afford it, is probably fairly apt.
Yeah. Yes, Miles, and thank you for the questions. It is right what you say. This publication is from Larry Dorr about a couple of months before he passed away. It's very good. He published in the Core Insight that the surgeon actually who might need that, the low volume surgeons who might need the most sophisticated instrumentation, but they cannot afford it, right? So I think back again. And it has to be, as a low volume surgeons to adapt this new technology, especially if you look at the publications. When I asked Leopold just now, that 91% who publish on this robotic or instrumentations, they have a conflict of interest. For example, now, how many of us here? So I saw, Miles, you are also a conflict of interest from Smith Nephew. Rob Nelson is a lot of a company, and Chung Lee also So and also Nainung, right? So it's always I don't know. It is a norm of the buyers, especially for the young surgeons. So maybe Rob, you can say some words.
Yeah, I think first of all, no conflict of interest doesn't exist. Everybody is biased. I'm biased because I'm from Leiden. We're the best center in the world, of course. I'm joking, but I think the major we are very arrogant in Leiden. But I think the major thing is, and that's especially for low volume surgeons, is that they need to be educated more. So you can think when people cannot afford it, that there are centers where they can just practice in cadaver to use with robotic. They get feedback. So they should not buy it. Well, of course, that's good for the industry. But I think it's more in better education, because you get feedback, you get tactile feedback, and that makes you do the next surgery better. But I might also think the big question mark is, are those surgeons have to be trained better? And perhaps the navigation or the robotics can help in this. I showed you the paper from this year's. I can show you tons of papers. The papers of this year didn't really show an advantage of this robotics when you look hardcore evidence, as was as a paper of the EFORT last week. I showed you. The interesting thing is, again, why do they believe keynote or opinion-based leaders and not evidence? That's very interesting.
Rob, yeah. Can I ask you a question, and perhaps Mayung as well? New technology has a cost. A robot has a cost. And if we amortize the cost of a robot over the number of cases before it's eventually discarded and a new one's purchased, what does it cost to use a robot? And Mayung, what does it cost to use the sensors that you showed? I mean, and can everyone afford that? Perhaps you could both answer that question.
So I'm going to answer it.
Yes. Oh, you can answer it.
Okay, well.
And Mayung, I think, too. Please.
So the Mako system in the Netherlands is 1.1 million euros to use. You need a whole setup. And of course, then the big question is whether it's very cost effective. Looking at the revision rate. The revision rate in an arthroplasty register in the Netherlands, we do about 40,000 knees on an annual basis. And the revision rate is 1.2% on a year. And the completeness of our registry is 99%. So it's like the Australian. And we're the second biggest already after Australia. So then you wonder. So I think it's more in education. In the Netherlands, it's easy. We are a small country. People are very well trained. We only have, I think, 4 maker systems around in the Netherlands. So again, my point is not every system, not every hospital needs it, but it depends on the education. So for training purposes and for research purposes, it is very interesting. The big question is, should you invest this to educate your surgeons better? That's a big question mark. At least from evidence, and that's RSA, micromotion, there is no advantage. The feedback might be that you get better CT data for your PROMS evaluation. But that's also a big question mark. So they can use AI things intraoperatively for better prediction.
Thank you. Mayung, what's the cost of your device?
Yeah, that fully can cost may be a big problem, but it may not be a problem. I think the sensor devices can help, especially young surgeons, when they try to compare their subjective balance with the objective information from sensor devices, then they can understand what is the ideal balance, what is the ideal subjective balance. And then I think we don't need to use this passive device for a long time, but with this device we can get very good information, and this I believe this is very useful for young surgeons and low volume surgeons as well.
Prof. Lowe, have you got any other questions of the panel?
Well, there's one question on the slide though. I think it comes from India, and it says, in this age of new technologies, what is the role of finger palpation of the MCL tension to a soft tissue balance? I guess, is there still a role for the feel and fit kind of traditional way of doing things?
I'm sorry, I cannot understand the question.
Well, the question on the Slido from India wants to know, is there still a role for just the surgeon's feel of the soft tissue tensioning, or should all knee replacement surgeries start to have the use of tensors and navigations and so forth?
And before we discuss this problem, I believe the big problem is we don't know what is the ideal ligament balance in doing total osteoplasty. Exactly equal balance medially, laterally is ideal, or a slight tight gap on medial side ideal. Then how tight it should be, we don't know. Then what is the ideal tension of PCL in CLD? We don't know. But that's the big problem. I believe this is the things what you need to break through in estimating, or before we're doing it, the usefulness of devices, robotics, something.
Thank you.
I think I fully agree with Prof. Lee, because in essence, it's when you have your normal knee, it's convex, two balls and balls on the lateral side, and convex and concave on the medial side. So what are we really doing? So actually, what he is saying is that that's the reality. We do not really know how to release. We know what we do, but it's really mimicking nature. It's always a compromise to nature. I think that's probably the best answer.
Yeah.
Nico, can I ask you a question? You've been very skeptical about any of the new technologies that are available, from pressure sensors to navigation to the use of robots. What are you doing now, and what do you think you'll be doing in 5 years' time?
It's a very good question, Miles. As you know, I'm not skeptical, but I have to show you that what is the end result. As you know, I was one of the first who used the CAS in Asia Pacific. This was back in 2003, and then I published also with Rob on this the ABN, accelerometer-based navigations. And by the end result, we look at systemic meta-analysis, and we saw there's no much difference. The same as robotic, and I'm part of a robotic designer. But then again, it is like, we are like surgeons. We like something new. We like something, as a surgeons. But then if you ask again, what is the end result? It's still a long way to go. But the way, if you ask me now, what is what I have to do, would like to do in another next 5 years, I think robotic will be good, but depends on. I have to be very honest to the patient. As you know, if you look at the latest publication from Lindell Sage in 2021 March. They asked the perceptions of the patients on what they thought on robotic for the replacements. They thought like the old Robodoc, that the machine operate for you. You understand what I mean, Miles? So it's again, and me also, if I have like something like that, maybe I don't know, another 5 years, maybe I'm going to use that or not.
Myung, can I ask where you will be in 5 years' time with your total knee replacements?
Me?
Yes.
I have experience with navigation system, robotics, as well as a PSI. But at this moment, what's the point that I have to say is that each system has their own advantages and disadvantages. The point, which is very important things to us, is the disadvantages and limitation of this system. What's the limitation of navigation? What's the limitation of robotics nowadays? We need to improve these technologies. I think these technologies will give us huge advantages to us in the future, but right now we need to summarize the disadvantages and the problems of these systems nowadays, and we need to improve the system. So this is my basic stance.
And what about you, Rob? Where will you be in 5 years' time?
5 years' time, I think. In 5 years' time, I think the biggest advantage that we have in the better indication. I showed you already there's a big discrepancy between what we achieve during surgery and how the patient perception is. I think we are more than just technicians. We are not cardiac surgeons or neurosurgeons, which are technicians. And the indications are very important. So with AI, with all the radiographs incorporated in national registries, we have this project in Europe now. They will give also better outputs of how the performances of knees. And then I think so, involving AI with hundreds of thousands of radiographs, pre-op, post-op, and see what's happening. And then with robotics, I think that will happen. Only in very small, handheld, small devices. The make was too big. That doesn't work. So, and I think the public will demand from us that we are better trained. It's already happening in the Netherlands. You cannot use your new device in Young Hospital. I'm one of the advocates of this. It's a prospective risk analysis. So no surgeon is allowed to do the surgery when he did not train before. And that's happening a lot in Europe.
Okay, thanks, Rob. We're out of time. Thank you very much to all the speakers and to the panel and my co-moderator, Professor Lowe from Singapore. I'm now going to hand over to Parag, who's going to moderate the debate. Thanks, everyone. Good afternoon.
Thanks, Miles. That was an interesting session. Thank you. Very well. A lot of useful information. From there, we move gears and we now move on to a very, very hot and interesting debate. And that debate is going to be on TKA, the current gold standard, cementless or cemented. You know, the take is that cementless is the gold standard. And we have Professor Gary Hooper, who is going to speak for it. And we have none other than Wasan from Malaysia, who is going to speak against it. So first, let me introduce to you our speaker, Gary Hooper. And he is from New Zealand. He has been doing uncemented replacements for quite a while. He is at the Christchurch Hospital, the University of Cottage, and I've known him for a long time. Excellent surgeon, a great speaker, and we look forward to hearing Professor Gary Hooper to tell us why he thinks cementless is gold standard. And we have Dr. Bharat Modi also co-moderating the session with me. So over to Gary Hooper to convince us why cementless is the gold standard. It's all yours.
Greetings from Christchurch, New Zealand. I'm Gary Hooper, and Rami has selected me to start this debate in the affirmative, confirming that cementless total knee replacement is in fact the gold standard. I always find these types of debates difficult, and this one will be particularly difficult doing it remotely. The reason they are difficult is that this is not a normal audience of average IQ. You are highly intelligent, skillful surgeons with experience from years of successful outcomes with many happy patients. Your success is driven by your pragmatic common sense developed from these outcomes. So I'd like to share with you my experience over 40 years of arthroplasty and hopefully convince you that cementless knee replacement is the pathway to the future. I could start by telling you that the major reason for failure of cemented knee replacement is aseptic loosening. Or I could tell you about how the incidence of femoral and tibial loosening has not changed over 22 years, with over 30% failing due to either femoral or tibial loosening, despite over 80% of the implants being cemented. I could tell you that the initial problem with first-generation cementless replacement was not understanding the different forces across the knee compared to the hip. The high shear force and torsional forces across the tibial bone interface resulted in early failure, secondary to the lack of primary stability. The subsequent use of screws only increased the failure rate with widespread abandonment of cementless tibia. I could tell you that better biomechanically designed tibial trays with improved primary fixation with multiple pegs and semi-coated stems has resulted in over 15 years of successful implantation with tibial loosening rates less than cemented knees. As orthopaedic surgeons at the forefront of innovation, I could tell you about the development of 3D printed implants, customized for individual use with the potential to be seeded with stem cells to improve bone regeneration. Or of how periprosthetic infection, particularly in males less than 55 years, has increased significantly in the last 10 years, with increasing organisms produce a protective biofilm. And how we have shown in the laboratory that the development of smart implants with an increased titanium surface with multiple microchannels is protective against infections. And when these channels are combined with M10 inhibitors, they inhibit biofilm production at the same time as promoting bone regeneration. Of course, these smart implants are only effective in the cementless mode. I could tell you about the significant impact hospitals have on global warming, with over 35% of carbon waste coming from operating rooms, and how cemented implants generate significantly more waste and when coupled with the increased operative time and use of anesthetic gases, they are more environmentally unfriendly than cementless knees. I could tell you of how the current studies are biased towards cemented knee replacements, with most long-term outcomes involving first-generation knees, and the largest meta-analysis having only 755 patients. But instead, I'll tell you of my experience with cementless knee replacement, which started in 2007 when I finished reviewing our 15-year follow-up of the LCS knee. I found that the cementless knees had the best radiological results. And from that point on, I changed to third-generation cementless implants in all patients of all ages. I'd like to share these results by comparing them to a matched group of patients who had a cemented arthroplasty with at least 5 years functional and survival outcomes. This is the largest study comparing 763 cementless knees with the same number of matched cemented knee replacements. Cementless knee replacements better utilised operating room time, being on an average 18 minutes quicker than cemented, and at 5 years were almost twice as many revisions in the cemented group. 5 cementless knees were revised for aseptic loosening compared to 8 for the cemented variety. Although revision rates are low in both groups, the fewer infected knees in the cementless group is encouraging. When comparing functional outcomes with the Oxford Knee Score and the WOMAC, the overall improvement was the same. And so, my colleagues, I would appeal to your surgical pragmatism and ask, why would you not use a cementless total knee replacement? When the survival rates are better, the operative time is decreased, they can be used as smart implants to combat infection, and they have a smaller carbon footprint, all without sacrificing functional outcomes. Thank you.
Case of why cementless is the gold standard. We now move to Vasan Sundurdai. Vasan has been a good friend and has been associated with APAS for a long time. He comes from Ipoh at the Pantai Hospital from Malaysia and has been doing cemented knee replacements all along. So let us hear from Dr. Vasan why he thinks that cementless TKA is not the gold standard. Over to you, Vasan.
Thank you, Parag, and thank you very much, Gary. I think Gary is a little bit. You have disappointed me, Gary, because I think after listening to me, you probably get into cemented as opposed to cementless. Anyway, thank you, Nick, and thank you, Rami, for putting this together. But with that, I'll quickly come to the point of cemented TKA. This is like, you're pitting David against Goliath, So I take myself as David and Gary as Goliath because Gary is a big figure in arthroplasty. And as you can see, that's me trying to get around Gary, all right? But I will win, Gary. I will succeed. Can I have the next slide, please? Now, we'll quickly go through the literature. Now, Gary, he very rightly said just now, that the literature supports cemented. There's a bias towards cemented. And as you can see, can I have the next slide? This is some of the literatures that I've just taken out at random. And these are the latest literatures from the bone joint journals. And you can see they all talk the same language, that the cementless TKA migrated more than the cemented TKA in the first 2-year period. Hence, the failure rates are high. The aseptic loosenings are high. And this is a very important, peculiar study from the Dutch study, almost 200,000 patients. And they talk about the tibial stem and the femoral stem loosening more towards cementless as opposed to cemented stem. Now, with that, next slide, please. With that, I would like to differ from the topic. Why differ from the gold standard? To me, the gold standard is still with cementing. Now, the longevity of TKA is dependent, among other factors, on the cementing techniques. Now, over a period of time, over the last 60 years of cementing, we have changed the way of cementing and we have improved the techniques of cementing. And this is a Herculean task to talk against Gary. But nevertheless, I think it's a worthy task of me, David. Now, normally, as we can see, in my practice in the last 25 years as an arthroplasty surgeon, I've noticed that majority of my patients are in the 5th decade onwards. But, next slide, please. But aseptic loosening is something that is bothering all of us because it remains the most common indication for revision in total knee arthroplasty. Although there's, despite excellent survivorship and clinical outcomes in TKR, component fixation still remains the long-term concern. Next slide, please. Now, the number of young active patients undergoing TKA and TKR is definitely increasing, especially in this current growing world. where everybody wants to live without pain. Now, consequently, the average life expectancy of these patients undergoing TKA is also increasing. Now, I've done TKRs for the last 25 years, and my revision rate for aseptic loosening is about 0.01%. Next slide, please. Now, why is this trend changing? Younger patients seeking TKA because of pain? Cemented implant is a subject to shear force. Of course, people talk about loosening is possible because of demanding activities. Yes, it is demanding, but as you can see, that majority of our patients that we do TKR or TKA is in the 5th decade onwards, where their life is literally not so demanding as the younger patients. Next slide, please. Now, a little bit on history. Now, before I start on history, that slide that that picture of the X-ray is a patient of mine who had a motor vehicle accident 3 years ago. I did this TKR on her. I did a bilateral TKR on her 7, 8 years ago. And, it was a high velocity accident, a motor vehicle accident. The femur broke, but the components are intact or were intact. And now she is already back walking with an implant in situ. Now, coming back a little bit on history, Sir John Chandy taught us the importance of cement in joint replacement. And I don't think any of us, history always is the best. You have to go back, please. Sorry. All right.
Vasan, you have 1 minute more. Vasan, 1 minute more.
All right. Next slide, please. Now, we know the properties of cement. Next slide. And I think, next slide, the most important thing is the way we mix them, we prepare them, and we deliver them. Next slide. And I think the mixing, waiting, working, and setting time is the most important thing in getting a good cemented knee. Next slide, please. Now, as you know, the cemented processes, this is what I would normally do. Many of us do this. We literally, we make small micro holes, or we drill with a 1.5 millimeter drill and get them grouting. As you can see in the slide, we have that cement grouting deeply into the joint and holding, because most of our patients are also osteoporotic, not just osteoarthritic, but also osteoporotic. Next slide, please. Now, the PMMA is a wonderful cement that has come. We have different, next slide, please. We have many people speaking about, many authors have spoken, Gravius and all, Zhang and all, and Terry and all have spoken about the cementing technique and how cement has actually helped with TKR and also the longevity of TKR. Next slide. Now, the other important thing is the cost. The cost of TKA in a cemented TKA is about 30% cheaper in the place where I come from and in the many places around the world. It's a third world countries, they benefit a lot and it's easily available. And that picture that I just put up will speak 1,000 words. That's a 76-year-old lady, a patient of mine, bilateral TKR done, good range of motion, and she's happy. Next slide.
In 10 seconds.
Correct. With that, I'd like to thank you and let you take back this message of these 2 slides that I've put up. Look at how strong the implants are in spite of a motor vehicle accident. Next slide. Gary, this is your last attempt. Thank you.
So thank you very much. That was a good exposition of trying to prove why cementless is not the gold standard. Gary, you have 30 seconds to quickly rebuttal. You want to say anything?
So I'd like to say several things. The first thing I'd like to say is that I've lost quite a bit of weight since that photograph was taken. So thank you, Gussie. The major issue that I'd like to point out to you, though, is that the continued problem with knee replacement and early revision and late revision and knee replacement is aseptic loosening. That is despite at least 80% of the knees being cemented. And so I would put it to you that that is a failing. In the hands of a superb surgeon like yourself, of course, you don't get aseptic loosening. But in every other surgeon, yes, we do. And that happens over the course of time. And that's the result of the failed concept of cemented knee replacement.
Okay, so I think it's been an excellent debate. I have one question for each of you. First to Gary. In cases of osteoporosis, in the Asian countries, we do see a lot of osteoporosis. In that particular case, do you do a cemented then, or would you do a hybrid? Or how do you tackle osteoporosis? Because I think that's one of the contraindications for cemented. Uncemented, I mean, sorry. Yeah.
So in my hands, I do it in all comers. So even in the 90-year-old osteopenic female, they get an uncemented knee replacement. And uncemented osteopenia doesn't limit the ability for the bone to adhere to the implant or to ingrow to the implant. And so I still do that in those older patients, yes. And that's the results as I have presented them. Yep.
Okay, so osteoporosis or osteopenia is not a major concern. You've seen that it fits well. So, Vasan, the question to you now is, don't use uncemented at all? Is it just because of the cost, or is it some other issue why you don't use uncemented?
Thank you, Parag. Good question. Now, I only use cemented in TKR, but I do uncemented in hips. So, but we will not get into that. That's a different argument altogether. Now, I think over the last 25 years, I'm not as old as Gary. I'm way younger. But probably in time, I may change. But for now, I've got good results with cemented, number one. And the key, to me, the key take-home message is a good cementing technique. That's something that I have learned over the years. A good cementing technique. I'm sure people like Rami, yourself, Chung and Bharat and all these people will agree with me that good cementing technique is the key for a good TKR. And I weight bear my patients on day one post-op, and they start walking on day one. I have no issues with the aseptic loosening.
Perfect.
So that's
perfect. So to conclude, I think there is no clear mandate. I don't think we can have a clear winner here, whether uncemented is the way to go or cemented. So as a moderator, I would like to say both win. But can we have a vote on this? We have Theopont here. Anything you want to say, yes or no? So we'll conclude the session to say that with better material, with better trabecular pattern, integration is good. Cost is an issue. Cementless will come in due course of time. Thank you very much, Vasan. Thank you very much, Gary.
Thank you, Parag. Stay safe. Thank you very much, guys.
Bye-bye.
Bye.
Thanks,
Gary.
I'll continue losing weight.
Our surgery stage live.
Great. Thanks very much. Are we on now? Yep. Great. Welcome to our second case. My name's Simon Coffey. I've got the team, got Carly scrubbing, Raj and Amit assisting, and Paul and Di on the anaesthetic team. Today we're going to run through an Apex total knee using technology, the Omnibot spacer technology, which is a variation on a number of different themes, but essentially uses active spacer technology to plan our femoral cuts and our tibial cuts. It's a little bit different to the case that Rami showed earlier, but again, it's largely doing similar things, just with different technology. The plan for this case is to use an inverse kinematic alignment protocol, and we can talk a little bit about that as we go. There's a few slides that we might share just to project the case. Gary or Emmanuel, I'm not sure who's on there. You want to just
Emmanuel is on now.
Oh, great. Emmanuel, welcome.
Yeah, hi, Simon.
Nice to see you. So we're going to get started.
Okay, so I will show the case that Simon sent to me. I will share my screen.
Whilst you're doing that, Emmanuel, I'm going to just start opening the knee and doing the exposure.
All right. So normally you should see the screen now. Can you see it, Gary or Barrett?
Yes, yes.
Yeah. So this is the case Simon will show us today. This is his presentation. So it's an 81-year-old female, rheumatoid arthritis patient, well controlled. You can see her medication there. She has a slight valgus, but we will show you, of course, the x-rays. She has a fixed flexion deformity of 10 degrees and a flexion of 100. Her Oxford knee score is 20. She has a history of right total hip, left total hip, and right total knee, where you can see that she has an Oxford knee score of 44. So I think it's a happy patient with a good range of motion. These are the x-rays. So we can see that this is real tricompartmental arthritis. So no discussion about the indication. Here we see the full leg. There is so on the right side where she was already operated in the past, she has some slight remaining valgus, about 4 degrees. On the left side, which is Simon doing now, she has 6 degrees. The distal femoral valgus angle is 1 on the to be operated side, MPTA 3, and the slope is 5 degrees as measured on an X-ray. So the plan will be to perform inverted kinematic alignment knee with robotics. So it will be with the Omnibot system and with the Apex total knee. So this is a plan of inverse kinematic alignment. It's a new philosophy which comes also from Belgium, as myself. From Dr. Winock de Grave, who is one of our young colleagues. And the plan is to have equal resections on the tibial side, on medial and lateral, and then to have parallel cuts in extension, thanks to the Omnibot robotic system in this case. And then in flexion, you will see that this is more a balancer-based system. And in this case, there will be a special balancer, as I will show in the video that Simon has sent us. So it's still with some external rotation on the femur. The knee will be an Apex knee system. And as you can see, there is an implant which has 9 millimeter distally and 11 millimeter posteriorly. And Simon will have several options of poly thickness, 1 millimeter increments at the start, and different types of constraint with an asymmetric tibial implant. So this is a very short video that Simon wanted to show about the balance bot. So this is the balancer system that he will be using during the surgery. You can see that it individually lifts on the lateral and medial side, and you can use it going through the range of motion, extension to flexion, and then it gives you the information with a force, with a standard force which is applied thanks to the system. And you can also use it. You can also use it for your soft tissue balancing or checking what your balancing did. So here you see how it would look like for a perfect case, which is probably what Simon is going to show us. So finally, we have a screen on a femoral planning. So this will be the data that we will be able to compare during the surgery. So for this case, I'm joined by two giants of surgery. So we have Gary Hooper from New Zealand and Bharat Modi from India. They will be animating the discussion during the live surgery. And we can, of course, get some questions from all of you through Slido. So looking forward to this and going back live to Simon.
Great. Thanks very much, Emmanuel. That's a lovely introduction. So a couple of points to make. We've just finished the exposure, but for those of you who are familiar with navigation, pin positioning for this particular technology is a little bit more important. Where you might be used to having your pins either inside the wound or in the tibia, you'll probably be used to having the pin more on the sort of anteromedial side of the tibia. For this technology, you really do need to have the pins on the medial side of the tibia position. And I positioned those just a moment ago. So that the navigation the arrays can be out of the way of the balance spot, and you'll see what I'm talking about as we proceed. So once we've done that, we do the exposure, get the bracket on to attach then the array, and we can do that. We'll put those others on. The next step is actually to position our femoral pins. And what the femoral pins do, there's two roles. One is to support the robot, which will cut the end of the femur, and the other is to support the femoral array. So a little bit fiddly at times, but once you get used to it, it's really fairly straightforward. So we position the rake retractor just inside the medial retinaculum, find the medial epicondyle and just define it with our diathermy. So our positioner will go just anterior to that. So we use this device which allows us to position the femoral arrays in a fairly predictable way. But the bigger the patient, the more difficult it can be. Just have an osteotome. Sometimes you just got to get rid of the osteophyte off the anterior part of the femur if there is one, and that gets that out of the way. So important to get this positioned well. Yep. Next. Yep. Next. And second pin. Okay. So once those pins are placed, the bracket needs to be just tightened, or the holder needs to be tightened so that there's no movement between the pins and the arrays. Then we position the femoral array on the femoral guide. Make sure that's secure. And then we position the tibial array on the tibial end. We make sure that's secure. And again, once we've positioned those, we need to make sure that the arrays are not going to be obstructed by the balance spot. Just show you for a moment. The balance spot will eventually be going in this position, so we need to have the arrays out of the way. Thanks. So once we've done that, it's now time for registration. So we've got to make sure that all the pins are stable, and then we just go through a registration process as with any other navigation system. So thanks, James. Yep. So this just takes, again, we're finding the center of rotation of the femoral head, and the system is finding those points to define that central position. Yep. Medial malleolus. Yep. And lateral malleolus. And again. Yep. Yeah, we're just not seeing it. Sec. Just got to make sure that the trackers are picked up. Just not seeing that. Pinned. Not seeing it. One sec. We'll just reposition.
I do reject you.
It's just not seeing that. Just one sec. Just one sec. Just seeing it there. So just seeing it there. So let's persist. Let's persist. Yep, got it there. Yep, good. This is the center of the tibial ACL footprint, medial third of the patellar tendon. The next is to the medial tibia, just holding there, thanks. Now, it's important when you're mapping the medial and lateral sides of the tibia to know exactly where you've mapped, because that does have impact on your planning. So I'm looking at the cartilage wear here, and it's worn, but it's not completely down to bone, but we go in the mid-coronal position. Yep. On the lateral side, we want to see where we're going here because, again, it's important to know where you're mapping in relationship to loss of cartilage. So I'm looking to map to where the tide mark is here, not necessarily the lowest point. So it's the junction between where there's any cartilage and the bone, and that's relevant when it comes to our planning. So, yep, let's take that. We'll measure, this is a slope measurement, yep. From front to back, yep. And then there's a validation point that we put on the tibial array just in case something moves during the case, we know that it has moved. Next, we move on to femoral registration. Yep. Yep. And yep. So center of the distal femur. Yep. And white side line. Yep. Medial epicondyle. Again, I don't worry too much about medial epicondyle and lateral epicondyle being perfect. Yep. Similar to what Rami was talking about in his earlier case. We register it, but it's not relevant. Or not always relevant. So here we have posterior condyle. We're mapping it. Yep. And lateral condyle. Yep.
So Simon, on the posterior side, you're taking the cartilage part, not the tide mark.
I'm taking the cartilage. Yeah. Yeah. On the posterior, I'm taking whatever it is that's here. Yep. Distal femur on the medial side. Yep. And lateral side. This is we're taking the medial side of the tibia, of the distal femur. It helps with sizing. Yep. Sizing and also positioning and validation of the axis, the mechanical axis. Yep. And then we take the anterior, we map then the anterior distal femur, making sure we've got rid of the synovial layer there. Yep. So far, this is all just standard navigation registration process. Yep. So we just validate that we're in the right position. That the technology will tell us if we're more than half a mil or out, and that looks all good. So we've completed our registration. Now the software will give us information about the underlying kinematics. So firstly, I want to check to see what my level of correctability and minimum and maximum alignments are. And so this lady corrects almost to neutral with a few degrees of flexion, but her resting position is 3 degrees of valgus and 9 degrees of flexion. We then take her through a range of motion. Now, and that then gives us our initial alignment and kinematic curve. She hasn't got a lot of deformity, as you can see on a preoperative x-rays, but nevertheless, she measures, what did we say, 6 degrees of valgus, at least on those preoperative imaging. Now, there's often a difference between what you might see on preoperative imaging and what you actually find on the software. And I must say, I'm much more comfortable going with what the software tells me than what the preoperative imaging does, because there's rotational variation, there's measurement error, there's also a lot of variable things that can happen if you're just looking at the x-rays. So whilst I do look at the x-rays and I use them to help with planning, I'm not driven by the x-rays.
There is also a difference between load-bearing and non-load-bearing, I think, in the valgus knee side.
Yeah. And consistency of measurement and consistency of positioning. And so any technology that utilizes the preoperative imaging, especially standard x-rays, you have to be aware of its limitations. So next, we're now onto the planning screen, okay? And this is an important screen. So in the normal circumstance, for a kinematic alignment, you would plan for, because we're putting 10 millimeters back, you want to take 10 millimeters total from the medial or lateral side, whichever is the least worn. So in this case, the tibia is the least worn, but because she's valgus and she's got a little bit of wear, we're going to start with 8 millimeters on the tibial side. So are we seeing that planning screen there? So yeah, we're going to resect 8 millimeters from the tibial side.
You mean from the medial side?
On the medial tibial side, correct. Because it's the least worn. Because there is some wear, and she's also valgus, and most valgus knees I will tend to under-resect a little bit on the tibial side. On the lateral side, we have a decision to make about where we put that alignment. The resection, if we assume that she's got complete cartilage wear on that lateral side, which we do, she's got complete lateral wear on the lateral side, then that accounts for at least 3 millimeters of wear. So if we say 3 less 10 is 7, then we would say, well, it's 7 millimeters. But in this case, because we're planning for an 8 mil resection, we're going to go to 5. Does that make sense? 5 mils of lateral resection. Okay, which puts us into 2 degrees valgus. Now, why am I a little bit concerned about that? Because 2 degrees is the maximum that we would like to go for a valgus alignment of the tibial component. But I also happen to know that she's got 3 or 4 degrees of valgus that's actually built into the tibial shaft, as you might have seen from the previous imaging. So if we assume that we've got 3 millimeters of lateral cartilage wear, we account for that. That makes 5 plus 3 is 8. So that means we're taking equivalent amounts of proximal tibia. In terms of slope, we're going with 4 degrees slope, which is the plan for most of these apex knees. So we'll go with that. Yes.
Simon, so here, how do we know for sure, especially in cases where there is hyaline cartilage loss and some additional bone loss?
Yes.
And then, as we can see just now, that the surgeon has no choice but to take some assumptions here, right?
Yes, correct. Yeah, there are assumptions in that algorithm.
Yes, and if is that not where part of the vulnerability of the logic of this overall approach of kinematic alignment, whether reverse or regular, is?
Yeah. So the discussion around the assumptions around standard kinematic alignment are on the femoral side with femur first, are that you've essentially got a 2 millimeter extension wear on the most worn side. It changes a little bit with the inverse kinematic process, and with what's published by Winnock de Grave, he's used the criteria of bone wear, not bone and cartilage wear. So there is a difference. But what we've seen is that the thickness on the lateral side, in particular, of the proximal tibial cartilage is somewhere between 3 and 4 millimeters rather than 2. So that's why that assumption is made of 3 mils. As long as we're staying within reasonable boundaries of varus valgus, then I'm happy. So the next step is to then position this device, which is called a nanoblock. Can we see that, guys? This is the nanoblock. And this is not positioned with the robot. This is positioned by me, but then there are micro adjustments made. Let's just see it on that camera. So, yep, great. So what we do is we then position this according to, let's take the whole thing. Thanks. And we'll position this with pins. And if you look at the screen now, you can see that we're going to position this so that we get some blue lines. And that will then allow me to make the micro adjustments. Okay. Yep. Oh, that's no good. Stop, take that out. If I start with red lines, then we won't get it into position. So let's see. So the sponge things. Oh, yeah, we will do that. Yep. That one's bent.
So the red and the blue lines on the screen, basically once it turns blue,
so if I have a red line,
close enough.
That's right. If I have a red line, I won't be able to make the adjustments, okay? So if I then get into a blue zone, then I will be able to make the adjustments, or even better if it's green.
Right.
Gary and Barrett, what type of alignment are you using for your patients?
Basically, I'm a mechanical alignment person, and I have strong reasons for it. In terms of the gain, I personally feel that there are many vulnerabilities to the approach of kinematic alignment, whichever way you want to use it, whether inverse or regular or restricted kinematic or functional or anatomic. Any of these, you pick your choose, and I can debate on the overall
I don't think
ratio.
I don't think we'll have a debate about KA versus mechanical in the middle of the case, but it's certainly something for discussion. Just a couple of little points I want to make. Firstly, I'll just finish the lateral meniscectomy here, and have a knife. Thanks. How I assess my rotation, how I set my tibial rotation, is according to the way Stephen Howell has described for his technique, and that is to determine the axis, the AP axis of the lateral tibial plateau, and we mark that with the diathermy, and then I'll pre-drill 2 holes that I will find again when I come to position my tibia. Drill, please. When I've come to position the tibia with its correct rotation. So again, this is
Is this a symmetrical tibial component?
No, it's an asymmetrical component.
Asymmetrical, okay.
Yep.
And it's a fixed bearing component too, Simon, correct?
Say again?
It's a fixed bearing, rigid bearing component?
This is fixed bearing, fixed bearing. And so we just mark that.
Simon, this is different from the original technique from Philippe Vinogradov. So
yes.
Why did you change?
Because I've done a lot of femur first KA, and I found it to be so good at reproducing good tibiofemoral rotation match. We check all of our cases with postoperative CT alignment studies, and we're usually within 1 or 2 degrees when we use this technique. So coming back to now the micro adjustments for the tibia, the software tells us essentially what to do. And so I'm making some adjustments with this screwdriver so that the nanobot will be positioned into the correct alignment. And you see we're just going to, reduce the slope. And then once we hit green, we're pretty much in the right ballpark. Okay, so once we're on green, we can then lock that in position and then make some cuts. The other Homan, thanks. Yep. Good. Now, often with this cutting block,
so Simon,
always get to the back of the tibia. So we'll just finish the cut with the block off. Yep.
Simon, the cutting, the saw I just saw it's not part of the robotics or haptics.
No, totally controlled by me.
All right. Yeah.
This first device that we put on is just essentially it's a navigated tibial cut, not a robotic tibial cut. Correct. Lost your time. Let's go clamp. Lost your time again. Try and take this out in one go if we can. You'll notice that my exposure is I have gone back just to the mid-coronal line. I try not to extend the medial tibial release any further than that so that we don't go over releasing ligaments and then having issues with balance.
So Simon, that's something that while you're doing that, you can just say yes or no, but that's something that's important if you're going to be maintaining your femoral geometry on your ligament balance medially and laterally, isn't it?
That is absolutely. Yep. Okay, so I'll just have a saw, thanks. I'll just, I think iatrogenic ligament injury is not good. Okay, let's have the validation. There's another pair of gloves. Thanks. I'll just come through this. So this is our validation process. So we've got 2 degrees extra of slope, but we're on alignment is good. We've taken 1 millimeter extra on the medial side and 1.5 millimeters on the lateral. We'll take that. Yep. I'll just change gloves. We've just got a hole in one of them. So once we've done that, and I just want to make sure then that we've got adequate resection of all of the proximal tibial surface because it can interfere. So we'll just have that saw back. I'm getting over to Gertie's tubercle. You just need to clear that out. Okay. So this next step is really where this technology becomes useful. This is the Omnibot or the BalanceBot device. There are 2 paddles. There are 2 paddles which will expand and contract depending on the amount of pressure that's put on them. In extension, we have 90 newtons, and in flexion we have 70 newtons of pressure, which is, I guess, a reproducible amount, which is a point of difference, I suppose, between this and the device that Rami used to measure his flexion space. So what we do with this is, having made our tibial cut and validated its position, we place it into the femur, bring the knee into extension, reduce the patella, and then we switch the machine on. And now the bellows expand the soft tissue, expand the paddles under a defined amount of pressure. I then, without varus or valgus force, just take the knee through a range of motion from flexion and then into extension. Do it a couple of times just for reproducibility. And that then gives us our initial laxity curves. Yep, thanks, James. All right. And that's from there is where we will then plan our femoral resections. So James has just brought up now on the screen a femoral planning screen. And so what it's telling us there is at 10 degrees of flexion, we've got 10 millimeters in extension, both medial and lateral. And in flexion, we're a little bit looser. We're at 12.5 degrees and 13.5 degrees of flexion space. So we've got about 2 to 3 millimeters of difference between flexion extension space. So what can we do about that? Well, we can tighten up the flexion space by going to, what size are we on? A 5. It's interesting, we're on a 5. So we can tighten the flexion space or loosen the, or take a little bit more bone on the distal femur and then put a slightly thicker poly in. So we're now looking at curves that are almost perfectly balanced just by having brought the distal femoral resection up just a touch. So that looks pretty good. Do we want to adjust the varus valgus? Looks pretty okay. Let's go into, just for the sake of argument, just put some varus onto that femur and see what it does to the curves. You can see what happens here. The curve tightens up a little bit on that lateral side, which is not necessarily a bad thing. Whereas if we go back to the neutral varus valgus, it's a little looser on the lateral side. And this is where personal preference comes in and experience with the technology. So let's go 1 degree varus. Thanks, John. I just like the curve there. We've got nice balance between the medial and lateral with slightly looser inflection, and there's pretty good balance all the way through. So I don't mind that. And we've ended up with, at least in the planning process, 2 degrees of valgus on the overall alignment. And that's using an 11 millimeter insert with pretty good balance. So any questions about that at this stage? This is the most, really, this is the crux of this technology, yeah.
Yes. So what I can see is that the bone cuts are basically predicated on the ligament tension, right?
Correct.
Because that's what it did. The balance board brings about a ligament tension in a measured way.
Yeah.
My question is, ligaments as structures have been designed by nature primarily as check reins, right?
Yeah.
They are designed to prevent unnecessary movement or excessive movement. Now, the tension that we measure as a surrogate indicator of an appropriately, into inverted commas, balanced, close inverted commas, ligaments, right? The tension can change dramatically by 0.5 millimeter once you have reached the end point of a ligament's ability to stretch.
Sure. Yep.
Now, each patient has different collagen composition in their individual bodies, as evidenced by hyperlaxity to solid, ligament status. How do we know in a given patient whether the 100 Newton force was the right force for this particular patient's ligament to be balanced appropriately?
We don't, but this is the only technology that defines it.
I agree. This is a beautiful technology which can quantify it for you. But it certainly cannot decide whether it is the right tension for a given knee or a patient. Would I be right in my comment on that?
And I ask you the same question when you do it yourself under conditions where you don't actually have any information apart from what you feel. So this does give us information. It gives us the flexibility to act on it, and it gives us the ability to act on that information with precision rather than with what we think might work.
Sure.
So just to reiterate the points on what we're actually doing here, our resections on the distal femur will be 10 millimeters on the medial side and 8 millimeters on the lateral side. They'll be, the posterior condyles will be 10 millimeters each. So there's no external rotation being placed into this device off the posterior condylar axis. Okay.
And this is based on the ligament tension readings that we just saw, right?
That is correct. Yeah. So the next step,
this is a beautiful, simple, and intuitive screen that you have there. Even an uninitiated guy like me is able to follow it every step. So
I think the one thing I do like about it is that the visual interface is very easy to to interpret. So what I'm doing here is just making sure I'm micro adjusting the position of the the Omnibot, the femoral robot that will make the final cuts. And I want to, again, be in the green zone. We've made adjustments, both external rotation, internal rotation, and varus valgus of the block that I've got my hands on. And then once I'm in the green zone, we then position the device so that it's most posterior, and then it'll go through a range of motion to calibrate. What it's doing here is the robot is communicating with the software to say, basically, am I able to get into the position to make the cuts that we've planned? You won't be able to go forward if you can't. So now we're now going to make our distal femoral cut.
So can I just ask a question about your distal femoral cut?
Yep.
So is there a limit on the varus or valgus that you'll cut your distal femur?
Technically, there's no limit, but we can select limits.
So you're driven by the collateral ligaments.
We are driven by the tension in the ligaments, yeah.
Yep.
So there's two elements. It's the thickness of your cuts, both on the medial and lateral side, and therefore your distal femoral valgus angle. So we've had patients who we've had distal femoral valgus angles before we've made any cuts of 8 degrees. And then at the other end of the scale, you have distal femoral valgus angle of, say, 1 degree of varus. And so we've got decisions to make. And I think we, being the broader orthopaedic community, have to define what those limits are now that we've got technology that actually defines it with accuracy. Right. And I think, and obviously there's work to be done there. I've taken my approach has been maximum 6 degrees of valgus on the femur and 6 degrees of varus on the tibia, for that matter. Yeah.
Thanks.
Well,
just for the audience, this is what is also labeled as restricted kinematic alignment or inverse kinematic alignment approach. Would I be right, Simon? In the textbooks or in the papers, it's quite confusing for a person who is just starting his journey on understanding the different alignment approaches. And you have terms such as restricted kinematic alignments, functional alignments, anatomical alignments, and what Simon just described is a restricted kinematic or inverse kinematic alignment in this case.
Okay, so
Simon, I don't mean to interrupt you, but I've got a question from the audience, from Mark Clatworthy.
Yep.
He wanted to know whether you remove the posterior osteophytes before inserting the tensor.
I do if there are significant posterior osteophytes. If they're big ones, I will release them. But in this particular case, they're pretty small.
Thanks very much.
Yep. So we've just validated the distal femoral cut. We had green zone all the way. So we moved to the next cut. Have the finger of fate, please. So with the anterior femoral cut, when I started using the device, I used a cutting guide just to make sure that I wasn't going to be notching. But as we've become more familiar with the technology, we're not doing that as much.
So Simon, this is once again, it's very interesting that here the entire approach of robotics is in the cutting jig, not in the cutting instrument itself. So am I right?
That is the technology. Yeah, that's fine. We validated that anterior cut. The technology of robotics is not everyone thinks it's about what are you using to cut. It's actually really what it's doing is giving you information about gaps.
No, you're right. But one of the things put forth by the robotics schools as the merit in robotics is that, for example, it will stop if you go beyond the bony limits and therefore hopefully prevent neurovascular injury. But in this particular thing, that's not the point that one would make. Am I right?
So that's proposed. That's I guess the selling point of the Mako system is that it's haptic, and the Smith and Nephew system, the haptic limits. This and the ROSA technology don't have haptic limits. You still do have to use the saw. I don't mind that. I think you get a good feel for the bone. I have good confidence in my ability to take out the neurovascular bundle.
I agree.
I'm not critical of that fact. It's just that,
there are different options available to the audience, as long as the audience understands the subtleties in terms of the differences between these systems. I as a surgeon, I agree with you. I would any day prefer the saw to be in my hand control rather than because I tried that robotic haptic controlled sawing of the bone, and to be honest, it's not something that I felt comfortable with.
And we're just finishing off the chamfer cuts here. And the next.
As long as there's no play. Simon, just on the chance that a play develops because of the pressures that a surgeon might put on the jig, and if a play develops on that initial 2 pins you have put in the femur, would the system warn the surgeon that now, he's not in the zone, or that is touched?
Number. It won't proceed.
What won't proceed?
You won't be able to go on with the device. Won't let you continue if you're getting numbers that are not close to where it needs to be. So if you've moved, it's a fail-safe. So it'll stop you making. You won't be able to make the cuts. You'll have to come up with another solution.
Right. Okay.
So Simon, you're telling us that there's a sensor in the saw as well that's telling you that?
Sorry, I didn't hear that question.
Sorry, Simon. So is there a sensor in the saw as well that's telling you that?
No sensor in the saw, but it's the position. When this device is positioned, let's say the device comes around and it's positioned, in a bad spot, it won't proceed. It'll say the parameters for where it needs to be before it says you can proceed are well defined. So if there's been movement here and you didn't know about it, you won't be able to go forward.
So the computer screen will warn you. It'll tell you.
Yes. Yeah. We stopped.
Yeah.
Okay.
Thanks.
So we'll just finish off our femoral cuts. We'll just curved osteotome. We'll just take a couple of little osteophytes off the back. And we're just about ready to do our balance bot trial osteotome things. Mallet.
So this is a PC. What's the status of the posterior cruciate ligament just now?
Posterior cruciate, I still have some fibers inserting into that, so we're still happy with a CR knee, but we have the option here of going to an ultra congruent insert if I've got any concerns, and I'll have a low threshold for that, particularly if she's rheumatoid. So just trying to get these last bits of bone out of the back of the tibia. Have the saw, thanks. There's just a little bit of bone at the back of the tibia. Needs to come.
While you're doing that, Simon, maybe I can just talk to the audience and suggest that they can send through any questions they like on Slido, because we've got it here and we can put them through to you if the audience has any questions.
Yeah, that helped. Just making sure we're getting all the bits of rubbish out of the back of the knee, loose body. That's all clear, and we've still got our posterior cruciate ligament still hanging in there. Okay, that's the
is there a limit? Is there a limit to the preoperative disease-driven deformity, wherein you would say you would not use this approach?
There may be, but I haven't defined it as yet. we will make adjustments, sort of things. So the issue, so whichever, what I was referring to earlier, the limits of a kinematic or an inverse kinematic or a personalized approach are yet to be fully defined. You can take the unrestricted approach and accept that the results are fine, but that's mostly from a single author. And so I guess there's a degree of just being a little bit careful about the degree of tibial or femoral varus or valgus you put on the knee so that it's within acceptable parameters. Okay, so we're just about ready now to do our final balance assessment with the balance spot before we put in our trials. So, James, I think we go to a 5. She's pretty broad, actually. This device has this implant, this apex knee. It has 2 options for the same AP diameter. I can go narrow or broader, and we'll go with the slightly broader one for the same AP dimension because she's quite wide, and that seems to be a better fit. Good. Tap, tap. Just in terms of mediolateral coverage. Good. Right, now we pop the bot in. And, yep. Just on the, by the way, we will be resurfacing the patella here. Patella's quite worn out. You can see on a preoperative x-rays, it's some lateral bone erosion. So once we've done our femoral and tibial trials, we'll do our patella. So the next step with the balance spot is to now go and verify our balance curves. What we've done here that's different is we've then put in the polyethylene trial spacer that matches the femur so that it captures the femur as the polyethylene will do and more accurately assess the gaps. So we slide that in and then activate the device. And you'll notice we're making these assessments with the patella reduced, which I think is important, particularly in terms of over tightening the lateral compartment if it stays subluxed. So we now run it through our range of motion, and we can see that on the medial side we've got pretty satisfactory balance. Come down through, and we're a little bit looser on that lateral side. And down we come. Okay, so we're ballooning a little bit on the lateral side. We've got a 12 millimeter space on the medial side inflection and 14 on the lateral. I think this lady will almost certainly be a 12 millimeter poly that we will end up using. So we'll take that out.
So Simon, please explain again. What did you do just now in terms of the next decision that you will make?
The next decision is really that she's a little on the looser side laterally, and she had a 12 millimeter gap in flexion and 11 millimeter gap in extension. It's my thought that I'll probably use a 12 millimeter poly here rather than an 11 or a 10. So we will now position our tibia.
But at this stage, if you did have a asymmetry of laxity to the point where you would not accept it.
Yeah, so I would have a decision to make about either doing a soft tissue release or perhaps more likely do a slight additional varus cut on the tibia. So if I had a significant degree of laxity that I was not happy with, I would probably take 1 millimeter more on the tibial side, which would make those gaps more equivalent. But having said that, I'm pretty happy with this, and I would do that assessment based on not only the robot but how it all looks and feels at the end of it. And once I've positioned my tibial base plate. So coming back to our tibia, we now find those holes that we had defined before. That's one there, and the other one there. And that then defines our tibial rotation, which is that position. Is a 5. I think we'll drop back to a 4 on the tibia. Yeah, that's better. So we mount that tibia, and you can see that. I don't know whether we can show. It's asymmetric, slightly narrower AP dimension on the lateral side than it is on the medial side. We position that parallel to the previously determined tibial rotation. Yep. Yep. And that's it. We'll do a 12. Yep. So that's a 12 millimeter poly. Femur. Packed it. Again, we're not using tourniquet here. I've used tourniquet for a long while. So that's a 12 and bends well, extends with 6 degrees residual flexion. She's got a range of, it's interesting, her kinematic curve's very similar, noting that there wasn't a lot of pre-existing deformity. Her mediolateral stability is quite good. There's no mediolateral shift throughout that range. So it's pretty good. And in terms of AP stability, I don't know whether you can see that on the screen. I'm not, she's got good AP stability. We'll just drop back to an 11 just for the sake of it. Have a look. Just retrial an 11. A lot of this then comes down to personal preference as to whether you think the 11 or the 12 should be the way to go. 11 feels probably a little bit better, actually. It just feels good. Yeah. Okay, it'll be the 11. That's it. So now we'll
Simon, what about mid-flexional AP movement? Like about
so we're in
30 degrees.
Okay, we're mid-flexion here.
Yeah.
So
looks good.
Can you see
looks
that?
Good. Yeah,
you see that? It's
good.
quite stable. Yep. I really look for medial stability. I'm happy to have a little bit of lateral laxity, but I'm very keen to make sure that the medial side is stable throughout the range. And that's what I'll focus on when I'm doing my balancing. And it's what we've seen. We've been measuring this with the femur first kinematic technique and the tibia first inverse technique. I'm very keen to have medial stability. If I don't have that, then I've really, I've got to do something about that.
Yeah, I agree with you. Yeah.
And quite stable there. Yep.
Simon, this question is for all three of you, Gary, Emmanuel, and you as well, that the mid-flexion ligament tensioning that happens, in other words, the stability which just Gary alluded to, is, and correct me if you think I'm wrong here in my question, but it is heavily dependent upon the anatomical J-curve of a given knee for its given collaterals, right?
Yeah, I believe so, yeah.
Yeah, so here, when we put unless we talk about something like the conformis, which has at least, if nothing else, 3 options of the J-curve as well, but in any other system on the planet that we have at the moment, the J-curves are fixed into the components. So how is it that we can even theoretically claim, let aside practical results, but theoretically claim that we are doing a predictable event here in terms of the mid-flexion tensioning of those ligaments? So once we are replacing a contour of a given native anatomy with a man-made contour, which is of a very fixed nature.
I'll make a quick comment on that, and then I'll keep going with the patella. You can vary that with femoral flexion extension. You can vary the mid-flexion characteristics with flexion extension of the component. And you can see that when you do the planning on the balance with the software. And that's the same case with all of the systems. They'll allow you to do that as long as you're measuring that through the range.
Okay. Yeah. Do you always replace the patella?
Say again?
Do you always resurface the patella?
Not always, but in this case I will. She's very eroded.
Yeah, I see. Yeah. See, again, my question to all in general is that when we talk about the this entire movement of kinematic alignment has started as a result of the 20% unforgotten knees. It has been presumed that the 20% unforgotten knees are the result of the soft tissue envelope not being looked after quite well by the existing approach of mechanical alignment. And my question to Gary, Emmanuel, and Simon would be that the soft tissue envelope is not only two collaterals, it's about the entire capsule that goes around the knee, the bony knee. And all these that we are discussing just now are more predicating itself on the measurements, or at least attempts at measuring the tension in the collateral ligaments, which is not the same as the entire soft tissue envelope. Even changing the joint line inclinations does not actually address the soft tissue envelope, which is basically nature had made it to fit the exact volume and the contours of the bones that form the knee joint in a given human being. So are we not, Emmanuel, if you could comment on it, and Gary, please, if you could weigh in, are we not actually trying to chase shadows here rather than the man himself?
It's a good comment. I mean, I personally think that the 20% we are missing, they're probably more in indication, making sure you operate on bone to bone, avoid depression, anxiety patients, chronic morphine use. And if you take all those out, we are probably doing better than 80%. But I think it's a very interesting challenge that we as orthopedic surgeons, maybe a little bit under pressure of the companies, but try to find the solution with a technical option. And as you said, I personally use a little bit now patient-specific implants to check this out. This is another way, and we will see if we can do better. But I think this is fantastic, a fantastic evolution.
Yeah, I'll get that.
Thank you.
My personal opinion is, and I've always mentioned this, is that a knee replacement really is a soft tissue operation. It's balancing the soft tissues, getting the soft tissues to be in harmony with the implant that you insert. It is a replacement operation. We're not actually giving the patient back exactly what they started with, and the fact that we are endeavouring to do that is commendable, but I fear that we're not really going to achieve that outcome. And so all joint replacements are a compromise.
Absolutely. Both of you have just made me more confident about my approach.
And mix my idea, right? I think your question about soft tissue is the fundamental question. The judgment of what's enough soft tissue release, what's the right balance, that's where the art of the whole process comes in, I guess. But at least now with the technology that we're having, we actually can quantify those amounts rather than just go, it feels about right. Nicola, thanks. And so I think just like Rami, using the technology aids our it aids our information, but I got to say, with more information, it means more decisions. So when you're flying blind, you don't have too many decisions to make. Whereas when you've got all this data that you're getting, then you've actually got to make some decisions about what you're going to do with it. And that's our challenge, I think.
Simon, can you explain us what is exactly the difference between seeing soft tissue balance on a screen or feeling it?
Sorry, say that again.
Could you explain it from your experience, what is the difference between seeing soft tissue balance on a screen or feeling it with your hands? Because that is basically what we see with the technology now.
Well, we all think we're really good at it. And the best paper that demonstrates that we're not that good at feeling it is Sam McDessie's paper from Sydney. Sam demonstrated really nicely that what he thought was a well-balanced knee and what the technology gave him was not exactly the same thing. And with And we as surgeons all think we're probably better at it than we are, and the technology gives us the real information, I suppose. But nevertheless, we still are working out what's the right amount of tension for each individual patient. So
exactly. And Simon, once again, I think we are giving much more credence to readings offered by a measuring device, which we use the word technology just now in our conversation, much more credence than what is merited. And I'll explain what I mean by this. The tension in ligaments, which is what we are talking about here, in the post-operative phase, when a patient starts walking, will depend so much on the cadence, the stance, the sine curve of his gait. The tension that is generated in ligaments, it will depend upon whether he has a flat foot associated with it or not, whether he has a slight amount of pelvic obliquity. So to say that just because we could see mathematical figures on the screen at the time of doing the mechanical act of cutting bone and putting in an artificial component, and then to say that this actually translates into physiological or anything near physiological type of a predictable event. I think we are being naive on this issue as a community as a whole across the world. And the reason for that could be much more than just science. It could be our own predilection as gadget boys, and the industry forces and something new, and so things that are much more than science.
I don't for a minute want to have anyone think that we have all the answers to what we need to be doing. My point is that by getting the data and having some information and then making judgments with the post-operative satisfaction scores and assessments, that we might go some way to improving our understanding of that. But you're right, gait analysis has huge implications. And if you look at a lot of the latest gait analysis work, what we're seeing is improvements just with changing your alignment philosophy. And I think it's about getting a joint line that's horizontal at gait impact rather than on a two-dimensional X-ray. So, there's a lot of moving parts and a lot of things to consider. And I don't think that just having a special tool makes it a whole bunch easier. Just gives us more information.
So, Simon, I have to say that I'm extremely disappointed in you. After listening to the debate earlier about cemented and uncemented, you are now cementing me.
Well, I think, so here's a point. You've got to be very careful about which cementless device you're using. I did comment. I did a lot of cementless knees when I was using standard mechanical alignment instruments, and I have had not one loosen. So I think the technology is good. And I love using cementless knees, so I don't have to do what I'm doing here, which is to take cement out. However, you've got to be very confident in the technology of the actual device. And I'm more confident in the cemented technology for this particular device on the tibial side. Having said that, we're about to start an RSA study on a cementless device that is about to be manufactured for this implant.
I am a cemented TKA guy, but Gary, let me tell you, you presented an extremely comprehensive and powerful case for cementless knees, which will eventually come in. Of course, different parts of the world will have different reasons for not adopting it in wide scale, and mainly to do with economics, availability of those components, etc. But I think the first generation cementless were a different breed altogether. The newer cementless devices, especially with these ingrowth material that invites very powerful ingrowth, more understanding, precision cuts with things like what we have, Simon has so elegantly demonstrated. All this will lead towards far more adaptation of cementless in the knee joint, like it has done so in the hip joint in the years to come. Whilst both will have its own place, in large cavitary defects, for example, perhaps it might make sense to still have cement to take up the space, custom-made space, But cementless knees in numbers are bound to increase, and that's what my understanding of future move towards technology would be.
But the femur seems to be uncemented, no?
Simon, is the femur uncemented?
The femur is uncemented, yeah.
Yeah.
Femur is
there we go.
uncemented.
So you're hedging your bets.
Well, as I said, more cement means more fiddling.
Yeah.
But I do cement the patella. I think that's why Rami doesn't want to do many patellas, because he doesn't like cement. And he'd rather avoid it altogether by not resurfacing the patella.
So just looking at your cement, this is Pellicos cement, is it? That
Yeah,
you're
it is
using?
Pellicos, yeah.
Yep. So you trust antibiotic loaded cement?
Yes, I have no issue with using it.
Yep.
And so just to final comment, I'm very confident with the fixation that we have. I really do like this base plate in that with the cement, we get a really stable device that I'm happy to take the knee through a range of motion whilst it's still going off. The stability is very good. Patella's tracking centrally. I'm pretty happy with that. And we just
Simon, as usual on a navigation system, full extension clinically measures -5 or something.
Yeah.
Do you want to aim for 0, or you are happy with the -5 as most of us are?
I'm pretty happy. I actually worry if I end up at 0. I think it's perhaps a little bit too loose in some of these patients. 5 degrees is fine. It accounts for a little bit of the femoral bow, I think. So we can take our navigation off, and we'll do like Rami, I use infiltration. We also use an adductor canal block, which I really do like. Use tranexamic acid routinely, intra-articular and intravenous. We get them moving from day one. Weight bearing is tolerated and fairly routine. Any
still
questions?
have about 6 minutes, so no worries. You're well in time.
That's good. Any other questions from the audience?
I haven't seen any questions from the audience yet, except that one from Mark Clatworthy. So no one else is putting their hand up to ask anything, Simon. But
one point on that question that Mark did ask about osteophytes. If there's a significant flexion contracture, or the osteophytes are clearly interfering with the soft tissue assessment, then I think it's imperative that they be removed. If there's few osteophytes around the femur that are not impairing movement, then I don't get, I think they should be removed, but I don't get too fussed about doing it at the time of the soft tissue assessment. But the other point is that if they are still there and you can't actually get to them before you do your distal femoral and your posterior femoral cuts, then you need to make allowance for it when you're doing your planning. So if you do your planning and the osteophytes are still there and you're going for full extension and the perfect gaps, you might find that after you've released your osteophytes, you actually have over-released the knee. Stitch things.
Simon, while you're closing, can you just comment why you changed from kinematic alignment to this technique?
The reason is because with the kinematic alignment, even though I use navigation and we can validate our alignment, I can't use this technology to do I can't use the balance spot to give me predictive curves, because the balance spot relies on a tibia first technique. So on a femur first KA technique, I can use this technology, but I can't use it in a predictive way. I can only use it to validate. We've actually done a nice little study, and it's actually in one of the presentations on the final day, where we've done 60-odd femur first kinematic knees versus 60-odd tibia first mechanically aligned gap balanced knees, and compared their soft tissue and bony alignments afterwards. And it's interesting in that it basically shows that you can do it either way. The predictive way resulted in a more horizontal joint line at full extension. A little bit more bone resection on the gap balanced group than the kinematic group. We think that's probably down to surgeon preference in terms of what you like to see in terms of a tighter or looser knee. But no real, we don't think there's any real differences between the sort of clinical outcomes, to be honest.
So what always has fascinated me is that as a collective psyche, as a fraternity of arthroplasty surgeons, 10 years back, I distinctly remember my very illustrious peers and colleagues waxing and waning about how CAS, has brought such precision that we won't now, from now onwards, have any outliers in the mechanical alignment sort of a philosophy, and therefore there will be a significant improvement in revision rates because it's all about outliers that is causing the implant to loosen up. Now we are using the same technology to intentionally bring outliers in, and we are claiming that it will reduce our problems. So I am really fascinated by ourselves.
What's interesting, Bharat, about the outlier comment is that with whatever approach, these personalized approaches, we're not seeing massive numbers of outliers. We're seeing changes in the geometry of the joint line. Thanks. We're seeing changes in where we make our femoral and tibial osteotomies. I'm just going to come through here. But we're not seeing massive numbers of varus valgus outliers. And I would contend that even before we had the technology, we had a broad number of outliers. As we used navigation to bring those outliers in, then we would have been having more troubles with soft tissue balancing. So my comment about that is that the navigation tells us where we are. The software in the robot tells us what our soft tissues are doing, and now we can merge those two. Before we had the soft tissue information, we knew where we were in terms of alignment, but you can have a well-aligned and really badly balanced knee. I think with the robot, whichever it happens to be, you get that information, both the alignment and the soft tissue balance, and then you can make some decisions around that.
Maybe for Barrett's case, every mechanical aligned knee that we were trying to do with conventional instruments, when we made mistakes, we were maybe doing kinematic alignment or something like that. And those were maybe doing best. We never know. We will see.
But anyway, the good news is that we win either ways. We put in a slightly varus knee. The mechanical aligner can say that, no, but I'm so flexible that I have used my judgment to put in the physiological alignment here.
I just want to make a point, Bharat, there. A little bit of varus on the tibia is not necessarily a kinematically aligned knee. It's totally different. Totally different.
Oh, yes. I accept that.
And you can have a little bit of varus and make your extension space look great, but then you may have a problem with flexion instability on the medial side, and that's a bad thing to do.
Simon, I'm looking at the time, and I see we've only got about 15 seconds to go in the session. What I really would like to do on behalf of the audience is to thank your surgical team for what they've done and their attendance here today, because it's been a superb demonstration of surgical skill. And also, please thank your patient for making herself available to us.
Yeah, we will. Thanks very much, Gary. Thanks, Emmanuel.
Thank you, Simon. Wonderful teaching session.
Fantastic job.
See you then.
Fantastic job.
Hello, good morning, good afternoon, participants from all around the world. I hope that you are enjoying a combined session of APAS, Asia, and APKS. You've seen live surgeries and you're visualizing lectures in hip and knee sessions. So this is a complex primary knee session. We have 7 short presentations and we'll take question and answer at the end of the session. My name is Shahid Noor. I'm the president of Pakistan Orthoplastic Society. And with me moderating this session is Kiki Novito. Thank you.
Thank you. I'd like to speak to you about trabecular metal augmented patella resurfacing for advanced patellofemoral osteoarthritis in primary total knee arthroplasty. This is a patient of mine who represented with 15-year Avon patellofemoral arthroplasty. It may be a solution for this sort of pathology. The patient is still asymptomatic, but the registry results aren't great for this sort of implant. I'm going to address it in a different fashion, talking really about patella bone loss and what to do for the patella with severe bone loss, let's say less than 10 millimeters in thickness with advanced patellofemoral arthritis. I'm going to use a particular case to demonstrate this because this was an interesting presentation on a patient who represented with a complication. 67 years of age, overweight female, disabling knee pain, difficulty walking distances greater than 200 meters, unable to negotiate stairs, frequent giving way episodes, knee stiffness and recurrent effusions. This is her initial x-rays on presentation. You can see she has advanced arthritis in the medial compartment, but very severe patellofemoral osteoarthritis, tricompartmental osteoarthritis with severe bone loss of the patella. How do you manage these patients? The bone loss of the lateral femoral condyle and the patella may be extensive. You may use a CT for further analysis, but you need to be prepared with the appropriate implants at the time of surgery. The intraoperative findings for her are standard medial parapatellar approach. She had a very thin concave patella that measured less than 5 millimeters in thickness. How do you manage these patients? Very thin patella could not be resurfaced in a standard fashion. What are the options if simply left? The stress on the concavity will eventually lead to a periprosthetic failure of the patella. The options as I see it, you have major debridement options with patella resection arthroplasty, but the risks here are anterior knee pain and a compromised extensor mechanism. You can do an osteotomy, the patella vertically, convert it to gull wing osteotomy, allowing it to become convex and track centrally on the femoral trochlea, risking here, however, anterior knee pain and another compromised extensor mechanism. The patelectomy, there are risks with this. Extensor mechanism could be compromised. You can have an extensor lag, resulting in anterior knee pain. You can cement a very large patella button into the defect. Problem here is poor cement fixation into what remains of the bone surface, the risk of early failure and dissociation, compromising extensor mechanism. You can cement an all poly biconvex patella if you can find it. You can bone graft the patella with autologous bone offcuts and cement a patella button, but you've got to wait for bone integration and this will delay your rehabilitation. Or you can use a porous trabecular metal augment patella replacement, which we'll discuss here. This has been around for a couple of decades now, initially came out from the revision situation, but we'll discuss it here with the primary TKA. It addresses the issue of the severely bone deficient patella in primary, and knee arthroplasty relies on bone ingrowth into the porous tantalum surface and the polypatellar components then cemented onto that tantalum component. This is Lotke's group who reports on this in a revision situation with an 85% success rate if there is a residual shell of good patella bone. The technique specific, you prepare the patella using either their own reamers, or I tend to use a 50 millimeter standard acetabulum hemispherical reamer, which does a good job of preparing the bone surface and making it even. Onto this sits the tantalum augment, and because of the rough surface, it sits with good stability initially. You then use a 1.6 millimeter drill bit to prepare the holes, or even a thick K-wire, and then you're using something like fiber wire sutures, using a Keith needle, pass couplets of suture and tie them onto the anterior surface, as you can see here, with doubles of suture material tied multiple stages onto the anterior surface. Once this is stable enough, you then use CMW to cement onto the polyethylene surface of the patella button. The standard patella button's then cemented in place, giving you an overall thickness of somewhere between 22 to 24 millimeters, reconstructing that moment arm for your quadriceps extensor mechanism. This is a post-op x-rays at 6 weeks. The patient was pain-free and demonstrated a good range of motion, as you can see here. Interestingly, at 6 months, she represented, she had good function, she was negotiating stairs, she had good quads control at that point with a good range of flexion that hadn't been compromised. This patient, however, had a fall 2 years later, rupturing the patellar tendon, as you can see here, with the patella going quite proximal. You can see the amount of bone that's come off here as well. This patient required exploration and reconstruction using a last double breasting technique with drill holes into the tibia. Note that the patellar-trabecular augment originally remains in situ with good bone integration and hasn't moved. At 6 months, she had a good recovery of function after this reconstruction. This 72-year-old lady, predominantly patellofemoral OA, this was the original radiograph I showed. She had significant bone loss to the patella, reconstructed with the trabecular metal patella augment, achieving a good range of motion. Here at 3 months, you can see the good integration of the patellar surface onto that tantalum porous surface here, giving good stability. It also reconstructs that moment arm. This 69-year-old lady presented with bilateral patellofemoral osteoarthritis. Here I chose to do it in a staged fashion, the right knee first, and at 6 weeks you can see her gait is good. It's a routine post-operative protocol in terms of mobilization with physiotherapy input for range of motion exercises, and immediate weight bearing is tolerated. We then did her left knee 6 months later, and this is a post-op film of her left knee, and at that stage this was the 6-month radiograph of her right knee, and she had good function on the left and right side, being 6 months on one side and 6 weeks on the other. Good quads control, good mobilization. The indications, therefore, are a measured patellar thickness of less than 10 millimeters or a misshapen patellar anatomy not suitable for standard resurfacing or keloectomy debridement, and it can be in a primary or revision situation. The 75-year-old lady, post-op, and at 6 weeks with good integration into the tantalum surface. 6 weeks post-op, trabecular metal patellar recon. So this is the group from Italy and Bologna showing 10 patients with follow-up of 45 months, only failures in a case of post-patellectomy with no residual bone stock. And this is Lotke's group, again with a minimum 5-year follow-up, showing that there is a 83% survivorship as long as you have good bone remaining in the patella, even 2 to 3 millimeters of thickness. So your patellar arthroplasty restores patellar thickness, optimizes quadriceps moment arm, allows polyethylene articulation of the femoral component, no impact on post-op rehab, decreases the risk of extensor lag, reduces the incidence of anterior knee pain, expects success with deficient but residual patellar bone thickness. Thank you for your attention.
Hello everyone. I'm Dr. Bing Yue from Shanghai Renji Hospital, Shanghai Jiao Tong University School of Medicine. My topic is the intercondylar notch ceiling as an accurate reference for distal femoral resection in TKA. It has been well established that restoration of the normal joint line is critical to obtain correct knee kinematics and good clinical results of TKA. However, in severely degenerated knees, the distal femoral condyles often have significant cartilage and bone defects, and the continued use of the surface of the distal medial femoral condyle as a reference for the distal femoral cut might result in unexpected over-resection. We know the medial MDFA, the angle is 94 degrees. When we make the distal femoral resection, it should be perpendicular to the mechanical axis. So the medial femoral condyle is removed more than the lateral side when we resect the distal femoral condyle. But in some cases, on the medial side, the cartilage and the bone are worn very significantly. So when the distal femoral cutting guide is inserted, on the lateral side, the bone and the cutting guide are already contacted, but on the medial side, there is still a gap. There is still a gap here. So at this situation, if we resect the distal femoral condyle using the distal lateral femoral condyle as a reference, then the more bone will be removed than we planned or than we expected. We searched the literatures. There is no clear answers or there is no clear landmark for distal femoral resection. All the methods are based on the author's experience. In this literature, the the author reported that in case in which the surgeon had an impression of a cut more than 10 millimeters of the distal femoral section, the distal cut was reduced by 2 or 4 millimeters. In the second literature, the author reported that if there was an existing loss of bone due to an erosive defect of 2 millimeters, then the resection on the medial side was decreased by 2 millimeters. In this book, The Master Techniques in Orthopedic Surgery, the author's experience is that I like to see a figure 8 configuration on the cut surface. If I see 2 ovals, the cut is too far distal. If the surface is continuous bone, the cut is too proximal. So all these measures are based on the author's or surgeon's experience. In this literature, the authors found that the deepest point of the intercondylar notch is unaffected by wear. It can serve as a reliable landmark to check the level of distal femoral section. With such literatures, there is no quantitative research about the intercondylar notch sealing. So we performed this research. We recruited 100 healthy adults from southern China, 50 females and 50 males. We made this 3-dimensional femur based on the CT scan, and we defined the femoral mechanic axis. And along the mechanic axis, we set a plane at the level of intercondylar notch sealing, perpendicular to the mechanic axis. Then we measured the distance between the distal femoral medial condyle and the level of the intercondylar notch sealing. We also measured the femoral condyle size using the lateral anterior posterior dimension of the femoral condyle. The results show that for the male patient subjects, this distance, the distance between the distal femoral medial condyle to the intercondylar notch sealing level for the male patients is 9.2 plus minus 1.5 millimeters. The range is from 60.3 to 12.5 millimeters. For the female subjects, this distance is 8.2 plus minus 1.4 millimeters. The range is from 5 to 11.9 millimeters. These results indicate that when the thickness of the distal femoral section is 9 millimeters, then for both the male and female patients, the resection level of the distal femoral condyle should be around the level of the intercondylar notch sealing. We also found that this distance does not change significantly according to the femoral condyle size for both the male and female subjects. So discussion. For the complicated primary TKs, the medial and lateral epicondyles have been used to locate the joint line during surgery. But the maximal errors in the intraoperative selection of the medial femoral epicondyle and the lateral epicondyle was 7.6 and 4.2 millimeters respectively. And several other literatures reported the similar results. It means to use the medial or lateral epicondyle as a landmark for the severely degenerated knee is in this needs to perform the distal femoral section, use the epicondyle, use the medial or lateral epicondyle is not accurate. So the conclusions of our study is that the intercondylar notch sealing could serve as a clearly discernible and accurate landmark of the proper distal femoral section level during TK for knees with significant deformations. For the clinical relevance, the distal femoral bone cut position should be at the level of the intercondylar notch sealing with most current TK prosthesis systems. And our research has been published in the KSSTA. So that's my presentation. Thank you for your attention.
Hello, good morning. I'm Professor Shahid Noor. I'm the President of Pakistan Arthroplasty. Welcome to the Congress. Today I'm going to talk about bone loss in primary knee arthroplasty. Bone loss in patient who are going primary knee arthroplasty in Europe and North America is least of a problem for arthroplasty surgeon. But for patient in Asia and Middle East, the scenario is different. Arthroplasty surgeon here needs a skill of extensive soft tissue release and balancing. They need to have special equipment like metal augment, metaphyseal sleeve, trabecular metal cone, as well as constrained implant available. There are several classifications for bone loss, but AORI is the most commonly used. Type 1 metaphyseal bone is intact. In type 2, metaphyseal bone is damaged. And in type 3, metaphyseal bone is deficient. This can be further summarized into cavity and contained defect and wall and segmental defect. What are reconstructive options? Cavity defect can be filled with cancellous bone and cement. Uncontained wall defect can be reconstructed with structural autograft, allograft, or metal augment. Metaphyseal bone loss will require metaphyseal sleeve or trabecular metal cone. Stem extension are used to protect the bone graft and augment. I'm going to show you a few cases. Initially, varus knees. This is typical varus knees that we see in Asian patients. These are preoperative x-rays with significant varus deformity and overlapping of the femur on the tibia. So this has been managed with a primary implant with soft tissue release, AP in a lateral view, and she's 12 years down the line doing pretty good. These are correction of deformity preoperatively and postoperatively. Another patient with severe varus deformity, more bone loss on the left knee. Lateral view. These are intraoperative pictures of his left knee, and the medial tibial plateau bone loss has been managed with autogenous bone graft and a screw. These are postoperative x-rays, AP, and a lateral view. This patient is 8 years down the line and is doing pretty good. Another patient, a rheumatoid patient, a female with significant varus deformity. You can see the standing scanogram with the mechanical axis passing significantly medial on both knees. These are a walking gait with the lurching gait, more significant on the left side. These are intraoperative pictures of a left knee with massive osteophyte of the patella and bone attached to the medial soft tissue structure. After removal of osteophyte and extra bone, these are the pictures, and you can identify the bone loss. This has been managed with metal augment on medial side, and the implant is PS type of implant on the right knee and a constrained implant on the left knee. So this is the standing scanogram, preoperative and postoperative, and you can see that the mechanical axis has been restored. These are pre and postoperative clinical pictures, and these are pre and postoperative gait analysis, and you can see the lurching gait has been improved. Another patient with severe varus deformity, and the gait shows a lurching, painful gait. These are preoperative x-rays in a non-standing position and a standing position, and these are standing scanogram with significant mechanical axis medially placed. These are intraoperative pictures with significant bone loss. This has been managed with broach and metaphyseal sleeve. These are trial implant and the real implant. And pre and post-operative standing scanogram, which shows that the mechanical axis has been restored. These are lateral views and pre and post-operative clinical pictures and pre and post-operative gait analysis where the gait has been improved significantly. A case of a valgus deformity. This patient has been non-ambulant for a year. She has had a stress fracture of her left tibia, which was managed elsewhere. When she came to our practice, she had an infected implant, and the infected implant had to be initially removed and antibiotics beads were applied. First, the right knee was done with significant medial tibial plateau bone loss. This has been managed with metaphyseal sleeve, and a constrained implant has been applied. And a similar procedure has been done on the left knee. These are postoperative x-rays and postoperative standing scanogram. Another patient with wind swipe deformity, varus on the right knee and the valgus on the left knee. And the left knee also shows a significant bone loss anteriorly on the tibial plateau. These are standing scanogram with varus knee on the right with the mechanical axis passing medially on the right knee and laterally on the left knee. These are intraoperative picture of his right knee, and the defect has been managed with a metal augment and a constrained implant LCCK. This is his left knee with significant bone loss more anteriorly. and this has been managed with a LCCK implant. These are lateral views. This is a standing clinical picture and a video where the gait has been completely improved. Another case of a post-traumatic bone loss where patient presented to us with bilateral tibial plateau fracture leg. These are lateral x-rays. His right knee, you can see the bone loss and the tibial plateau. This has been managed with metaphyseal sleeve. These are post-operative x-rays of AP, lateral, and a skyline view. So in conclusion, severe deformity and bone loss in patient requiring knee arthroplasty can be predictably corrected to improve and transform quality of life. This requires advanced surgical skill, careful preoperative clinical and radiological assessment and planning. Bone loss can be managed with autogenous bone graft, metal augment, metaphyseal sleeve, and trabecular metal cone. It is mandated to have constrained implant available in OR when dealing with such deformity. I'll be happy to answer your queries and clarification. Thank you very much for listening.
Hi, I'm Peter Chiu from Hong Kong, China. Please note that my connection to Stryker Mako is relevant to the content of this talk. In the past, everyone focused on lower limb alignment when doing total knee arthroplasty. Many of us still practice mechanical alignment and try to line up the centers of the hip, knee, and ankle. There are two big questions about it. First, is neutral lower limb alignment normal in the general population? 20 years ago, we studied the lower limb alignment in young Chinese adults. We performed standing radiographs of the entire lower limbs in 25 male and 25 female young volunteers. We measured different parameters and compared them with the published data in Western subjects. For both male and female, our lower limbs were in more than 2 degrees of varus, and please note some may even reach 7 or 8 degrees. How about Western subjects? In year 2012, Bellarmine studied the lower limb alignment in 250 young Belgian adults and found that more than 3 degrees of varus was not uncommon. They call it constitutional varus. What is the implication? This subject had minimal arthritic change in the knee. However, the femoral axis and the tibial axis show the varus angulation of 9 degrees. For such kind of constitutional varus, if the surgeon cuts the distal femur and the proximal tibia perpendicular to the respective mechanical axis, the extension gap can never be balanced. Therefore, neutral alignment is not necessarily normal for all. The second question, is neutral alignment a must for the survival of total knee arthroplasty? In contrary to the previous reports that emphasize on the importance of neutral alignment, this paper in 2010 from Mayo Clinic find that there was actually no difference in the survival rates for knees that were well aligned and for those that were more than 3 degrees away from neutral after a follow-up of 15 years. In 2008, they published the results of 20 years follow-up of the same cohorts. Once again, there was no difference in the survival rate. So, neutral alignment is not a must for the survival of total knee arthroplasty. The focus is now shift to gap balancing. I will share with you my thoughts in achieving gap balancing with the Mako total knee system. I prefer to do pre-resection balancing. After removal of all the osteophytes and before any bone cuts, I balance the knee by putting the thickest possible spacer paddles into the medial side of the knee with the knee in extension. By doing so, I tense up the medial collateral ligament and restore the pre-arthritic alignment. I will accept 3 to 5 degrees of residual varus. and then modify the bone cuts in order to create a balanced extension gap of appropriate thickness. Likewise, with the knee in 90 degrees of flexion, I will put in the thickest possible spacer paddle into the medial side of the knee to tense up the medial collateral ligament. I will then modify the bone cuts to achieve a balanced flexion gap of appropriate thickness. I need to emphasize that this are actually done before actually cutting the bones. Let me illustrate with a case with bilateral knee osteoarthritis. In the interest of time, I will show only the left knee. The initial alignment was 18 degrees. After removal of the osteophytes, the varus improved to 6 degrees. I do not accept varus alignment over 5 degrees, so I pie crossed the medial collateral ligament until it became acceptable. I did not target at 0 degree of mechanical alignment. I then changed the component position. I moved the femoral component into slight varus, and I cut away more bone from the medial distal femoral condyle to make the extension gap better. This is because the patient had about 10 degrees of flexion contracture. So just like in conventional total knee with flexion contracture, we cut a little bit more bone off the distal femur. But by doing so, I can balance this knee in extension with acceptable low limb alignment. The flexion gap was only 1 to 2 millimeters too tight, so I kept the femur as size 4, and I plan to anteriorize the femur by 1 millimeter and increase the posterior slope from 4 degrees to 5 degrees in order to open up the flexion gap. And after doing so, I further externally rotate the femur but from 1 degree to 2 degrees so that now I can have a balanced and appropriately wide flexion gap. I then call in the robot and start to cut the bone according to my revised plan. These are the situation after I put in the trials and the actual components. This is the situation in extension, and this is the situation in flexion. These are the post-op radiographs of both knees. In conclusion, medical robotic arm assist total knee arthroplasty permit one to achieve balanced flexion and extension gap in nearly all the knees. We now prefer not to release the ligaments in order to chase for a neutral mechanical alignment. The alignment only needs to be acceptable. It does not need to be perfectly neutral. Thank you.
Thank you very much for your kind invitation. Hoping to see you soon live next year. These are my conflicts. We'll try to get some insight about trochlear dysplasia and its association to malposition and problems when you do a total knee replacement. This is a common deformity associated with patellofemoral malalignment and instability. We must remember that it's not just the knee. Most of the patients who have trochlear dysplasia has problems like hip dysplasia and torsional problems also in knee and in the foot. We must again consider this deformity as a rotational deformity. And TKA in this group of patients have higher risk to have residual complaints because of anterior knee pain or malposition of the components. In all the patients, we need to know that TKA must achieve a correct frontal alignment, soft tissue balance, and axial alignment. And as we see here, trochlear dysplasia could lead to osteoarthritis. Axial alignment could affect flexion stability, tiliofemoral kinematics, patellofemoral kinematics, and knee alignment in flexion. And the CT scan is a helpful tool to detect the malrotation and also to control how we put our implant when there's any disturbance of the anterior knee pain or patellofemoral malalignment after the total knee replacement. The associated deformities and of trochlear dysplasia are femoral neck anteversion related to hip dysplasia, internal femoral rotation, and hypoplastic lateral femoral condyle that leads to trochlear dysplasia, increase of the femoral height in the sagittal plane. So we see a mismatch between the anteroposterior size and the medial lateral. We can find external tibial rotation, and to compensate that, we can have a metaphyseal varus deformity of the proximal tibia, again to compensate the valgus of the femur. So there's a feature of patellofemoral malalignment, and also it could be found that many of these patients got foot deformities. What are the problems of sizing and rotation of this implant? So we got an internal femoral rotation with hypoplastic lateral femoral condyle, and so we can find also a trochlear band. So that is an increased size from the AP size to the medial lateral. So there's a mismatch. And when they try to find a good implant, a conventional implant for this patient, sometimes we need to change our sizes and our rotation. Sometimes in these patients, anatomical landmarks are hard to find, and the posterior congenital line, most of the times internally rotated. Light side is not reliable. It's very hard to find in the de jure C or D types. So there's a higher risk of implant oversize or malposition. First, we need to recognize the deformity. Second, when you use the sizer to know what size do we need, we don't have to put it on the bump, just middle to the bump on the anterior femoral cortex. We need to check your trials. When the size, you don't agree with the size because you see it's too big in the medial lateral, you need to put your size with your hands, the trial with your hands over the femur. Then you will find out which size is better for your knee. You need to be prepared to add some external rotation. And when you do that, many times, you need to tolerate some notching of the anterolateral femoral cortex. But you don't need to compromise the posterior offset. That could lead to posterior or flexion instability. I prefer to use a transapicondylar third anatomical axis because the sulcus, most of the times, is not detectable. And this has been published. So I use the transapicondylar anatomical axis from the medial epicondyle to the lateral one. This is the system that I use. I use the Genesis 2. The anterior and posterior cuts are in 0 degrees, and the implant comes in 3 degrees of external rotation. So if I need to add some external rotation, I use a sort of augment to the lateral side. You see a patient with an hypoplastic lateral femoral condyle. Good issue, if I need to downsize this one size, it doesn't affect the posterior condyles. It just affects the anterior surface. So what are the consequences of increasing external rotation? It could increase the flexion gap. And also, if you want to keep it without notching of anterolateral cortex, it would increase the size of the femur. That was stated with Emmanuel T-point. But we could accept some notching, not to oversize our femur. The tibia also got their problems. We got external rotation, a TTG distance that it's increased, and many times we got an increased varus. The classical ways to find the rotation are to put the asymmetrical tibial platform on our cut, but many times it's not matching the cutting surface. So we can use the medial side of the tibial tubercle or the medial third of the tibial tubercle. That's one of my landmarks. The other thing is, like Richard Scott said, to moving into flexion with the femoral trial put on and the tibial trial free on the cutting surface. So it will find his way. But many times, it is not easy to do that. New landmarks are the Kagi line, that is very useful. So I also use that with the medial border of the tibial tubercle. And Kim and Andrea Baldini have said that anterior tibial border also is a reliable way to get a good external rotation. External rotation greater than 35 degrees many times would require an additional osteotomy. We are carrying a study in our practice. We have focused on 317 TKAs in normal patients without dysplasia, and we compare them to 31 dysplastic knees in a gap of 4 years. The radiological analysis was the important issue. We used the Joule classification, and we didn't use a CT scan in the patients. We have no previous surgeries or osteotomies on the hip or the knee. Most of the patients were females and younger compared to total knee replacement. Almost 50% of the patients have a patellofemoral instability history. There's a high incidence of hip dysplasia, and we use always the same implant, a primary implant, a PS knee, using Gen 2. What we found, that 74% of the patients, we downsized one number of the femur, and in 10% of the patients, it was 2 sizes. We increased the femoral rotation in almost 83% of the patients, and we got notching of the lateral femoral cortex in 1/4 of them. We did a lateral facetectomy in 100% of the patients, and we just required 1 lateral release. When there were size mismatch between the femur and tibia in close to 50% of the patients, and just one complication when there's an arthrofibrosis that required a manipulation at 4 weeks. So it's the patient. Here we see how we deal with the 2 downsides of the femur. So does newer technology help in this patient? Well, it's difficult to recognize the deformity, and there are no reports in the literature of femoral or tibial malrotation using PSI, navigation, or robotics. As most of surgeons who utilize conventional instrumentation, experience is crucial detecting the deformity and adjusting surgical technique on difficult situations. Thank you very much.
Hi everyone, my name is Sun Li. I'm from the Department of Orthopaedics in Guizhou Provincial People's Hospital. Today, my presentation will focus on TKA for post-traumatic osteoarthritis caused by tibial plateau fracture malunion. These images showed tibial plateau fracture malunion. The goals for the surgical treatment of tibial plateau fracture malunion are as follows: restoring the mechanical alignment of the lower limb and the stability of knee. The surgical methods for the tibial plateau fracture malunion, including fracture reduction and fixation, high tibial osteotomy, tibial plateau osteotomy, and total knee arthroplasty. Among those methods, the indication for TKA are as follows: patient older than 50 years, severe bone defects, uncorrected deformity of knee, and a favorable outcome, severely functional impairment of knee, and post-traumatic arthritis. These are several technical challenges for TKA in tibial plateau fracture malunion, such as malalignment, bone deficiency, joint stability, post-traumatic stiffness, previous knee infection, the soft tissue problem, previous scarring, and internal fixation devices. These are also several complications for TKA in tibial plateau fracture malunion. Images in this slide show that the complications wound healing for TKA in tibial plateau fracture malunion. Tibial plateau fracture malunion usually has severe bone defect, which need bone graft, metaphyseal fixation, and megaprocesses to solve the problem. Unbalanced soft tissue is common in tibial plateau fracture malunion, which need ligament reconstruction and constraint processes in TKA. Systematic soft tissue release is necessary for limited joint mobility in TKA. Sometimes it is difficult to obtain a good exposure in TKA for tibial plateau fracture malunion. Therefore, we have to perform slip hole TTO. We should be aware of periprosthetic joint infection. Let me show you some cases for TKA in tibial plateau fracture malunion. This patient is 70 years female who suffered deformity, pain, and lived after knee injury for 10 years. Images show X-ray for full-length film of both lower extremities in AP and LP view. She had a TKA for the left hip and had a right tibial plateau fracture malunion. 3D printing model showed that the patient had severe deformity for the right tibial plateau. For range of motion in the right knee after anesthesia, images showed the postoperative X-ray for the knee. Images show the postoperative X-ray for full-length film of both lower extremities. The deformities of right lower limb was corrected. The video showed the postoperative function of the patient. The patient is a 60-year-old male who suffered left knee pain and dysfunction caused by knee injury for 2 months. He had a left tibial plateau outflexion. He had a severe deformity for the left lower extremity. In the CT scan, we can also see the severe fracture. In these images showed the bone defect in TKA, which solved by autografts implanted. Images showed the postoperative X-ray for the knee. We use LCCK in this case. The deformity of left lower extremity was corrected. These X-ray images showed the better recovery for the patient at 1 year after surgery. This video showed the function of the patient at 1 year after surgery. This patient is a 50-year-old female who had left tibial fracture with the left lower extremity. This image showed tibial plateau bone defect in surgical operation. Images showed the postoperative X-ray for the left knee. The deformity of the left lower extremity was corrected. The video showed the postoperative function for the patient. In conclusion, we should pay more attention to the indication of TKA for post-traumatic osteoarthritis caused by tibial plateau fracture malunion. Severe techniques could prevent the complication, such as the choice the incision, removing the internal fixation before TKA. For the prosthesis selection, we could choose the LCCK rotating hinged implant. Moreover, correctly osteotomy, soft tissue balance, and revision techniques are also very important for TKA in tibial plateau fracture malunion. Thanks for attention.
Hello everyone, I'm Dr. Gordon from Center for Joint Surgery, Southwest Hospital. I would like to share with you total knee replacement with extra-articular deformity. Complex primary total knees include severe varus knee, valgus knee, flexion deformity, stiff knee, overweighted and osteoporotic knee, and extra-articular deformity. So what is the EAD? So these are examples of EADs which are very obvious. We can see old bone fracture and malalignment. But these EADs are often ignored because it's close to the joint line and it creates the femoral varum. These deformities seem severe, but they are not extra-articular deformity. They are only intra-articular deformity. So what is extra-articular deformity? We need to draw a box from the supracondylar line and the tibia. So EADs means deformities outside the reticular. So this is an example of combined intra-articular deformity and extra-articular deformity. So we can see in the green box is uneven balance, which is intra-articular deformity, where the yellow line is not vertical to the box, which means that it combined with the EADs. So the second picture is an example of a normal knee. The green box is rectangular and the green box is vertical to the yellow line. The third picture means that there are no intra-articular deformity, but the yellow line is not vertical to the green box, so it contains extra-articular deformity. The common reasons for EADs include developmental disease, such as Gleason disease, and maybe heavy physical labor could create femoral varum, and endocrine reasons could be one of the main reasons. So this is an example of thyroid cancer. The most common reasons for EADs are trauma and bone fracture. Nowadays, we are doing more and more high tibial osteotomy, so which is another reason to create more axial deformity before total knee replacement. The influence of EAD to total knee replacement include it could be easily misled by deformity axis at intra-articular osteotomy of the total knee replacement, causing unbalanced gaps. If the deformity is more severe, it could lead to bigger unbalanced soft tissue. The third one is that if deformity lies closer to the joint line, it could lead to bigger soft tissue unbalancing. And the femoral deformity will create unbalanced extension and flexion gap, while the tibial deformity will not influence it. And the femoral deformity will influence the hip joint, while the tibial deformity will not influence the ankle joint. So how to correct EADs for total knee replacement? We could use intra-articular soft tissue lacing, and we could use extra-articular osteotomy, or maybe intra-articular sliding osteotomy. Some surgeons would ignore and kill deformity. So first is intra-articular releasing. For most of the cases, even with a bone fracture and extra deformity, if it is not severe, we could do inside joint immediate release. For example, this is a patient with 21 degrees of HKS angle, while the MLD FA angle is only 96, which means there's only 6 degrees to correct. So we could do a medial soft tissue release to correct the varus. And Dr. Ranwa said that extra-articular deformity is less than 20 degrees in coronal plane could be corrected inside joint, where you need to prepare a CCK or more constrained knee. No matter you crack the joint inside the knee with sleeve releasing or maybe with pec crusting, you are damaging the MCL. So maybe that some surgeon would not like to damage the soft tissue and use extraarticular osteotomy to correct the EADs. In some cases, if we correct the EADs with osteotomy, we do not need a total knee recently. And sometimes we need to correct the deformity with external fixation or maybe intramedullary nail. So if we correct the alignment with osteotomy, maybe we do not need to do a total knee replacement in the recent stage. And if not, we could do osteotomy and the total knee replacement at the same stage to relieve the pain. You can also use intraarticular sliding osteotomy. So the first example is that we do extraarticular osteotomy to correct the alignment. And the third picture is that if we do a medial sliding osteotomy, so we could also correct the alignment and do a total knee replacement in the same stage. So this is a case of extraarticular deformity. So when we are doing the distal bone cut and the proximal tibial cut, we have an unbalanced extension gap. So we do a medial sliding osteotomy, do a medial release and input the implant. So from the pictures, we can see that we correct the alignment and do a balanced total knee replacement. But most of the time, we need a CCK or maybe a rotation hinge knee to ensure that we have a stable knee. But if you do not correct the deformity, the patient can get a near stage fast recovery, but maybe a late revision. So in summary, we need to recognize the EADs and we need to correct the minor EADs by soft tissue releasing. The ideal solution could be that osteotomy intra and extraarticularly. When you're doing a case like this, you always need to prepare CCK and the hinge. But if you do not correct the alignment, it could be a fail in the near future. Thank you very much.
Thank you very much, Kiki. I would request you to proceed with the question and answer session.
Thank you, Professor Shahid. We have 3 questions in Slido, and also we have 10 minutes for question and answer. Okay. And I think the first question will be 2 questions for you, Professor Shahid. Yes. The question is whether the using of CAS is really will help in your case. And maybe this question also for other speakers, whether the using of CAS will help in like a complex primary knee arthroplasty. Please, Dr. Said, Professor Said.
If I can answer, I don't think CAS is going to help in these extreme deformity which requires soft tissue extensive release. So CAS is going to help you in getting the bony cut, but the problem here is extensive late presentation, extreme soft tissue deformity, whether as a varus, fixed flexion, and a valgus, and combined with bone loss. So you need to have the surgical skill of revision surgery. So somebody who's experienced in doing revision surgery can deal with that. So I tell my young consultant that you have to define whether a knee is a simple, complex, or challenging. So these are challenging knees, which requires extensive soft tissue release, and you need to have the armamentarium to deal with bone loss. And finally, you need to have constrained implant available. So my simple answer is that CAS does not help in my practice.
Okay, thank you, Professor Said. Now, how about you, Peter? The question for you is whether the CAS will help in patellar alignment.
Yes, thank you, Professor David Chun, for asking this question. He also asked whether gap balancing is more important or whether the patellar alignment is more important. I think, Oh, that's okay. I would say for valgus knee, I think we still aim at gap balancing, but we prefer to do more soft tissue releases over the lateral side because we don't want the final lower limb alignment to be in too much valgus. That will increase the Q angle and thus increase the risk of patellar maltracking. So for valgus knee, I do not accept more than 2 degrees of residual varus, residual valgus. However, for varus knee, I'm prepared to accept a residual varus of 3 to 5 degrees because with varus knee, the Q angle is not increased. The only problem is if we put the tibial cut in varus inclination, in order to have a balanced flexion gap, you probably also need to internally rotate the femoral component a bit. But our own study find that mild degree of femoral internal rotation to compensate for a slight varus alignment, it has no effect on the patellar maltracking. So we now do much less releases over the medial side for our varus knee. For valgus knee, we still do more soft tissue release over the lateral side in order not to have excessive residual valgus alignment. So my target is still on gap balancing.
Okay, maybe from another speaker, maybe Dr. Bing Yu or Dr. Gabriel, I think has already stated clearly that the cast will not help in rotation deformity, but how about the other speakers? Dr. Bing Yu, maybe, yeah, if it's cast will make you decide differently or will help in your case? Dr. Bing Yu?
Hi. Pardon me. Is there a question?
Yeah, because you state that your presentation state that your intercondylar nodes can be your landmark for cutting the distal femoral, right? So I ask you whether the cast will help in your case to determine better than your landmark.
In class?
Yes.
So our research is that for some varus knees, especially for some varus knees, the distal medial femoral condyle is worn. So the cartilage and the bone is worn. So if we still use the regular method, more bone or thicker bone will be removed from the distal femur, and that will raise the joint line and remove more bone. So we in the clinical in the surgeries we found that almost all the resection of the distal femur, the resection level is around the intercondylar notch ceiling. So that is a helpful reminding or landmark for us to check our distal femoral resection, especially for the young surgeons or the beginners to avoid some errors and mistakes.
Okay, thank you, Dr. Bing Yu. And Professor Sahid, there's another question for you about your decision whether you're going to use bone graft or you're going to use augmentation, metal augmentation, whether you can use bone graft for more severe bone loss. What is your cascade of decision making? Please, thank you.
Okay. So obviously the bone, there are two bone that are available. One is autogenous bone, and then if you have a bone bank, then you can use an allograft. It is obviously convenient for our patient and for the surgeon to use a metal augment, a metaphyseal sleeve, or trabecular metal cone. But in countries like Pakistan or other developing countries, cost is extremely important. So when we use bone graft, it costs less, but it is very convenient to use metal augment. And I love metaphyseal sleeve. It resolves my problem immediately, whatever the severity of bone defect is there, and you can mobilize the patient full weight bearing. Just to summarize, you can use autogenous bone graft, you can use allograft, but my preference now is to use metal augment. And in severe cases, especially where there is metaphyseal bone loss, I use metaphyseal sleeve. And in the 3B cases where the collateral ligaments are damaged as well, then the metaphyseal sleeve is combined with the rotating hinge type of implant.
Okay, thank you, Professor Said. And maybe we have still have 3 minutes, maybe for Dr. Gabriel Baron. And you said that in your case, the rotation alignment is the most is the big problem with the dysplastic knee. And my question is how you align between the femoral rotational to the tibial rotation, whether you use the method separately or you want to join it with the, when you do that the flexion extension testing. How is your method to align the rotational between the femoral and tibial rotational? Thank you.
Okay. Hello to everyone. It's nice to see you in this meeting and hope to see you live soon. It's the regular landmarks. I'm a conventional instrumentation guy. I use the regular landmarks as I show. I think the femur is the most, to get an adequate rotation, I use the epicondylar axis, the anatomic epicondylar axis. We need to remember that the posterior condylar line is between 3 to 5 degrees of internal rotation from that line. So we need to go straight to the epicondylar line. We need to neglect the posterior condylar line because most of the time it's internally rotated in that deformity. On the tibial side, most of the times I use the middle third of the tibial tubercle. Now it's easier. Then you need to, after that, you need to have your release of the soft tissue structures. The best, as we say, the previous presenter, the most important issue is to recognize the deformity. 99% of the surgeons, all around the world, we are using conventional instrumentations, and CAS or navigation or PSI or robotics. Most of the time, they don't need good information to achieve the programs of rotation. CT scan is a useful tool preoperatively to access that and to plan.
Okay, thank you.
We need to finish this session, and the time for the debate is on. So I'm extremely grateful to all participants and the faculty who've given a very nice lecture. And Kiki, you have conducted a very good discussion. Thank you very much.
Thank you very much.
Hello, everybody. This is Mark Clatworthy here from Auckland, New Zealand. I'm the moderator for the debate, Are the Days of a CAM Post-PS Design for TKO Over? In the affirmative, we have Jose Antonio Sandoan from the Philippines, and our President Nico Budaparama has chosen the best side of the debate, sort of biased there potentially. But Jose, I'd like you to tell us why the PS design CAM post is still the way to go.
Thank you very much, Mark. I shall share my screen right now. For most things, my good friend Nico and I would normally agree and would probably disagree on the same things. This is probably one of those few occasions where we've both agreed to disagree. And so I'm going to take on the position of being the posterior stabilized total knee replacement surgeon, as against my good friend Nico taking the CR. So this debate has been going on for quite some time. It seems to be an unending debate. And pretty much the debate has probably taken another level in that. Is it actually based on true science, or is it just basically based on religion, depending on whether you've actually trained being a CR guy or a PS guy? So we'll try to look into the advantages and disadvantages of either technique. And I would say that as is appropriate probably for these times, it's probably the same debate we're encountering with a lot of our friends and colleagues around as to whether to get vaccinated or not get vaccinated for COVID. So why is a posterior stabilized total knee replacement your better option? Looking at all the level 1 and level 2 studies as of late that have been included in the most recent meta-analysis and looking at all the functional scores, as you see here, comparing all these different brands of both the CR and the posterior stabilized knees, they have come to just a few basic conclusions. First and foremost, there's no significant difference with regard to functional outcome. There's no significant difference in terms of range of motion. There's no significant difference as far as the kinematics and survival rate of both systems are concerned. And so, why bother? Why even bother talking about a PS or a CR knee? As you'll see here, I will just highlight a few simple words for us to understand. As we know, orthopedic surgeons always want it simple. It's easier to do a posterior stabilized knee. It's more conforming. It affords better results. It has probably more predictable outcomes, and it's reproducible, particularly if you're talking about the function of the knee. We're probably looking at avoiding the risk of a complication, which is commonly encountered in CR knees, particularly in the long term, which is an eventual PCL insufficiency. So just looking at the keywords, we can come to the conclusion that doing a PS knee is probably easier and more reproducible and a better procedure to do compared to a CR knee. So it definitely is your better option, particularly if you're looking at patients who have significant flexion contractures of more than 20 degrees, a steep posterior slope of more than 10 degrees, particularly in this part of the world when we're dealing with female patients with small femoral component sizes, PCL insufficiency, particularly in chronic cases already, severe deformities in varus or valgus of more than 15 degrees in the coronal plane, and if we had patients who probably have post-traumatic arthritis or previous surgery to the knee, then a PS knee will probably be your better option because you're able to achieve better balance. And more importantly, when you're dealing already with knees that have significant bony defects. Now, while there has been documentation already with regard to conversion, if the initial plan was to do a CR, then it was eventually converted to a PS knee. This has happened in a study where they actually had a conversion rate of approximately 9%. In other studies, it ranges from 6% to 13%. And the major challenges that eventually led them to convert to a PS was the presence of contractures, a steep posterior slope, and a small femoral component size. The most recent meta-analysis looking at level 1 to 2 studies comprising 36 articles of over 4,000 patients, close to 5,000 procedures. What ruled in favor of PS knee was that, of course, while it may be insignificant, but there was pretty much a better range of motion, better WOMAC scores, and better knee society functional scores in the PS knees compared to the CR knees. So altogether, looking at these kinds of deformities that you will see, like more than 50 degrees deformity in the coronal plane, already the steep posterior slope, most likely subluxation because of PCL insufficiency, you know that using a posterior stabilized total knee replacement will be your better option compared to a cruciate retaining knee. More importantly, regardless of what system you use, what's most important thing for us is we make the right decisions and that we only do what's right for our patients and do it right the first time. Thank you very much.
Thank you. Nico, away you
go. Yeah. Where's my... Other days for Campos PS design for TK over? For me, definitely yes. This is my disclosure. If you look at the demographic, it is like a pyramid that a lot of PS done by low volume surgeons or general orthopedic, while the CR done by high volume surgeons and arthroplasty expert. Why do surgeons prefer PS? Because more forgiving and no need for proper soft tissue balancing and higher flexions. It is based on the fluoroscopic data from Richard Comstock. It seems like that Tony is going to win this debate. But in reality, scientific and data evidence is the answer. We know that each designs have their own advantages. And disadvantages PS such as anterior knee pain and crepitations, where impingement as post-phatic fractures, patellar clung, and condylar fractures depends on the size of the box and the higher revision rate. If you look at scientific and data evidence, this publication from Michael Menachini, it shows that 4 things that we have to consider: there's retrospective meta-cohort studies, prospective randomized studies, patient satisfaction data, and the National Joint Registry. Matthew Abdul looked at more than 8,000 knee in the Mayo Clinic. He shows here that the CR prosthesis has a 15 years better survival rate. And the strength of the study is unbiased. Look at the registry data from a single institution. Well, if you look at the simultaneous bilateral 1 CR and 1 PS, there's no significant differences in functional score, range of motions, or patient satisfaction. It's slightly superior in the knee flexion score in the PS, but does not appear to impact the PROM. The prospective randomized study from David Scott shows that the CR has an excellent clinical, functional, and radiographic outcomes comparable to the PS, but less complications. This cadaveric study in 2020 shows that significant increase in varus laxity at 60 and 90 degree flexion that correlate with increased tibial wear in PS that not seen in the CR. So about patient satisfaction data, this publication shows that satisfaction scores show no difference among the groups. So I think the answer now is the National Joint Registry. In UK, is the CR much more than the PS, but in Norway, it's about 6 times more the CR. New Zealand's about 80% CR. How about the Australian registry? Shows also here that CR is more than PS, but 45% higher revision for the PS. And the PS with no patella is the most efficient compared to the CR with the patella. In Netherlands, that PS TKA were 1.5 times more likely to be revised, especially in younger than 60%. It's published by Rob Nelson. How about in USA? There's not so much difference, though that PS is nowadays gradual decreasing in the trend. So why is Campos PS designed a vestigial organs? Because newer tibial insert with enhanced sagittal conformity with the anterior lip designed to substitute for the PCL rendered the post-cam is obsolete and superiority of survivorship compared to the PS design implant. These 2 publications from 2021 that CR lip bearing is safe and effective solution for the PCL laxity and correlations between the presence of medial pivot and the ultraconcurrent and higher post-operative scores. To my conclusions, no scientific evidence to support that the Campos mechanism to replace PCL. And the Morse registry data indicates favorable toward the CR. In my practice, 80% CR and medial pivot and 20% the PS. So if you ask, I can ask which one you think that is going to win, former racers or runner, you can decide it by yourself. Thank you very much for your attention.
Thank you, Nico. So, Jose, now you've got 30 seconds to negate what Nico just told us. So, do you have a reply to his talk?
Yes, I think the bottom line here is, as far as functional outcomes are concerned, looking at the long term, there seems to be no difference between the PS and the CR. I think for most advocates of the CR, there's always been an issue with regard to wear of the post and an eventual fracture of the post at some point. But this was more a design issue and a material issue that's already been addressed as of late. So we're using better polyethylene materials right now for insert, even for the post. That's eventually led to less wear as far as that's concerned. Now, looking at rollback, which is a very important function of the knee, particularly once that's replaced. Basically, studies have shown that the moment you have your PS knee, your rollback is a lot more simulated compared to the CR knee. And I think more importantly, the biggest issue there is balancing. If you're a CR person, I think at the back of your mind, you should always have that backup plan, which is to do a PS, just in case your PCL recession will not be enough for you to be able to get enough soft tissue balancing, particularly if you're dealing with severely contracted knees. So being trained with both, will definitely help. But if you're just starting out, I think for ease, particularly for low demand patients, PS is still the way to go.
Nico, do you agree?
It's a good, Mark. I mean, like, some point I agree with Tony. For example, for the young surgeon who start to do an arthroplasty, a knee replacement especially, so it's more forgiving to use PS. But as I will always say to my fellows that, a knee replacement is different than a hip replacement. Knee replacements, it is like an arch, when you have to balance the knee. So whenever like my I show you on the pyramid. So later, when you done about thousands knee replacements, then you would like to enjoy how to do the operations like an arch. Then you're gonna move to the CR, and especially if you look back to the registry, that is the main concern. And you can say, oh, in my clinic is better the PS or whatever. Registry tell. So that is it.
Yeah, and I think you're right. And I think what's very interesting, if you look at the geographic spread, the PS knee is most commonly used in America. And in America, the most common technique is to do a femur first measured resection technique, whereby you cut the femur and tibia independently and hope they marry up. And when they don't, then therefore you've got a more constrained device to do that. And so I think that's quite interesting. And if you look at other parts of the world like ours and Europe and Asia, where people are balancing the knees better, there's CR. And certainly that's something I've seen amongst those surgeons. As you get more confident with the procedure, you tend to trend towards a CR knee. So just for everybody there, we do have a poll on Slido. And so if you can just go to the Slido app and just let us know who you think has won this debate. I think the other interesting thing is I think the person who's done the most work on survival is Chris Fatullo out of Australia. And there's always been this belief for those who are the PS designers or users that the PS is only done in the poor knees. So what Chris did from the Australian registry is take only those surgeons that did CR and only those surgeons that did PS and showed a substantially better survival with the CR knee. So I think also a lot of that technology we've seen today with the robotics and navigation, where you're getting intraoperative feedback of the soft tissue envelope, will enable you to do a better CR knee and maybe not need the PS as much. And certainly in my own hands, I very rarely do a PS knee because of the technology I utilise. So if we have 30 seconds to go, so let's go to Slido and let us know who's the winner of this debate. So. You've always got to let the president win, I think, particularly in Asia.
Yeah. He deserves that honor.
But I think you've done a fantastic job. Well done, and it's great to have a debate. And to Nico, well done organising this meeting. I think it's incredibly amazing to have live surgery beamed around the world. We probably thought we'd never be doing this pre-COVID, and it's a fantastic experience. So thank you, everybody.
Thank you, everybody. Thank you.
Thanks, Mark. Thanks, Nico.
Thank you.
Zoom in कर. Zoom in. अभी हाँ कर. मला आधी दाखव सर.
Okay, you're live now, gentlemen.
Parag, we are live now. You can now start describing the patient that you're operating.
Yeah. Hi, everybody. Hi, Shahid. Hi, Gabriel. And hi, Jose. Good to see you. I am Parag. We are doing the live surgery from Pune, India. And this is a 61-year-old gentleman. You can see the X-ray. It's a malunited upper end tibia. He had a fracture 20 years ago, which was treated just by bone grafting elsewhere. And this is a fixed varus deformity. You can see this is the long leg view. So all his varus is in the joint and in the tibia. So his MPTA, medial proximal tibial angle, is 72. The LDFA, lower distal femoral angle, is 87, which is normal. So he has a substantial varus in the upper end tibia. So my plan is to do conventional prosthesis, cemented next-gen components. We will have to stem the tibia. So that's the plan. So I just want to show you the video of the patient. Can you see this? Shahid?
Yes, we can see that. Varus lurching gait.
Zoom in, zoom in. Yeah. So this is a fixed varus, as you can see, because of a malunited upper end tibia. Gloves there. Gloves.
And do you have a plan for bone loss on the medial tibial plateau, Parag?
Yes. So there will be bone loss, so we will build it up with screws. We'll see what is required. CD player लाओ तो कर. Okay. So we will start the surgery.
Parag, I just came out of the debate with Nico about the CR and PS. So it's good you're doing this surgery because I know you're a PS guy, and this will just affirm my position as well.
I just cannot hear you. Speak a little loudly.
Yeah, I just came out of the debate with Nico.
Yeah.
On the CR versus the PS total knee replacement, and I'm glad you're doing this surgery with knowing that this patient has significant bone loss and that you're doing a PS. I know you're a PS surgeon, so
yes,
this will help affirm that position.
Yes. What was the conclusion of the debate?
Well, I think Nico won that debate. We have to give that honor to the president.
Okay. So this is the patient. You can see this is a fixed varus deformity, partly correctable. So I'm going to go by an anterior midline approach. And this is a previous scar, which is seen on the medial side. Knife. Starting left knee, next-gen Zimmer with extension rod. So I'm taking an anterior midline incision. So I always change the knife after the skin incision. Camera 1. So I do a medial parapatellar arthrotomy. And I mark this with methylene blue, so that the capsular closure becomes easy later on. Camera 2. Sir, thumb. तू मागे सर 1 minute. So this is a gutter release. This is the medial and the lateral gutters I'm releasing. I first prepare the patella. I'm always resurfacing the patella. Shahid, can you guys hear me?
Yes, perfectly.
Yes, we can hear you.
So just a little bit of response, so I know that you guys are around. So I do a circumferential cauterization and just prepare the patella.
So Parag, you did say you resurface all your patellae.
Yeah, 100%, unless the thickness is small in rheumatoid patients. This the preparation is done. I'll come back later and do the resurfacing. So you can see the joint is very light. So this is the joint now. The camera 1. Great.
This patient does have a flexion contracture, Parag. Am I right to assume that?
It's going to be to release the MCL, the medial collateral. Camera 3. Yeah, so now I'm releasing the camera 2. So I'm taking a thick sleeve of the MCL Shahid, so that later on the closure becomes easier. Vicryl number 1. Counter. So this is a old surgery done, so there's a little bit of fibrosis here, so I'm just going a little slow. Camera 1. Yeah. So my plan is to do an all intra-articular correction, because the deformity is less than about 20 degrees. Very. Osteo. So my release at the moment now is done, Shahid.
Parag, do you go posterior medially as well?
I will go posteromedially also later because of the severe fixed deformity. So now this is done. I'm going to show you a step which I do, because this is going to require a severe release. Number 1, device. So I'm just going to tag the MCL. So that it doesn't retract behind. Camera 1. Can you see this?
Yes, we can see very clearly.
So now this is
good picture quality.
It does not retract behind. That's the idea. Camera 1. Okay. So now this part of the release is done at the moment. Now we will clear the intercondylar notch. So I am a PS guy. As I told you, we'll remove the ACL and the PCL. And anyway, the deformity is so severe, I wouldn't even venture or think of doing a CR knee. मागे बघतो आता तुला दिसते ना ठीक आहे तू मला दिसते. So this is the intercondylar notch which I'm completely clearing now. This is the white size line. And this is my entry point with the patellofemoral articulation here. So this is where I do. So this is the intramedullary jig I'm going to use. This is the entry point. Here. Fine. Madam, sang na please. We do the suction of the intramedullary.
I think we lost his connection, Saeed. Yeah, while we're waiting on the feed, perhaps we can ask you, Saeed and Gab.
Yes.
Like, what are your percentages for doing CR or PS, or what would be your criteria for selecting whether you do a CR or PS for a patient?
Jose, you see that patient in India and Pakistan come with severe fixed deformity, and they have a combination of deformity. They have a combination of fixed flexion deformity and a varus deformity. So I'm 100% PS guy. And majority of knees are varus. So in addition to what Parag is doing, I go more posterior medially rather than going distally on the MCL, which was initially proposed by Sir John M. Saul. And I find it easier to correct the deformity, and I would even go to release the semimembranosus and pes and serina. So there's no instability, but you get intraoperative correction. And then you have to release the bone which are attached to the MCL and remove the osteophyte, and posterior medially the osteophyte of the medial femoral condyle. And these really help in correcting the varus deformity. So that's my take. I 100% do patellar resurfacing unless the patella is very thinned out, but 99% of my cases are patellar resurfacing.
So my distal femoral cut is now done. I always do the distal femur first and then the proximal tibia, like sectional rotation. Flex. Cautery.
Parag, how many degrees did you cut the distal femur?
So that was 5 degrees valgus.
Perfect.
So I measured that preoperatively, the difference between the anatomical and the mechanical axis of the femur, and that's 5 degrees because I'm using the conventional instruments.
Okay.
I'm removing the lateral meniscus. I take care of the lateral geniculate here. So are you
How
able
about you, Gab? Are you a CR or a PS guy or a selective?
I was trained with John Insall, so I do 100% of PS knees. In this particular case, I agree 100% of what I mentioned. I do resect my osteophytes first on the femur, on the tibia. I do femur first, and agree. I do just a medial and posterior release, very of the deep MCL. So I leave the more inferior MCL or superficial MCL to the end of the procedure to see what I get. I don't want to stress my MCL release at the beginning of the surgery.
Gabriel, are you a measured resection guy or a gap balancer?
But classically, I will be a major resection guy, but I use some things about the gap balancing when I need to balance my posterior gap and my extension gap. I do some releases. I try to do some gap balancing techniques, but I am a major resection guy.
So camera 3, zoom out. So now I'm going for the proximal tibial cut. My landmarks are the medial third of the tibial tuberosity, the center of the ankle, zoom out, and the second toe.
Just a reminder to the participants, if you have questions, you may use the Slido app. You can post your questions there, and the members of the panel and our surgeon, Dr. Parag Sanchetti, will try to answer them. So please post them on the Slido app.
Camera 1. So this is, I'm cutting at 9 mm now. I've not been able to completely subluxate the knee, so I'm just going to finish the cut and then subluxate the knee. Yeah.
I think what you were mentioning earlier, Saeed, about really doing that posterior medial release, particularly in severe varus knees with a flexion contracture, that's really what helps bring your tibia forward, particularly when you start your tibial preparation.
Sometimes when there are lots of osteophyte, I would complete my posterior medial cut after doing the proximal tibial cut. So similarly, first the distal femur, proximal tibia. If you are able to dislocate, fine. Otherwise, do your proximal tibial cut and then go posterior medially. Obviously, if you have dislocated the tibia completely, then the chances of you getting a proper 90 degrees cut on the tibia are very high.
So you can see this cut here. You know, the medial side, I've hardly cut anything. The lateral side is the one which is more. So this is all, you can see the bone loss here. Now I'm removing the remnant of the lateral meniscus because I could not subluxate the entire knee.
Gab, just in relation to your talk earlier about dysplasia as well on the femur, usually in a lot of severely varus knees with a bit of contracture, there's a bit of a defect as well on the posterior medial side of the femur. How would you do any special imaging before surgery just to anticipate the possibility of using augments in that area to restore your external rotation?
After some years, I think the X-ray is enough, but CT scan is very helpful to get that. I measure my anatomic and surgical transapicondylar axis with the CT scan. Then I try to get the relationship between the posterior condylar line and the epicondylar axis. But most of the times, I think it's very easy to do it intraoperatively. I think that CT scan is good to get the bone defects if you've got any doubts, mainly in these the fixed defects that sometimes is very hard to see in the regular X-ray. I just want to make a little comment to release the medial side of the MCL. As we said, it's a very
easy technique after your tibial plateau cut. Don't do before you do the cut. If you do it later, it will be very easy. You release the PCL, the deep MCL. You don't need to go to a far release of the superficial. So you will be very safe, and you will have the deformity most of the time corrected in that deformities. You don't need to do any other release in 80% of the cases, 85% of the cases. So it helps. It's very helpful.
So this is a size 5 Shahid.
Okay.
And there's a little medial osteophyte, so I'm slightly undersizing because I want to lateralize the tibial component.
And then you will have no bone defect on the medial side, and you'll not have to deal with the medial bone defect with undersizing.
Yeah.
So undersizing is going to help you in correcting the deformity as well. Parag?
Lateralize, that's correct. And these are the osteophytes. These are the extra osteophytes I'm removing, so it also helps me in my medial release. Can you see this?
Parag, can you tell the audience how did you calculate your tibial tray rotation at this stage?
I go by 3 techniques. One is I see the anteromedial and the anterolateral border.
Okay.
And then there was a rod which I dropped below, which goes with the medial tuberosity, camera 3, and which goes straight down. So this is what it is. And then the anteromedial and the anterolateral border, I match the component. Yeah. मार्क करून गेलं ते नंतर काढू आपण. मागे घेऊ. मला ड्रिल द्या साधन.
Do any of you guys still use the medial third of your tibial tubercle like as a secondary landmark, assuming there's no rotational deformity of the proximal tibia? Aside from the drop rod that determines, the drop rod corresponding to the center of the ankle or the second toe.
Gabriel?
Yes.
You still use that, Gav, the medial third of the tibial tubercle?
I use a medial third, and some, if the tibia is very externally rotated, I can do just posterior to the tibial tubercle. You can go a little bit medial, but most of the time it's okay. It's a good landmark.
Yeah. So what happens is this, just to interrupt, there is a lot of sclerotic bone here. So I'm just, removing some of the sclerotic bone. Otherwise, once you broach it, then it can have a fracture. Okay. This is the broaching I'm doing now, and then we will finish off the reaming right now. Reamers, please.
Will you put in drill holes on that sclerotic surface as well, Parag, just before you cement?
Next. Well, since there is a bone defect, which is more than 50%, I want to use an extension rod. Akitiya sister. 11 final. 11 rod. Chala. Kada. Mark karna ra maage. Chala. Osteotome. So now I'm going to show you something. This is the extra osteophytes which I am removing. We will now do the balancing in extension. Traction. So you can see here now, it is tight in the medial side. It's opening on the lateral side. Lateral is opening quite easily, but medial is tight. Retraction. Can you appreciate that, Shahid?
Yes, we can see that, Parag.
Medial is tight. So now, camera 2, I will show the figure of 4 release. Camera 1. So you can see this figure of 4 has been...
It's a posterior medial release.
This is an important part of the release on the posterior medial corner. And camera 1 and 2 PIP. So you can see here, I can go all the way posteriorly, posteromedially. So this is going to help in the release. Okay. Dippler. No problem. 3 degree. So my femoral component is complete. Femoral tibial preparation is complete now. Now I'm going for the femur. So this first I use a fixed 3 degree external rotation guide, and then I go by the parallel to the tibial cut technique. So what I want is a rectangular gap here. So if you see, it's slightly trapezoidal. It's less on the medial side, and it's more on the lateral side. So I'm going to slightly externally rotate the tibial component. Yeah. So this is now my posterior reference. This is a multi-referencing system, pi soda. I will just slightly dissect the suprapatellar pouch, only the area where my tibial component, femoral component will be coming. I do not remove much of the suprapatellar pouch. It leads to some stiffness, only where the femoral component, the phalange would be.
Parag, do you use the transapicondylar axis also to help you in the rotation of the component?
Sorry, come again?
Do you use the epicondylar axis also to check your rotation?
Right side line, the epicondylar axis, but my main is parallel to the tibial cut technique, the Ranawat method. So that is what I believe in. I always mark the white sides line and the epicondylar, but I also go by parallel to the tibial cut technique as my primary method to gauge the rotation. So now I've got the anterior reference. I'll just show you. You can see here, and the posterior reference. So these are the two references, and this is parallel to the tibia. So now I use the Ranawat block, which is spaced here, pin. खाली किती है? हे किती आहे? आणि खाली पुढची द्या. F. So I'm going for a size F, which fits properly. Pin, yeah. One second. Yeah, pin. So now I finish off the posterior cut. The important thing here is to protect the MCL as well as the popliteus. Sometimes in that you can cut the popliteus. So now you can see that this is the partial notch cut I am finishing off. These are the peg drills. So my anterior and posterior cuts are now done with this APCC jig, the Ranawat jig. And the patient also had a lot of fibrosis posteriorly because of the old fracture. And this is a good opportunity to remove that. So now you can see the notch cut. Notch cut. Hammer. Yes. This is the notch cutting and the chamfer cutting jig. So my femoral preparation is complete. I will now go for the posterior release. Quadri. हे सगळं उचल खाल्लं नवीन फ्रेश फॉर्म. So now is the time to do the posterior release. I just bend the cautery tip, you can see here, and then I go all the way posteriorly to do the release, and my colleague Dr. Kailash just blocked the femoral canal with a bone peg. So now the femoral component preparation is complete. Cocker there. There are some osteophytes posteriorly which you could see on the X-ray as well. Just removing that. Trial. Hammer. Yes. Yeah, so this is flush laterally. So now I'm using a 10 poly. See, the deformity looks corrected and it's quite well balanced. This is the patellar tracking. I'm quite happy with that. Now we go for the patellar preparation. I do the patella freehand, whichever turn up, please. Any questions, Shahid?
No, very nicely done. Obviously, there are many ways of dealing with the deformity, but you have developed a system and you have shown very nicely correction of deformity. We see similar cases every day. So we have similar pathologies. Jose and Gabriel, you want to give any comment and question to Parag?
So no, it's. I think that the steps are the same. Maybe the how do you do the steps? Maybe sometimes it's different. Did you have full extension? Because we didn't see very well from here.
I'll just show you again. Just a minute. The bone is sclerotic. I'm just finishing from the patella.
Saeed and Gab, do you resurface all your patellae? Just
100%.
100%. Same here.
There are some good studies about some registries about if you resurface the patella if you do a PS knee, it's safe to resurface the patella in 100% of the cases. If you're doing a CR ultracongruent, you cannot resurface the patella. Also, it's a safe procedure. But to get the patient, younger patient, not resurfacing, or to have a selection with which patients are you resurfacing, it's not a very proper selection. All or nothing, I think it is.
So I always do resurfacing. And obviously,
this is a full extension.
Perfect.
Yes.
So, and this is the flexion. The patella is tracking very well, no thumb technique, and it looks good. So we will now start with the cementing. We will first cement the femoral component, and then we do the tibia along with the patella. And I'm going to rod the tibial component.
Just on the topic of resurfacing, I think close to 60-70% of patients with degenerative osteoarthritis will most likely have bicompartmental disease. It's always either medial compartment or lateral compartment OA plus patellofemoral compartment OA. So I think for most cases, patellar resurfacing is definitely warranted.
Jose,
they may come back with anterior knee pain, then it's hard to justify to the patient as to why you have to go back inside the knee and resurface the patella.
So in our part of the world, patellofemoral is the first joint to go with varus deformity. And people have had problem with anterior knee pain because they have been putting their tibial and femoral component in malrotation. So it was not the patella, it was the malrotation of the femoral and tibial component that was the culprit. But if you put it correctly, in my 25 years experience, I have never regretted putting resurfacing the patella. Never.
I agree 100% to you that patella alignment is about femoral and tibial rotation. I think resurfacing the patella will help you, but there are hundreds of patients, millions of patients in registries that are not resurfaced that have very good outcomes. If you are using CR knees or ultracongruent knees. But I think the patellofemoral alignment is a matter about femoral rotation mainly.
And if you're resurfacing occasionally, then you're bound to make more mistake rather than if you're doing it every time.
Exactly. 100% agree.
Camera 2. So now we are injecting, we use always the cocktail, the periarticular injection, which is a combination of bupivacaine along with morphine, adrenaline, and cefuroxime. We do 40 cc deep and 20 cc superficial.
Parag, do you inject the adductor canal intraoperatively?
We do the IPAC and the adductor canal block, both.
Perfect.
Our
Parag, your preference of cementing the femur first, is there any particular reason to cement the femoral component first?
Yes, I'm going to do the femur first. That's how I do it.
Any particular reason or preference?
No, that's just the way, I've been doing my knees.
Okay.
People ask me why not the tibia first. But then once I get the femur in, it's easier for me to get the tibia and then get the exact component of the size of the poly. You do the tibia first, Shahid?
Yes, I do.
So this is the injection. Now I'll finish the wash. How much are we doing on time? How much time do we have?
We have time. As soon as you cement the component, then we might just...
Sorry?
We have time for cementing. That's not a problem. You're on time.
Shoot, please. Start mixing. Count ka hai? Stop. काढा वरती मांडी उचल फेकून दुसरं मांडी उचल fresh punch.
Parag, can I ask you a question? This pulsatile thing that you've used, where was it powered from?
Yes, Shahid.
The pulsatile lavage, it seemed to be a reusable thing. So where is the power coming from for this pulsatile lavage?
And use it. We don't use a disposable one.
It seems like it's voice activated, Parag. Kind of, yeah.
Assistant activated.
Right.
So the bone is nice and dry, you can see here. So we are ready to put the femoral component. Cement ready?
You've made some drill hole on the tibia, isn't it?
Yes, I put the drill holes on the femur as well as the tibia. Sister la dena, tu ito.
And you always use antibiotic impregnated cement, Parag?
Yes, always, all the time.
Yeah.
Start mixing tibia 40.
How about you, Sayed and Gab? Always antibiotic cement?
Always, yes, I do.
Start mixing.
It's amazing in the US that it's so expensive, a pack of cement with gent, compared to the rest of the world.
Very true.
Sister Getil, can you help here? Start mixing tibia. Plus.
Also, you use 2 packs of cement, Parag?
Yeah, we use 2 packets.
Yeah.
And since I'm going to put the rod on the tibial side, I'm using 40 on the tibia, and because I'm doing the patella also with it. And this is a size 5 of the femur, size E. Mota punch. 40 mixing, sister.
If this were just a straightforward standard total knee, Parag, would you still use 2 packs of cement separately for the femur and the tibia?
I would use just 40, one mix.
Just 1 mix, okay.
Yeah, just 40. 10 trial. Components open. So now I'm just taking a trial again. Give me 12 poly. 12 poly. It was initially 10, now I'm trying the 12. Oh. Real trial with the rod. So I've got a 12 now. So this 12, I'm going to go for the 12. It's now very well balanced. You can see it's a full extension. The tracking is good. So my final size of the poly is going to be 12. Lift it up. Bara poly open. Mota punch. Real trial. Posterior spike. Great. Yes. इकडे दाखव rod लावलेलं. Rod दाखव. So now we put the extension rod. Curve curate. तो कॅमेरा हल्लाय आपण. Always important to remove the cement posteriorly. Yeah. Punch. Posterior spike, fresh punch. Now I subluxate the tibia and now I go for the tibial preparation. Soda. Wash. Wash, please. ते पकडणार आहे. सचिन कॉटली तुझं काम नाही आहे ना. हा पाय पकडतो का? Start the jet. Pipe pocket and start the jet. Please hold the leg. Stop. Drill. Drill game. So now we will finish off the drilling of the sclerotic bone. Can you see?
Yes, yes, we can see that.
Screw there 20s, huh? Screw. Bus. 20 screw. Bus. Drill. Flex. The pipe pocket, please. Now for this bone defect, which is seen here, with the side में camera 1, I am going to build it up with 2 screws. Cement ready, Shahid, what do you do for your bone defects?
I don't use screws, but if it is significant, then I use a wedge and a stem. But for more significant bone loss, metaphyseal bone loss, I have a experience of using metaphyseal sleeve.
So I'm using 2 screws because the defect is about 5 millimeters.
But because you've already got a stem, this amount of bone loss can be dealt with some cement and a stem.
Okay. Yeah, bara open. So now I'm just going to check the screw is fine. It's not coming in the way. Camera 2. Camera 2. Yeah, this is good. Camera 1. Genta. Genta, please. Real trial. So I always use gentamicin again, even though it is a gentamicin loaded cement. I quickly just put a trial first just to check that whether the component is going in well. It is going well, so no problem. So now I'll start the cementing. Suction in the canal. Yes. So I always do digital cementing, a very conventional technique. The important thing is I want metaphyseal cement, copper, concrete. Shahid, just tell me exactly how much time we have.
I'm not sure, but I think if you can put the cement and implant, I'll let you know in a minute.
On the component as well.
Probably have around 10 more minutes. Parag, then we'll start entertaining questions. Or 24 minutes, in fact, yeah, because the session should end at around 7:20. So a good 25 minutes, Parag.
So now I've packed the cement to the metaphyseal area, and now my component will go in, cross piece. So it's fitting well now. Just removing the excess cement. 12 poly. So, you can see the bone defect is also completely filled up now.
Yes, very nicely fitting.
So it's the posterolateral cement is usually left there. So I'm just pulling the tibia in front, and my colleague Dr. Kailash is removing that. So the cement is removed. Poly. Penta. So yes. Clean the base plate, and again we are a big fan of Genta. My father taught me this, and we always use this as holy water. That's the gentamicin. And this is a 12 poly. Tranexamic acid. So we are ready to reduce tranexamic. Cut. First. Lift up. Sodna. Open na. So it's a little tight. Yeah, soda. So now it's reduced. Soda. So you can see now it's reduced well. I got full extension. It's balanced well. I'm just waiting for the cement to set, and then we will check the mediolateral balancing. While this is being done now, I have to finish the patella. So my colleague Dr. Kailash is holding it in full extension, so that is also helping for the pressurization of the cement. Shoot. We shoot. Stop. Drag.
We should get one of those voice-activated things, Parag. I think it's a patented thing for you.
So I always use this 3-peg patella. I have another joint called Indus, which has a single peg patella. Yeah, patella. Yeah. So, taga it. More pakad. Spatula. Right, sir, please. We are pressurizing the cement in the patellar component now. Yeah, so while now the cement is being set, we will go for the superficial periarticular injection. The superficial has mainly bupivacaine and normal saline, while in the deep we have adrenaline, morphine, and the antibiotic cefiraxime as well. Do you use periarticular injections, Shahid and Jose?
I don't use, we have a multimodal pain management system, including epidural infusion, which my anesthetist team is in charge of pain management. So we have combination of oral, injectable, and epidural. And we continue epidural for 48 to 72 hours. So we can fold it, we can give a bolus. So the idea is to give a sensory block and not a motor block. So the physiotherapists are very trained. So they stop the infusion 2 hours before they are coming for physiotherapy. After physiotherapy session, they will give a bolus. Okay. So the floor doctors are trained to do that. So we have post-operatively twice a day physiotherapy. So morning it will be stopped 2 hours before the physiotherapy. They have physiotherapy sessions and an epidural infusion, and then in the afternoon they have a stop. Parag, how are you pressurizing this pulse device? There's a motor behind or what?
Partly ulti kara सांगतो का तुला?
I still do a periarticular infiltration, but I usually use ropivacaine rather than bupivacaine, and I mix it with saline and morphine as well. We're trying to keep the epidural inserted as short as possible, and of course, still with a multimodal analgesia protocol, both consisting of oral and IV pain medications. Yeah, but the periarticular infiltration definitely helps.
Yeah, we've been extremely happy with the epidural infusion, and we dilute it. And in the epidural, we have tramadol and some other combination, which reduces the amount of local anesthetic that you require.
Yes. Okay. So,
I guess with the trend now in short stay surgery, and more people are shifting to probably even shortening the period of having an epidural catheter in. So
this is was a fixed varus deformity. We could correct it. Zoom out. So now you can see it's absolutely well balanced extension. It's full extension. We got a 12 poly. Just waiting for the cement. Yeah. So, gloves. So we also inject tranexamic acid. We give it. We just infiltrate it a little bit, and the important thing is tranexamic acid has really proved to be very beneficial, and we always use it.
We give IV tranexamic acid.
One dose is given initially just at induction, and then this is the tranexamic acid. We just kind of, a little bit infiltrate it, as you can see here.
How's your dilution of the tranexamic acid, Parag?
Sorry?
Your dilution of the tranexamic acid when you use topical.
The dilution, madam, kitne apan karte?
Yes, of the tranexamic acid. How many units to, how many milligrams to use per syringe?
2 grams is what it is now. And 1 gram is given at induction. So this is instilled, and this is just, what you're saying, the capsule and the superficial area just infiltrating. We do not dilute this. Cement set. So I'll just show you the flexion now, suction. So it's well balanced. In full extension, completely balanced. Varun Dako. Can you appreciate?
Yes.
Good. So we are just waiting for the cement to set, and then we'll start the closure. I just want to show you one more thing. So if you see the stitch which I had taken, that helps to keep the MCL intact. Can you see this?
Yes.
So the whole layer is intact here, which will help me for the closure. Otherwise, what happens in such a severe deformity when you're trying to release, the whole thing can retract back. So this stitch is very useful for me to prevent the medial capsule from retracting behind. Set. So
as for closure, Parag, would you close it in flexion or in full extension?
So we close it in full extension first. So we take interrupted layers first and then continuous layer. I always use a drain for 24 hours.
So obviously you're using a tourniquet here. Do you release the tourniquet before closure or release it after closure?
So I will release the tourniquet once I finish the capsule. And even though, I've been told that tourniquet should not be used, but I always feel it's comfortable. Usually the knees, which I do, take about 30 minutes, and that's a good enough time to keep the tourniquet. I have not seen much difference with and without tourniquet. What about you guys? Do you use tourniquet and drains all the time?
I use tourniquet. I have stopped using drain for last 5 years, but I release tourniquet to see the deep bleeders. So I'm not too concerned about superficial bleeding, but any major bleed. So I've had no problem with not using drain. One of the major advantage has been that post-operative blood transfusion has reduced. So TXA and no drain has really helped.
I use tourniquet in all my patients. Most of the surgeries are less than 60 to 65 minutes. I don't use suction. I don't use drains for 15 years. I use tranexamic acid intravenously, 3 doses, 1 gram previously, 1 gram at the end of the surgery, and 1 gram 4 hours after they leave the OR. No transfusion, and the patients, most of the 75% of the patients are discharged the day after the surgery. No drain.
Gabriel,
I give tranexamic acid as well, just before incision. It's usually just immediately after induction. So that's 1 gram of IV tranexamic acid. And then, of course, inflate the tourniquet. We release the tourniquet just before closure, and I don't use drains anymore. Haven't used drains for quite some time now.
Jose and Gabriel, if you come across patient with bilateral severe deformity, do you do bilateral simultaneous or stage or interval bilateral?
Yeah, so Shahid.
Yes.
So now we are doing the closure in interrupted layers, and then we do the continuous layers. I just wanted to show you the trick. What we use here is, if you see the tibial component, which we slightly lateralized it.
Yes.
And artery there. So and we removed a little bit of the tibial component here. The tibial osteophyte and a part of the proximal tibia. This was the old fracture which was there. And then the posterior capsule was very adherent, so we had to do a lot of posterior release as well. So that is the critical step, and this was a fixed varus. Would anybody have thought of doing a first extra-articular correction, some kind of an osteotomy for this?
Never for this case.
No.
Yeah, this is usually all intra-articular. And if you see the paper by Wang and Wang, which was written in 2002, if your cut is not going to compromise the collateral incision, I don't think it really matters, and then you should go for all inside. I think that is something critical. Gabriel, any thoughts on how you would have corrected this deformity?
No, I think that the same issue. I think the same. The only issue is that, but maybe I would use a short cemented stem instead of a big stem. The defect is very proximal, and you found almost a very small bone defect on the medial tibia. So maybe I would use the 5 centimeter stem instead of the big one. I don't think it's any difference in that situation.
Okay. Now this is Madam Yantu. This is our anesthetist. She is Dr. Bharti Madam. And this is Hidako. Camera 1, please. So this is the...
Sorry, we cannot hear, Parag.
Combination of the adductor canal block and IPAC, the infiltration between the popliteal artery and the capsule of the knee. In the adductor canal block, it is important to go below the sartorius muscle, which is the trick. And this is done by our anesthetist. And as Shahid also said, the most important thing is that the anesthetist should be involved in the pain management.
This is a adductor canal block.
Can you hear?
Yes, we can hear now.
The local anesthetic is injected around the saphenous artery under ultrasound guidance. And for IPAC, we go between the posterior capsule of the knee and the popliteal artery. So this is also done under the ultrasound guidance, and we use total 60 ml of ropivacaine 0.3%, and we add a little clonidine to this injection.
Okay. Any other questions which I can take, Jose or Gabriel?
What is your experience with the peroneal nerve block on the, if you want to raise the patient and let them walk the day after or the same day?
So the peroneal nerve block, we do not use the peroneal nerve block, and the femoral nerve block is something which we used to use.
Hello. Yes, we don't use any peroneal nerve block. Initially, we used to give femoral nerve block and the sciatic nerve block, but for last maybe 6 years, we have stopped that, and we are now into adductor canal block and the IPAC. And generally, our patients are not mobilized on day 0, but the next day morning, they can definitely be mobilized, because we are not using very high concentrations of local anesthetic. So the motor blockade is not a major problem for us.
Okay, so now we are closing the remaining part of the wound in flexion, as you can see. Initial few stitches are taken in extension, and now is taken in flexion, camera 1. So this is, I just wanted to introduce to you my team. This is
Parag, we have an interesting question here from David Chun from Malaysia.
Sure.
Yeah, his question to you, Parag, is that cling film that you use to cover the foot?
Sorry?
Is that cling film that you use to cover the foot?
Yes. So what we do is, it's a part of the drape which comes, and this is the sterile plastic which is adhesive, and it can completely close it. And what is important is, we should be able to see the ankle. That's because that's an important landmark for me when I do the proximal tibial cut. So therefore, it's completely kept open, and this is transparent. And you can see the second toe as well here. So the second toe, the center of the ankle, and the medial third of the tibial tuberosity, these are the important landmarks for me. So that is why, David, this is a special adhesive, transparent adhesive, which we use.
Probably even the transparent upside drapes should help.
So now the continuous layer is going on. I just wanted to introduce you my team. Camera 3. So Dr. Kailash Patil is here. So he helps me with my knee replacements. My resident Janil, my sister is here. Now, Swati sister. And the anesthetist you met, Dr. Bharati. And she's our anesthetist, head of the anesthesia department. And Praveen, who helps me with the audio visual. And Sunny, can you come in? So Sunny has been coordinating with Alison and Peggy and the entire team. So Sunny, thank you. Camera. Yeah. So this is the team. I think the team has done a good job, and that is why you can see that the surgeries goes quite smooth. So one question to you, Gabriel.
Yes.
So how soon do you discharge your patients? What is your average discharge time for a unilateral or a bilateral?
A unilateral, 75% of my patients are going day after of the surgery, not ambulatory. They go in 24 hours after the surgery. Bilaterals, they depends on the comorbidities of the patients. I do less than 5 to 10 bilaterals per year, and most of the time they're out at the second day of the surgery. Most of the times.
Also,
no more than 3 or 4 days of staying at the hospital.
Shahid, your plan, when do you discharge your patients?
When they are mobilized, full weight bearing, the next day they stand. 90% of my surgeries are bilateral knee replacement, single stage, because most of the patients come late and they have bilateral problem. The most expensive part of our surgery is the cost of implant. The hospital stay is least expensive. So we have no problem in keeping them couple of days. So third, fourth day, they go home. We arrange post-operative physiotherapy. So our physiotherapist will go and mobilize them and teach them exercise every day.
Okay. Because for us also, the discharge time has come down now. However, the number of bilaterals we do are not as many as 80% as yours. We would do probably 20 to 30%. And the bilaterals would take about 3 to 4 days, and the unilaterals would go home in 48 to 72 hours. So, that has been our discharge time. So, what about the robotic?
Okay, we'll need to wrap up, Parag, at this time, because there's going to be a masterclass to follow this particular session. So,
Ali,
would like to congratulate you and your team for a job well done.
And Shahid, this is Mr. Ali. Please help with the audio visual. Please, thank you, Ali.
Thank you, Ali. Thank you.
Yeah.
Thank you, everyone.
Thank you, and extend our appreciation to your patient as well, Parag, for allowing us to be part of her surgery. And congratulations to you and your team.
Oh, thank you.
The newer procedure, the lavage pulsatile device. It's great.
The voice-activated one, right? Yeah.
Thanks, Shahid. Thanks, Gabriel. Thanks.
Good job, Parag.
Bye-bye.
See you.
Thank you.
Guys. Bye-bye.
My name's Piers Yates. I'm from Western Australia, and we'll get right into it. These are my disclosures. There are relevant disclosure there. So what do we want now for knee revision? We want stable fixation of components, alignment of the knee in all planes, including rotation, stability throughout range, ideally restoration of the joint line, because this enables us to have those other things, And this, if you do all of these things, the patellofemoral joint will sort itself out in most cases. But I think one point I really want to make is that most revision knee replacements can be balanced without constraint, and this should be your aim to begin with, unless you have already assessed this knee revision as being an unbalanced knee revision requiring special implants, which you obviously need to have available for you. So how do we achieve this? We establish the tibial platform. It's pretty straightforward, even more straightforward with a rotating platform. We balance in flexion, if possible, and establish the flexion gap, and that involves your femoral sizing and femoral rotation. Balance the extension gap, and then establish the joint line finally to get as close as possible. And then you decide whether you need constraint and use the appropriate constraint implant. So the flexion gap is determined by the femoral component size, the posterior offset, and the femoral rotation. The extension gap is determined by the femoral component distalization, so how far you put your femoral component by using augments from the hip. We've heard a bit about the joint line already. What are the real problems with raising the joint line? You get about patella baja, and there's differing opinions of how much difference this makes. I think you have to get pretty extreme to get flexion limitation from patella baja. You do see it in extreme revisions. But possibly what's becoming more apparent is mid-flexion instability. So if you raise your joint line more than about 4 or 5 millimeters, you balance in flexion, you can balance in extension, but that mid-range becomes unbalanced because the collaterals are no longer rotating around their optimal point. So you get a mid-range instability, which is a little difficult to judge and measure. So we're just going to briefly run through the Attune revision system for a ligament competent knee replacement. So this is the vast majority of knees. So it's pretty straightforward work plan. Ream the canal. I use IM alignment. You're aiming to ream 1 millimeter over your final reamer size, your final stem size. Then you ream the metaphysis. To your diagram here, reaming the metaphysis. And then you lift with this cavity. Do a clean-up cut, so you've got a flat surface, but the tibial surface is not important. We're not at all relying on that for any fixation if we're using sleeves, which I would routinely on every case. Then you broach your tibia for your sleeve. You trial on the broach, and you know when you've got the right sleeve because you can pick up the weight of the limb on the broach without it coming out. With a rotating platform, as I think the world is moving towards rotating platforms in revision, one of the big advantages is tibial sizing, and also you don't have to worry about the tibial rotation, which is a big advantage in revision. It's done. You're finished once you've got your tibial base plate on there. So that's the tibia finished, easy. Slightly more difficult, the femoral side, same process, ream it. 1 millimeter bigger, usually you're 2 or 3 millimeters bigger than the tibial side, metaphyseal ream, then broach again. Now here we come to the balancing. You've got to establish your femoral rotation with balance in flexion. So that's a combination of size. So pick your size on what you've selected before. In most revisions, you've got an implant coming off, and generally you have a good idea whether this is oversized or undersized. It's usually oversized, if anything. And that's your basis of choosing your femoral size. So start with this, then externally rotate in relationship to the epicondylar axis as your primary mark. Lock it off in this position and then trial it. Restore your femoral joint line. You heard a little bit about this before. And then check your extension gap with trials until it's absolutely straight. So there's no excuse for a knee not being fully straight on the table before you leave theatre. That is a no-no in any knee surgery, I think. So then you're just left with fine-tuning, adjust the extension and flexion gaps, and you can do this by moving your femur proximally by going down one on the sleeve, or you can move it distally by going up one on the sleeve, and that will be a 4 millimeter difference each way. So each sleeve you change, you've got a 4 millimeter difference in your extension gap. And then trying to match the joint line. Professor Sujimoto mentioned the patella as a guide. I find that unreliable in revision because they're often scarred and short already. and often difficult to avert as well to have a good look. So I think by far the best guide is the meniscal scar. You can always see it. So there's me pointing it out on this revision here. Our secondary landmarks 1 centimetre north of the fibular head, or I've heard the patella marker as well. So if you balance your knee revision, you can use a primary PS bearing in all your revisions because you balance. The bearing is just providing a bearing that you've already balanced it with. Minimum imbalance, maybe due to a minor stretching of the MCL. Then you've got the option to switch straight to a CRS on the Attune revision system very easily with MCL incompetent. So they're planning for a hinge component. I'm using a landmark of an epicondylar axis because we can't rely on flexion gap balancing. So we're doing an anatomical landmark of epicondylar axis. Look at the joint line for the extension and the posterior condylar offset. You can feel behind the femur to match the posterior condylar offset, and that should be even if your epicondylar axis is in line. Use long stems just to get your alignment in the long bones, but they are just the trials. I don't engage the diaphysis with the components. And then posteriorize the femur to reduce your joint gap, your flexion gap with posterior augments and upsizing your femur. We've already seen the establishing of the joint line landmarks. And then I use a unconstrained trial in this and just see what ligament imbalance is left after I've done all these component positions. And at that point, I'm going to decide whether I really need a hinge. You can see how your patellofemoral joint behaves as well at this point. And then it's just a case of using definitive implants. Always use metaphyseal loading, in my opinion. I think this is the revolution in revision knee surgery, and just use it all the time. Problems. Tibial femoral mismatch used to be a big issue. The tibia is too small for the femur. We've got cone prostheses in some systems. I think the Attune revision system is great because you've got a two-size mismatch, and the rotating platform really facilitates that very well. So it's rare to have an issue with that now with your mild to moderate revisions. And then flexion gap instability is usually due to the femur being too small. Upsize the femur if possible. And if you run out of sizes, then you're going to have to raise the joint line with your tibia to compensate, and then constraint on the end of that. So I hope that sort of gives a brief idea of how to simplify a very complicated subject. And I think a Attune revision system really enables you to do that. That's all from me.
Hello, welcome all to the final section of day one. This section is about hot tips and techniques. My name is Peter Chiu from Hong Kong. My partner is Professor David Chun from Malaysia. We have 4 highlights, each of 5 minutes, covering varus knee, valgus knee, fixed flexion deformity, and iatrogenic injury to the medial collateral ligament. And at the end, we will have 10 minutes discussion time. Please type in your question through the apps so that we can ask the presenters questions. Okay, we shall have the talks now.
Good evening, everybody. I'm Dr. Xie Jie, come from Xiangya Hospital, Central South University. It's my honor to speak here, and I'm very glad to share my topic with you. What I want to share today is how to release for varus deformity. Varus knee is the most common deformity of the knee joint. There are three main reasons. The first is the medial bone defect, and the second is the medial osteophyte. The third is the ligament contracture. The patient may have all three reasons or only one of them. For varus caused by bone defect, the symptoms are very serious, but the low number of the patient can easily return to the neutral position. For each kind of patient, repair the bone defect with augment can solve the problem of the varus. For the varus caused by the medial osteophyte can increase the tension of the medial collateral ligament and lead to varus of the knee joint. So the first release is removing osteophyte by the medial board of the plate and femoral condyle with a ronger or chisel. The procedure permits to reduce the bone strain effect on the medial collateral ligament and then opens the gap. In most of the cases, this is enough to obtain a well-balanced knee. If varus is not created after bone cut, the patient may still have ligament contracture. We will release according to the following step. First, release the anterior medial capsule and then deep layer of MCL. If the balance not be achieved, reduction of osteotomy of the tibial plate. If the gap is still not balanced, release the posterior medial capsule. If unbalanced, additional release are the superficial MCL elevating and PS ascending release. Pie crusting is the most commonly used technique for release the anterior medial capsule and then the deep layer of MCL. After opening the joint gap with a retractor, we can use a large needle or a pointed surgical blade to complete its operation. Pay attention, the depth of the insertion cannot exceed that of 5 millimeter. Don't tie it at the same point so as to avoid the rupture of the medial collateral ligament. For the reduction osteotomy of the tibial plate, we can choose a small tibial tree to be placed on the lateral and then use a ronger or chisel to remove the excess bone on the medial. This can further reduce the tension of the medial collateral ligament. If the gap is still not balanced, we can release the posterior medial capsule. We must elevate the deep part of the MCL using a cobble elevator to posterior medial section of the tibial plate. This can enable us to get a better balance in the extension gap. PS Surgeries is released cutting tendon at 19 degrees, starting from the proximal and then going distal, checking the amount of the release during all the procedure. That's all of my presentation. Thank you.
Good evening, colleagues. I'm Dr. Yang from Beijing Jishutan Hospital. Thanks for having me. My topic is releases for severe varus knees. I will talk about the related anatomy, classification systems and the techniques. Varus deformity occurs in nearly 10 to 15% of the population undergoing total knee arthroplasty. It typically presents tightening of the lateral soft tissues. The soft tissues contributing to the lateral contracture, including posterior lateral capsule, iliotibial band, popliteus tendon, lateral collateral ligament, posterior cruciate ligament, iliopatellar band, gastrocnemius, and biceps. The primary stabilizer in extension are MCL and LCL. Secondary stabilizers mainly include the posterior lateral capsule, ITB, and the PCL. Both the lateral and the medial soft tissues can be affected in various knees. On the lateral side, the soft tissue typically contract, and on the medial side, the soft tissues can become attenuated. When knee flex, the primary stabilizers are still MCL and LCL. Secondary stabilizers shift to capsule on the lateral side, the popliteus tendon, and the PCL. There's one thing I want to emphasize. Lateral flexion gap is usually very flexible, even in most of the varus knees. LCL is quite different from the MCL. It is rope-like, which means there is little room for lengthening. So in my practice, I do not release the LCL. For classifications, there are multiple systems for varus knees. In my practice, I prefer a combination use the SOO classification system and the JST classification system. This is a SOO classification from France. It divides varus knees into 4 types by telling if the deformity is irreducible or irreducible, and if the medial structures are attenuated. This is the JST classification system, which was proposed by Dr. Zhou Yixin. It labels varus knees by different deformity origins, and it allows logical speculation for lateral soft tissue status, especially for the LCL. With a combination of the SOO and the JST classification, we can further pinpoint which soft tissue should be released. As for the techniques, there are several sequences reported in the literature. Crackle suggested releasing the LCL first because it is more efficient than releasing other structures. But I personally don't do this for the reason I mentioned before. Whiteside suggested a patient-specific release approach based on the different structures working in knee extension or flexion. Reynolds reported the inside-out approach, which involves releasing the PLC, the capsule first, and then pie-crusting the ITB if needed. I learned a lot from all these methods. My experience is quite similar to this approach. I always remove all the osteophytes first and release the capsule and the girdle tuberosity during the exposure. And if the extension gap is still tight, I will pie-crust the ITB. In case of the lateral collateral ligament contracture, I will use a sliding osteotomy. If the medial side is attenuated, I will compensate the medial gap by less bone cut, or I will go to constrained processes or do the upsliding osteotomy. Now I will show you some videos. During exposure, I will peel the anterior lateral capsule and the girdle tuberosity. Then I come to release the lateral sulci and retinaculum. Then I take out all the osteophytes, both from the tibial side and the femoral side. When I flex the knee, I will further do the posterior lateral capsule release. The ITB is usually evaluated in knee extension. If it is tight, I will do the pie-crusting, use a stake or a needle. If the LCL is contracted, I will do the lateral sliding osteotomy to avoid extensive release or constrained processes. After release, I will check the balance. In extension, I usually use the varus stress test, and in flex, I will use the polar test. I always check the patella tracking after I have put several sutures to the medial side. I will press the patella to tell if it is tilting. If yes, I'd like to release the iliopatellar band. In some severe cases, with a fixed patella dislocation or modified Judith procedure is needed to realign the whole extensor. So in summary, as for releases, we need to know the common pathology and anatomy, and well personalize every varicose knee and choose personalized techniques or sequence. Thank you all. Thank you for kind attention.
Good evening, friends. Thanks, Rami and Niku, for the invite to this exciting virtual meeting of APAS 2021. I'll be speaking on correction of fixed flexion deformity, the knee replacement. The posterior structures are very important in a fixed flexion deformity because they are spreading like a white contracted curtain. So the release of this whole of the white curtain in a severe deformity is very important. The steps are the release should be sequential of these posterior structures, and if the deformity is not corrected, only then the shortening of the femur should be done because it may cause the midflexion instability, which may need the constrained implant, and also the MCL or LCL tightening. The sequential release is like this, what you see here. If it is not corrected, more release under the sponge or a gauge piece. The posteromedial aspect of the tibia should have the sufficient release, and MCL should be released in the form of a sleeve. If the extension gap is still very limited, that's what you see here. Go for the more release and then more distal femoral cut. And then after a sufficient release, you should be able to achieve a good extension gap. That's what we see in this video with the patient who's having the fixed flexion deformity of both the knees. Important aspect is the release on the posteromedial aspect and the release on the posterior aspect. There are lots of osteophytes in these patients. Usually these knees are the stiff knees having the limitation of range of motion. A lot of osteophytes, and all osteophytes should be removed using a lot of patience. The tibial cut and the tibial cut, in any surgery, you should be careful that the blade should not cross beyond the posterior part of the bone, because the posterior structures are very important. Once you remove the tibial cut, once you do the tibial cut, you have more space to work on the posterior part of the knee. And that is why you should keep working on it with using the sponge. You see that in this patient, the middle structures are still tight. The sufficient gap is still not there. You will remove more of the osteophytes. You will remove more of the soft tissues, release more MCL, and MCL should not be damaged. It should always be released as a sleeve. And if you're cutting structures, whether the blade or a scissors, if it is close to the bone, normally you are safe. And it is very important to retract the tissues carefully. You can reduce the size of the tibia because these are the osteophytes which are basically tenting the medial collateral ligament. And when you see that there is the enough extension gap has not been achieved, you should go for the additional distal femoral cut. And additional distal femoral cut should not be done more than 4 millimeter or maximum 5 millimeter, because it can give rise to the midflexion instability. It can also give rise to the damage to the MCL. And now you see that the sufficient extension gap has been achieved. One must see it carefully with the help of the spacers. If it is still tight, that's what we find it here, we'll go for the more release. And you see that the osteophytes are tenting the capsule posteriorly. So the osteophytes removal is very important. I use the pituitary rhonger for this, which is a very useful tool. I use this COPS elevator, which helps a lot. And sometimes in a severe fixed flexion deformity, you might even release up to the linea aspera. And that's what you see now, that this patient is having the good extension gap. And then after, you see that the flexion gap. The flexion gap normally is more in these patients. That's what is demonstrated here. Using the size 3 and marking the posterior condyle. Now in the size 4, you see that you are removing less of the posterior condyle if you use the size 4. And thereby, you will be balancing the flexion gap easily. That's what you see here. And then after the final implant, you see that the stability both in flexion and extension, and a good correction of the flexion deformity of the patient. The shortening of the femur has its limit. It should not be overcut, as we have just explained. So this patient who is having the post-traumatic osteoarthritis with fixed flexion deformity, good function at 9 years using the same principle as we have just discussed. The periarticular muscle spasm contributes significantly, so the assessment should be done after anesthesia. Careful release of the contracted posterior soft tissue structures should be done. Care for the peroneal nerve is important. If mid-flexion instability, constraint implant should be ready, and you may need to release the MCL or the LCL tightening or advancement. Plaster cast or some kind of a posterior support is important in all these patients. Thank you so much.
Medial collateral ligament injury during total knee replacements. The MCL has 3 components: the superficial, the deep, and the posterior oblique. It is an important structure for coronal stability and soft tissue balancing during total knee arthroplasties. If the MCL is injured and not managed properly, it can lead to valgus instability, unhappy patients, accelerated wear, loosening, and higher revision rates. Various treatment options have been reported. These include polyethylene upsizing, repair of the ligament, repair with augmentation, reconstruction, or using higher constraint components. Direct repairs is best performed using non-absorbable sutures, such as 5 ethibonds. The sutures are placed into the torn ends of the MCL using modified Kessler or Krakow stitches. The repair is tensioned but not tied. The sutures are clipped while troweling the components. Once the components are implanted, then the sutures are tied with the knee in slight flexion and varus. A range of motion knee brace is applied for approximately 6 weeks. This protects the repair, but the patient is allowed full range of motion. If during repairs there's any significant MCL tissue loss, if there's a gap, if the MCL is of poor soft tissue quality, or if there's any potential stretching post-operatively, then augmentation with the autogenous semitendinosus tendon, a free quadriceps graft, or even synthetic materials can be used to augment. Currently, my preferred method is to augment with a fiber tape from Arthrex. Avulsion injuries can be repaired using anchors, screws, and washers for the femoral side and staples for the tibia. If for any reason repairs and augmentation cannot be achieved, then reconstruction is performed. I use the weave technique described by Joshi, as this is more anatomical. The semitendinosus tendon is harvested but still left attached distally to the proximal tibia. 2 vertical incisions is made in the most distal part of the medial collateral ligament. These incisions are approximately 1 centimeter apart. The semitendinosus tendon is weaved through this opening and sutured to the MCL at this point. An isometric point is identified at the medial femoral condyle epicondyle using a K-wire. a tunnel is reamed and the semitendinosus tendon is fixed in this tunnel using a screw. The free limb of the tendon is then fixed to the postural medial part of the proximal tibia using an anchor or through a tunnel with screw to reconstruct the posterior oblique ligament. Constraint implants have been described as an option. They provide immediate stability. No bracing is required. They can be used in older patients whose MCL is of poor quality to repair. Please note that posterior stabilizing components do not provide enough constraint and coronal stability in patients with MCL injuries. Components with higher constraint, such as the DePuy TC3, is advised. Constraint implants do have their problems. They transfer stresses to the interfaces between the prosthesis, cement, and bone. These cause wear, loosening, and high revision rates. Not all hospitals will have these high constraint implants on their shelves. They are more expensive. They require removal of additional bone. They need the use of stems, and they should be avoided in younger patients. So in summary, MCL injuries during total knee arthroplasties is best managed with direct repair without or with augmentation. High constraint components are only reserved for older patients who have low functional demands and who have lower or poorer soft tissue quality. Thank you.
All right, David.
Thank you very much, Peter.
Welcome.
Well, thank you. That's very interesting talk, gentlemen. Dr. Jie, sorry, I beg your pardon. Actually, many of us see a lot of horrible problems with various knees. And of course, we would do more or less what you would do. And it's pretty standard for us. Only thing is, what do you think of the role of just doing a meniscectomy first? I find that once I've done a meniscectomy before I do anything else, the balancing is so much easier to do. And the second thing is to do a superficial release first, rather than anything else. And then you can calculate your bone cuts. What do you think? See that?
Is Dr. Shea around?
Maybe he's not. Never mind. Okay, well, in this case, yes, Rajiv?
Yeah. When you are releasing the meniscus, the MCL is very close. So there is quite a possibility that with the meniscus, some part of the deep MCL is also released. So that probably is the reason what you are mentioning. And probably
it's a meniscofibrosis, basically. You're right.
Right.
So the combination of osteophytectomy with a medial meniscal release makes a huge difference to what it is, and that's usually what I do first.
Right.
So, Dr. Dejin Yang, I noticed you used a lateral parapatellar approach for your valgus knees. It is actually standard for me. So, how do you orientate the tibial insert? One of the problems I find with this lateral approach is that we often get lost when trying to locate a proper position for the tibial inserts, for the tibial tray. How do you get over that?
So your question is how to align the tibial component through a lateral approach. So I didn't do any lateral patellar approach. I use usually I use a medial approach for every knees, even for valgus knees. I didn't get used to do this for any knees.
Okay,
So,
well, my preference is for valgus for lateral approaches because you have an automatic lateral release. It's automatic. You don't have to do it. Anyway, Rajiv, how do you perform a posterior capsular release? How do you release the capsule? I saw you using the diathermy to go to the back of the knee. Is that what's standard? What do you actually cut with the diathermy?
See, what I do is initially I'll do the blunt dissection on the posterior aspect of the femur, starting from the intercondylar notch and going both to the medial and lateral condyle. And then shortening the size of the tibia and removing all the osteophytes. At the end of the surgery, you still find that the extension gap is still tight, especially medially, I extend the knee and put the cautery on the posterior part of the capsule and do the posterior capsulotomy with the cautery under the vision. And I take care that I don't cross beyond the central part of the tibia, because beyond that you have the artery. So it is pretty safe, actually, if you do it carefully and you stretch the capsule by someone pulling the leg in extension. And that's a very useful method.
Often I find that there's osteophyte directly in front of the PCL. If you retain the PCL, I guess you sacrifice it, so it's not a problem.
Yeah.
But it's just a little tip. If you retain the PCL, then actually there's that osteophyte. If you take that off, and actually it helps the balancing a lot. And finally, Dr. Jiang Dao, I loved your approach for doing all that repairs of the MCL. But if you're going to use sutures, do you have any preference of any kind of suture? I mean, there are all kinds of sutures that are available. What's your preference for currently?
So in the past, I've used the 5 bond, but more lately, I've used the 2 fiber wire. I find they're of equal strength, and it's a smaller suture to use.
Do you use?
I have a question to Dr. Dao.
Yes.
If you iatrogenically injured your MCL, what is your preferred management out of the methods that you mentioned? If you put in a CR knee versus if you put in a PS knee, is it any difference in the approach?
I still would use my CR knee. I won't need to convert. I'll just repair directly. If I feel that my repair is strong enough, that's all I will. I'll leave it at that and just put the patients in a brace. I think that's enough. Because
with a PS knee, you also cut away the PCL so that the constraint
the PCL
property of PCL is gone.
Yeah, the PCL has a role in the medial stabilizing of the knee as well. So if you convert it to the PS knee, then there's issue of increased laxity on the medial side, and putting at a PS total knee does not provide you that any extra coronal stability. So
you're the man. That's the idea.
Yeah,
absolutely.
Definitely leave it.
That is the reason Professor David Chun tried to convince me to do CR knees at the time when I did mainly PS knees.
Dr. Rajiv, when you extend a very flexed knee, have you had any issues with the neurovascular bundle or any neuropraxia post-op? And how's your approach?
It's very, very important thing what you just mentioned, that if you keep these knees in full extension, there is a possibility of problem of the neuropraxia. But if you keep them in the post-operative period and about 30-degree flexion for a day or two, now that is the trick. But you're right that if you keep them in extension, you can have some neuropraxia. And even when you are releasing so much, say you are releasing the grade 3 deformities, especially the deformities where you have the flexion deformity more than 90 degrees. We have many patients of more than 90-degree flexion deformity. And these are the patients where you have...
We have to go now. I've been told to sign off. So it's good night from me and good night from him. Good night.
Thank you so much.
Everybody.
Right.
Good night. Thank you.
Bye-bye.
Bye, David.
Bye.
Recording stopped.